One and all, I'm Dr. Vishwanath from Department of Pulmonology. On behalf of my colleagues, Dr. Gautam, Dr. Vinay, Dr. Nishant, Dr. Raghav, and Dr. Chandan, we welcome you all to this exclusive one-day event on best practices in management of sleep apnea. So we know that the incidence of sleep disorders is increasing, but however, structured training and curriculum is lacking in most MBBS curriculums and also in the PG curriculums actually. And most of the places actually dedicated sleep labs are also not there. So this one-day event, we have curated the content so that you get the updates about the best practices in the sleep apnea, all about CPAP, when to start, troubleshooting, surgical aspect, mandibular advancement devices, and myofunctional therapy exercises which are there for the airway actually, which are even not known for many people actually. So all these aspects we have tried to cover in this one-day event. And in the afternoon we have a workshop where we'll be demonstrating the different devices, and also delegates will have an opportunity to set the settings themselves hands-on actually. And just to keep you engaged during the sessions actually, we have given a pre-test handout of quiz questions in the printed format actually. So all the questions which have been given to you in this paper actually, printed paper, will be discussed respectively at the end of each talk actually. So, and you can also ask questions if you have any after the session is over actually. So I would request everyone to attentively listen to all the talks, try to get the answer during the talk for the question which is given in the handout, and it's in a way actually it's going to be very, very useful for building up your knowledge and also improves your focus actually. Thank you one and all, and I'll hand over the session to Dr. Chandan, my colleague, to start the first talk. We are starting at 9:30. We thought of starting at 9:30 and we are starting at 9:30. Thank you, Chandan. Over to you. Thank you.
Good morning. So as Dr. Vishwanath sir told, so we are about to start our session. For this, I would request Dr. Vijay Mohan sir to please come on the dais and help in moderating the session.
Dr. Vijay Mohan is a very senior internal medicine physician, professor and HOD at OIC Medical College, and he also heads the academics at CARE Banjara Hills branch. Thank you very much, sir, for coming us and helping us with this. Thank you.
So this, in the next 60 odd minutes, the first session we will deal with various aspects of sleep apnea. To begin this session, I would like to invite Dr. Gautam. Dr. Gautam is a consultant here at AIG. So he will let us know regarding the brief introduction on sleep apnea and its clinical overview. Over to you, Dr. Gautam.
Thank you, Dr. Chandan. Good morning, everyone, and a warm welcome to all the faculty and delegates. Today, I will be speaking on the introduction, the overview of obstructive sleep apnea. My talk will cover the basics of sleep and its functions, respiratory physiology during sleep, and I will be giving the overview of obstructive sleep apnea under the following headings. So sleep is a period of bodily rest. It is characterized by reduced awareness of the surrounding environment. We spend 1/3 of the life in sleep. We all know that sleep is classified into, it has got various stages like NREM, which constitutes about 80% of the total sleep time, and REM sleep, which constitutes about 20% of the total sleep time. NREM is again divided into N1, N2, and N3, and both these NREM and REM alternate cyclically throughout the sleep cycle. NREM sleep is characterized by decrease in sympathetic activity, which is evident in decrease in heart rate and blood pressure during the night time. And the cerebral blood flow is decreased, the breathing pattern is regular, and there is decrease in muscle tone and minute ventilation. Whereas REM sleep is paradoxically characterized by increase in sympathetic activity. The heart rate and blood pressure are similar to the awake state, and there is increase in cerebral blood flow. The breathing pattern is irregular, and the breathing pattern is mainly dependent on the diaphragm. and the muscle tone is completely absent in the REM sleep. So sleep aids in energy conservation, particularly in the brain. All the neurologic toxic waste is removed during sleep. It aids in memory consolidation and it improves cognition and immune function. Sleep deprivation is associated with various neuropsychiatric and cardiovascular complications like stroke, etc. So when the person is awake, his respiration is controlled by the central nervous system, the respiratory center, which is present in pons and medulla, which integrates with various inputs from the peripheral chemoreceptors. But at the onset of sleep, this wakefulness stimulus is lost, and the breathing is mainly dependent on the peripheral chemoreceptors, that is aortic and carotid bodies, and they are mainly respond to carbon dioxide stimulus. And something interesting goes on in the physiology when a person transitions from wakefulness to sleep. At the onset of sleep and during stable sleep, the wakefulness drive is decreased, the muscle tone gets reduced so as the minute ventilation, and the chemosensitivity is decreased. The CO2 becomes the prime stimulant for breathing, and the partial pressure of CO2 is 3 to 8 mm Hg, higher than the wakefulness state. During the brief arousals, which can happen even in normal individuals, the muscle tone becomes normal because of sympathetic activity. The wakefulness drives gets back, and because of these factors, there will be rapid correction of blood gases. And when again the person goes back to sleep, the muscle tone gets reduced, and these factors, there will be decrease in wakefulness drive. And because of these factors, there will be some breathing destabilization even in normal individuals. This breathing destabilization is mainly dependent on the arousal threshold and the ventilatory response to arousal. If the arousal threshold is low, the breathing destabilization will be high, and the person is prone to sleep disordered breathing. And when the ventilatory response to arousal is high, that is, it is called as high loop gain, there will be high breathing destabilization, and the person will be prone to sleep disordered breathing. Coming to the obstructive sleep apnea, it is a common disorder characterized by repetitive closure of the upper airway, particularly in the retropalatal and retropharyngeal regions, retroglossal regions, where there is lack of cartilaginous support. Few definitions. Apnea is called cessation. Apnea is defined as cessation of airflow for at least 10 seconds. Hypopnea, the reduction in airflow with 3% or more decrease in SpO2 with or without, associated with EEG arousal. Respiratory event related arousal, RERA, it is an event characterized by increased respiratory effort and for lasting for 10 seconds or more, but it is not fitting either to apnea or hypopnea. The sleep apnea, obstructive sleep apnea is, the severity is defined by various indices like apnea hypopnea index, which is defined as number of apneas or hypopneas per hour of sleep. Respiratory disturbance index, RDI, which is AHI, which includes AHI plus RERA. And in cases of level 3 polysomnography, they measure respiratory event index, which includes total recording time instead of total sleep time. Coming to the burden of the sleep apnea, it is estimated that around 936 million population around the world are suffering from mild to severe obstructive sleep apnea. Out of this, 425 millions are suffering from moderate to severe sleep apnea, and China is, these are the high burden countries, and India is one of them. So coming to the pathophysiology, OSA occurs because of the lack of delicate balance between the collapsing forces and the dilating forces of the upper airway. The upper airway can be considered as a hollow tube without any cartilaginous support, So the collapsing forces include negative inspiratory transmural pressure gradient and the pressure applied from the upper airway surrounding upper airway tissue, whereas the dilating forces include the upper airway dilator muscles. P crit is the critical pressure at which the dilating forces cannot overcome the collapsing forces. So when there is imbalance between these two forces, for example, in this pictorial diagram, the first, the above this thing is the normal this thing, where the collapsing forces and the dilating forces are balanced and there is normal airflow during inspiration. But in the second and third case, during inspiration, because of generation of the negative airway pressure inside the airway, because of various factors, the airway might get collapsed. If the collapse is partial, it leads to snoring and hypopnea. If the collapse is permanent, complete, it leads to apnea. So apart from, there are certain risk factors which can lead to this collapse. Apart from the upper airway anatomy, the upper airway dilator muscle responsiveness, low arousal threshold, and high loop gain, that is the instability of the ventilatory control, also play a role. This instability, this high loop gain is particularly important in heart failure and other patients which are prone to central apneas, and around 20 to 30% of the normal obstructive sleep apnea patients also have this high loop gain. So these are the risk factors. The obesity, neck size more than 17 inches in males and 16 inches in females. Males are more prone to OSA than females because of these anatomical factors and progesterone. Some genetic factors also play a role. Particularly this upper airway and craniofacial anatomy, macroglossia like lateral peritonsillar narrowing, tonsillar hypertrophy, adenoid hypertrophy, nasal septal deviation, mandibular abnormalities like retrograthia, micrograthia, they can predispose to upper airway collapse. Not only this, some genetic disorders like Down syndrome and endocrine disorders like hypothyroidism, polycystic ovarian disease, and acromegaly can also predispose to upper airway disease. Pathophysiology. So because of this apnea and hypopnea, there will be sleep fragmentation, the sleep is disturbed, and because of hypoxia, there will be repeated sympathetic surges during the night time, which can cause the loss of nocturnal dipping of the blood pressure and the heart rate, which can adversely affect the cardiovascular outcomes. And there will be a lot of oxidative stress and inflammation, which can lead to endothelial dysfunction and endocrine dysregulation. And because of large fluctuations in negative intrathoracic pressure, there will be adverse effects on the cardiovascular system, which can increase the right ventricular overload and increase the pulmonary arterial pressures. These cardiovascular side effects will be dealt in detail by the subsequent speakers. Coming to the clinical presentation, OSA is a very heterogeneous disease. Not all patients present with similar symptoms. There are certain symptom clusters. Many of the patients present with disturbed sleep with minimal symptoms, or many of the patients will be asymptomatic as well. There will be a phenotype called sleepy phenotype, where the patient has excessive daytime sleepiness, and some patients present with insomnia with obstructive sleep apnea. And there are certain polysomnographic based phenotypes like REM predominant OSA, supine OSA, hypoxic predominant OSA, etc. These are very important. This categorization is very important because some of these phenotypes are associated with adverse cardiovascular effects, side effects. Nocturnal symptoms include snoring, choking, witnessed apneas. Some patients present with nocturia because of increased intra-abdominal pressure and ANP secretion, atrial natriuretic peptide secretion. And in some patients, nocturnal GERD can happen. This results from large decrease in intrathoracic pressure and increase in intra-abdominal pressure during obstructive apneas. So patients presenting with nocturnal GERD symptoms, we have to think of obstructive sleep apnea as well. Coming to the daytime symptoms, excessive daytime sleepiness, deficits in cognition, vigilance, There will be mood disorders like depression, anxiety, irritability, and most of the patients present with fatigue. This is a scale which quantifies the level of sleepiness. It is a self-administered questionnaire with 8 questions. The respondents are asked to rate on a 4-point scale their usual chances of dozing off during certain situations. Clinical evaluation, we have to take proper history, his total sleep time, sleep onset latency, nocturnal symptoms and all, and asking the bed partner about the symptoms is very important because most of the patients doesn't know that they are having severe snoring and choking episodes during night time. We have to ask about the coexisting sleep disorders like bruxism, limb movement disorders, etc. And we have to take the history of all the comorbidities that the patient is having, including the drug history. Certain populations are at high risk of having severe OSA. This is obesity, patients with hypertension, diabetes, myocardial infarction, etc. PCOD, atrial fibrillation, and pulmonary hypertension patients. Various screening questionnaires are available. The most commonly used is a stop bank questionnaire, and this is a recent questionnaire, NOSAS questionnaire, which has the following neck circumference more than 40, and body mass index, snoring, age, and sex. Coming to the diagnosis of obstructive sleep apnea, the gold standard being the polysomnography, which has level 1, level 2, and level 3. Level 1 is the gold standard thing, and level 2 is also equally acceptable. These are the standard polysomnographic channels. EEG, EOG, and EMG are used to stage the sleep, and ECG to monitor for any arrhythmias, tachycardia, arrhythmias, etc. Airflow is assessed with the help of oronasal thermal airflow sensor. Respiratory effort is assessed with the help of abdominal and thoracic belts. This is useful in classifying obstructive and central sleep apneas. There is a body position center and video monitoring to look for any abnormal movements or parasomnias. These are the additional PSG channels which are occasionally used. And coming to slow home sleep apnea testing, it does not include EEG, EOG, and EMG sensor, so it is difficult to stage the sleep whether the person is awake or if he is asleep. And because the conventional sensors of home sleep apnea testing can miss the hypopneas, so it can underestimate the severity of obstructive sleep apnea. So whenever the test is inconclusive, whenever the home sleep apnea test is inconclusive, we have to go for a standard polysomnographic testing. Disease severity is classified with the help of AHI, but recently AHI is not that correlating with the cardiovascular outcomes, so they are coming up with new entities called hypoxemic burden, T90, etc. Consequences, apnea, hypopnea. Because of this, there are variable consequences over the body, like cardiovascular diseases. It can lead to diabetes and insulin resistance and various neurocognitive effects. Principles of management, I'm not going to delve deeply into this because the subsequent speakers are dealing with this. Mainly, the OSA is treated with positive airway pressure devices, and in certain cases, mandibular advancement oral therapy and surgical therapies, and adjunctive therapies like positional therapy, compression stockings, myofunctional therapy are also useful. So take home message, OSA is multifactorial. Understanding various endophenotypes is very useful for personalized treatment. Polysomnography is a gold standard test for diagnosing sleep apnea. Identifying and treating high-risk populations improve overall disease outcomes. Thank you.
Thank you, Dr. Gautam. That was a great introduction to sleep apnea. So in interest of time, the questions will be taken at the end of the session. So thanks for the talk.
Thank you, Dr. Bachu. You have nicely explained the physiology of breathing and pathophysiology of OSA. OSA has become a new burning problem worldwide, and this word OSA we are listening only for the last 60, 70 years, before which I am sure you agree with me, before which we never knew what is OSA, because obesity was not there. India was having malnutrition and undernutrition problem before the independence. And even this word, we used to say Pickwickian syndrome and all those stuff. Anyway, thank you very much without wasting much time. You have explained nicely the clinical implications and treatment part. Thank you very much. And obesity also is increasing now, and India is the fattest country in the world, so which is why Indians are more prone for OSA and related problems. Thank you. Now we move on to the second topic. I request Dr. Pranav Aish. Am I spelling right? Dr. Pranav, I think he is joining online. Dr. Pranav, are you there? Hello? So he is an assistant professor in VMMC, Safdarganj Hospital, New Delhi. The areas of interest are sleep medicine, SRMN,
Faculty of Pulmonary Medicine at Safdarganj Hospital, New Delhi. So today I'll be speaking upon decoding sleep study records. So basically we'll just try to see what all things we have to evaluate and probably interpret in the reports of sleep study that patients get to us. I thank AIG Hospitals, Hyderabad and the entire Department of Pulmonary Medicine for giving me this opportunity. We will basically focus on what all parameters we get in the report of sleep studies. Now, they are important because, see, even if we do not have a polysomnography or a sleep medicine department in our hospitals, we can always advise patients sleep studies, which they can get done at other hospitals, other centers, and nowadays even at home. So we have the concept of HSAT, that is the home sleep apnea test. So we must be able to interpret all those parameters and accordingly give treatment. So, first of all, there are 4 levels of sleep study. So, level 1 is something which we do in our hospital, like I work in a tertiary care hospital, where we have a level 1 polysomnography, which has at least 7 leads, which include the EEG, EOG, EMG. So, that is the electroencephalogram, oculogram, and myogram, which helps you to get the stages of sleep. This is important because if you get a printout report of a sleep study, which is level 1, you will get wake, N1, N2, N3 REM, which are the various stages of sleep, and hence you can probably get an idea of the quality of sleep also. Besides that, there is airflow as well as respiratory effort. Now, these two are important to mark apneas and hypopneas. We'll discuss them later. So, no flow would be apnea and a reduced flow would be hypopnea. The respiratory effort will tell us whether it is obstructive or central. And the 7th being saturation. So, these are the 7 minimum leads that we connect in a level 1 polysomnography. We can of course connect more leads. For example, if we are suspecting hypoventilation, we can have transcutaneous or end-tidal CO2. If we are going to diagnose probably periodic limb movement disorders, we can go for leg EMGs and various other. Same thing if you do without a technician, it is known as level 2. So level 1, level 2 are the in-hospital sleep studies that are often done in patients who have comorbidities, or probably for research purposes, or when we want to actually see the quality of sleep, diagnose appropriate respiratory sleep disorders and treat them. Level 3 polysomnography is something which is often done at home, where the EEG, EOG and EMG are not there. So here you do not have the stages of sleep. You will not have the wake, N1, N2, N3 REM. What you will basically have is the flow. So apnea, hypopnea, as you will find out, and the effort, obstructive and central, and the saturation, and often the 4th being either ECG or body position. So here you are not focusing on the neurological part, you're not focusing on the sleep study in the form of the various epochs or the quality of sleep, but just focusing probably on the sleep apnea disorders like obstructive and central sleep apnea. Level 4 polysomnography we as such do not do. It is just like probably doing a saturation monitoring to look for oxygen desaturation. Why these levels are important? Because the report appropriately will give you all those parameters. So let us say we do a level 1 polysomnography where we connect all these EEG, EOG and EMG leads. We will mark our sleep study as N1, as N2, N2 having the K complexes, N3 having slow waves, and REM, which have the rapid eye movement. So this will be marked in each and every 30-second window. It takes hours to do that, and we can get an idea about the quality of sleep. After that, we will mark the respiratory events. So the respiratory events would be, if there is no flow, it will be an apnea. For 10 seconds, the cutoff. And the thorax and abdomen show persistent efforts. So persistent efforts and no flow means an obstructive apnea. This will basically depend on the flow, which will be through the nose, and the belts on the thorax and abdomen, which will show you the patient's efforts. If there is no flow with no effort, that is parallel lines, all flat, it would be a central apnea. So obstructive apnea, central apnea, we even have mixed apneas, and we have something known as hypopnea. So hypopnea would be when the flow is not flat, but it is reduced. So when there is a 30% reduction in the amplitude of flow associated with an arousal or 4% desaturation, we call it hypopnea. And here in this hypopnea, the effort is preserved. So this is an obstructive hypopnea. Why are these apneas and hypopneas important? Because the most important parameter till date in reporting a polysomnography is the apnea hypopnea index. This is the criteria which we used to diagnose OSA. Apnea hypopnea index is the number of apneas and number of hypopneas per hour. If it is more than 5, we call it OSA. In a patient who's not having symptoms and it is just for screening, probably we need an AHI of 15. But most of our patients who come to us are symptomatic in terms of excessive daytime sleepiness, in terms of falling asleep anywhere, having loud snoring which is persistent, having fatigue, early morning headache. So these patients having an AHI more than 5, we can make a diagnosis of obstructive sleep apnea. Second, the gradation is also defined by the AHI. If it's 5 to 15, it's mild OSA, 16 to 30 moderate, and more than 30 is severe OSA. If we mark apneas, hypopneas, and RERAs also, RERAs being the respiratory event related arousals, where the events were there was desaturation, but it did not fulfill the criteria of hypopneas, then the index is ideally called as RDI, that is respiratory distress index. But most of the times we do not mark RERAs, so we do not get RDI. What we get is the AHI, and the AHI of 5 is the cutoff for OSA. So this is a sample sleep report. This was a patient who underwent a sleep study in our department. In the diagnostic portion, we see for the AHI, the AHI here is measured or marked as index per hour. It is 15.4. So having an AHI of 15.4 automatically means this patient has moderate OSA. Moderate to severe OSA are often and almost treated with CPAP, that is continuous positive airway pressure therapy, that is PAP therapy. This patient was prescribed a nasal mask with a CPAP of 11 centimeters pressure. But if you see in detail, this report does not only contain AHI. There are so many other parameters. So first of all, it's the light off, the light on, the total recording, the total sleep time. So the total recording time and total sleep time give you an idea of the sleep efficiency. Your ideally total recording time should be higher. Time in bed, again, slightly the same. But the total sleep time should also contribute to around 80 to 90% of the total time in bed. Besides, you get an idea about VASO, that is wake after sleep onset, again showing you an idea about the sleep quality. And you get these values, the N1, N2, N3, and REM. REM is the red part here. Supposing this was a split night study as shown here, where CPAP titration was done, we needed a 15-minute supine REM along with an AHI less than 5 to call it an optimal titration. So it is not an AHI criteria alone where we need an AHI more than 5 to diagnose OSA and an AHI less than 5 to probably correct it with CPAP. We need the quality of sleep also to define the optimal titration. And hence, we must always have a look at this total sleep time, at the percentage of REM, at the AHI along with its contribution, whether it was central, whether it was obstructive, whether it was the apneas which were majorly contributing or the hypopneas. Going ahead, we have other information also, whether Cheyne-Stokes breathing was there or not, whether the AHI was only in supine position, that is, it is a positional OSA, whether there were a lot of arousals just to look for the quality of sleep. We also get an idea about the saturation. We have a saturation probe which is highly sensitive, which is used in polysomnography. So if you see here, the patient maybe started with a saturation of 96, but minimum saturation was 52. So having a moderate OSA, you would say, okay, AHI is 15.4, but having a saturation going as low as 52 is a risk factor for arrhythmias, including atrial fibrillation, including ventricular fibrillation, including cardiorespiratory events, including cerebrovascular events because of the sympathetic surge. Besides, we also get idea about the time spent in hypoxemia. So we have something like the time spent below 90 degree, 95 degree, 85 degree, and the minutes the patient spends in this. So all these gives an idea about the hypoxic burden that the patient is going through in the sleep study. Finally, we have the therapeutic portion, that is when the titration was done. So in the titration part, again, all the same parameters are again measured. So if you see here, the index, that is the AHI, has now reduced to 0.9. Wonderful. So right from a moderate OSA, we have probably got it down to not even 1 event per hour. The saturations are all normal. The snoring is reduced to normal. The arousals are reduced. Chain stroke breathing otherwise also was not present. And just to summarize all of this, we get something known as a hypnogram. So I request all of you to probably see some sleep reports and try to evaluate the hypnogram. Hypnogram just in one image will give you a lot of information. So first thing will be you'll get the wake, REM, N1, N2, N3. So you'll get the parameters. If you see here in the diagnostic portion, there was not much REM. Finally, with the CPAP, there was REM. It may also be possible that REM actually physiologically also covers in the later part of the sleep, but in OSA patients being a protective reflex, they do not go into REM sleep. Second, you see saturation, you can see desaturations here which are stabilized. You see all the events, the apneas and hypopneas marked. You see the pressures also. So in just one bird's eye view, you can see desaturation, lots of events, titrated by CPAP, events corrected, saturation corrected, patient has now a good REM, and you can treat these patients optimally with a PAP therapy. Just again, a bigger image of this hypnogram. So see the saturation in the diagnostic part, see how much the fluctuation is there, how much it is like, just like probably the sawtooth pattern going down, coming up, maybe going up to 60s or 70s. Lots of apneas, lots of hypopneas. In the second half, CPAP was given, pressure of 10 centimeters, gradually increased from 4, 5, 6, 7, 8 to 10. Patient now has a good supine REM. Saturation is corrected, respiratory events are corrected. The patient is doing very well. He himself will thank you that probably after many, many days, he has slept so well. Once these patients are prescribed PAP therapies, there is, of course, nowadays, most of the devices have Bluetooth data, which the patient can see on phone. But traditionally, we also have machines which have data cards, which can give you a printout on the usage and the compliance of the patient. I sincerely advise you, see the sleep reports of the patient, see beyond AHI, see the saturation, see the sleep quality, see the titration part. But once started on CPAP, do not ignore your patient. It is actually more important now to cater to all his problems regarding the mask, regarding the machine, and some idea about the usage you can easily get with this compliance report. So here, if you see the patient actually show you day-wise how many hours the patient has used the machine. It gives you a day-wise split. So if there are lots of splits here, probably the patient is removing the machine intermittently. If the hours are only 3 hours, 4 hours, that means the patient is not compliant. You can also get an idea about the pressures that are set, the residual AHI. Now the patient started with OSA, you started CPAP for that. Now the average AHI on this CPAP, let's say of 12 centimeters pressure, is just 1.5. So that means you have an optimal titration and the patient is doing very well. One more important thing to see here is the leak. So you are putting a nasal mask or an oronasal mask which can have a leak from the side. Some leak is acceptable, that is to wash out the CO2, so that will be there in the normal mask fitting also. So if you see here, around 20 to 30 liters of leak is there, which is normal. And as such, there are no large leaks. That means the patient is optimally putting the device on his face. You can get the values also. The average usage being 10 hours here, the residual HI being 1.5. This patient is doing very well and should be continued on the same therapy. Okay. Besides that, if you just get an idea and look at the hypnogram, or probably go through the sleep report inside also, here what I show you is you have lots of desaturations, but all the events are central. The blue is central apnea. So this is a patient of central sleep apnea, not obstructive sleep apnea. Variety of causes can be there, drugs, it could be CNS causes, but this was a case where there was a heart failure with reduced ejection fraction. And when we tried to titrate this patient with CPAP, just look at the first half, you see the saturation going down, so many central events. Look at the second half. On CPAP, the patient's pulmonary edema cleared, probably the patient's circulation delay in the baroreceptor sensitivity improved, and the central events did settle. So we have proof here that there was central sleep apnea, probably due to an underlying heart failure with reduced ejection fraction, with the patient going into pulmonary edema, every of this feature being corrected with CPAP. So these patients should be given PAP therapy also. Okay, just few practice cases because I have a minute. So this was a patient who came to me with an AHI less than 5, but I was suspecting that this patient has OSA. So when I actually went into the detail, I saw, see here, 54% is wake. So most of the time the patient actually could not sleep. And it is possible. We apply so many leads. It's a new environment in hospital. The patient may not have slept well. So the AHI here in the diagnostic portion, the index here was only 4.4. We were, as per this
sleep report making a diagnosis of no OSA, but when I asked them to repeat it in a better surroundings where this wake up was only 3% and now the patient had a good REM also, the AHI actually increased to 24 and the patient was diagnosed as moderate OSA. Similarly, another case, very good REM, yes, so there was a good sleep, but AHIC 105, so that means 105 times in a minute the patient either had an apnea or hypopnea. And if you see here, the more predominant is the apnea, so it is pretty bad. The patient has severe OSA, the patient is having desaturations also, but if you see the titration part on a CPAP of 9, we are correcting the OSA and getting a very good saturation. So it is possible to have an optimal titration even in severe OSA when the AHI may cross more than 100. And I seriously request you, all of you, whenever a patient gets you a sleep report, just try to see what all parameters are mentioned in that. Try to find the AHI, which will of course help you say whether it is OSA or not, but try to look beyond the AHI also in terms of the sleep quality, the REM, the body position, the Cheyne-Stokes breathing, the saturation, the minimum saturation, the time spent in hypoxia, and the same parameters with the CPAP when the titration part is done. So I think I'll stop here. Any questions I'll be happy to have. Thank you once again, AIG Hospital, for giving me this opportunity.
Thank you, Pranavesh, for your excellent explanation of polysomnography in the details and the CPAP and the micro aspect of the CPAP. You've done a good job, though as a physician we don't understand much of this subject. Anyway, because Dr. Pranav is online from the Delhi, so we will leave him for the rest of the Sunday for his family to spend with his family. So we'll take a couple of questions. Pranav, are you ready?
Yes, sir. Yes, sir.
Sir,
am I audible,
any
sir?
questions, anybody? Or we have a couple of questions here. You want to read it? It is coming on this screen. Pranav, here is a question already printed.
AV team
Just a
needs
second.
to
Yeah.
pop up this slide for the questions.
Sir, if I'm audible, thank you for this opportunity, sir. And I agree, sir, sleep studies are a little difficult to comprehend, but if we know what all parameters are shown there, probably in time to come, we will actually look upon them and try to interpret them also, sir.
Should I read the question? So, Pranav, here is a question for you. The question is as follows. Central sleep apnea is diagnosed in polysomnography by evaluating, we have 4 options. A.
Yes, sir. Am I audible? Sir, am I audible?
You are, but am I also audible?
Yes, sir. Yes, sir.
Okay.
So I had given this question, sir. This question I submitted for the
you
pre-test.
gave this question. No, you can answer directly.
Yeah. So what I wanted to just say was that in level 1 and level 2 sleep studies only, where we have the body leads for thorax and abdominal belts, that is the effort, as well as the nasal pressure transducers, only then we can appreciate whether the event was obstructive or central. So some evidence we can of course indirectly get by other parameters like thoracoabdominal paradox, but as I showed in my slides also, flat lines, that is no flow and no effort. So no flow from the nose and no effort from the chest belts will help you diagnose a central apnea. So that was the question which I had submitted, sir.
Do you have second question with you, Dr. Pranav? Do you have the second question with you?
I'll just open it, sir. Right. Sir, if you can, if you can just tell me the question, sir, I'll tell the answer for that.
Optimal CPAP titration for OSA requires?
Yeah. So ideally, if somebody asks for optimal titration, as discussed, it is not only about the AHI. I agree the main aim is that we have to correct the AHI and bring it to less than 5. But as I told before, the sleep quality is also important. So we need to have a 15 minutes of supine REM, and that is considered along with an AHI less than 5. We consider it as optimal titration. So as per definition of ASM also, ideally we should have a level 1 or level 2 polysomnography so that we can get body position to look for supine position. We should have EEG to look for EOG, also to look for REM. And of course, for AHI, we should have the nasal pressure transducer and the thermistor fluid. So the correct answer there would be correction of AHI with supine REM. So these two questions questions I had submitted. And I request everyone, so if in the afternoon, besides the devices, if you get a hang of some polysomnography reports, try to interpret them and you can discuss with the faculty present there. It will help you in the future also. Thank you.
Thank you. Audience, any questions? Quick 1 or 2 questions because we will leave him here. Any questions? Dr. Pranav, usually the polysomnography report is a computer generated and printed one. So is it okay to go through the printed one and take a decision, or you have to take your expert opinion?
So when in our hospital, sir, what we do is we mark these sleep studies and we print them ourselves. But let us suppose we get a patient who has a printed report. So of course, go through the parameters like the total sleep time, the sleep quality, the AHI, the desaturation. Ideally, we expect, yes, it should have been marked correctly. But if you find any discrepancy, like in the case I had shown where AHI was less than 5 and the patient was having severe snoring and daytime sleepiness. So I immediately looked at all the parameters of sleep study and I found that the wake part was 60%. So definitely that sleep study was not done optimally. So when we get a printed report, if we can clinically correlate the findings, very good. If not, ideally, we should get the raw data also. And the raw data will be a little difficult to procure and interpret. It takes actually hours to mark all the complete sleep study of maybe 6 to 8 hours. But having that knowledge will help us in probably correctly marking reports, which are, if at all, incorrectly marked.
Any questions? So if there are no questions, Dr. Pranav, we thank you very much on behalf of the entire team of organizers and AIG and both of us chairperson sitting here. Thank you very much for joining. Have a good day.
Thank you so much, sir. Thank you, sir. Thank you.
Thank you, Dr. Pranav, sir. So, as Dr. Vijay sir was telling a couple of minutes ago, decades back, there was no mention of OSA in Indian setup, especially mainly because of malnutrition. So, how exactly did it evolve over the years, and what are the epidemiological factors and what are the cultural factors involved in the evolution of OSA? To speak on that, we have our next speaker. I would like to invite Dr. Abhishek Goyal. So, Dr. Goyal sir is currently the professor and head at JIMS, Dehradun. So, he has more than 100 publications, as you can see, and more than 50 alone in the field of OSA. So, it is safe to say that he is one of the giants in sleep medicine. So let us learn from him the various aspects of evolution and epidemiological in OSA. Thank you, sir. Over to you.
Thank you. Giant is a very big word for a 5'6" man for me. And regarding the statement which both of the chairperson were making, that we didn't know about OSA. The thing was, OSA was always there in Indians. We never knew about it because there was no data to support that. So my talk will be a role of ethnicity and evolution in the development of OSA, and how our genetics affects our risk to develop OSA. So as Dr. Vijay was saying, this was one of my slides around 12 years back when I started presenting lectures on sleep. So the most common myth was that this disease is a new disease, this is a disease of obesity, and it was never there because we were immune to develop OSA. Just like 40, 50 years back, we were immune to develop cancer. We didn't have diabetes around 50 years back. That was a statement which was made around 50, 60 years back. So similar kind of statements were made that we do not have the risks to develop OSA, and we are at a slightly lesser risk to develop OSA. So in the textbook also it was written that Africans are at a higher risk than Caucasian, and there was no mention of the Indians or Asian even in the literature. What is the risk? So my work for the last 5-6 years have been to see whether we are at a higher risk or at a lower risk as compared to Caucasian, and whether this disease is only seen in obesity. And then whether, at the end of the lecture, probably I will be able to convince you that this is not a benign disease, and this is not a disease only seen in West. So these are the headings in which I will be covering for the next 20 minutes. So I will be discussing about human evolution and the prevalence of OSA, how OSA in Indians are different compared to Caucasians, and what is the association of OSA in Indians compared to Caucasian and Africans, and what is the accuracy of existing questionnaire for Indian population and for the new questionnaire which we have made this year only. So the story starts around 2 lakh years back, when everyone was living in Africa, everyone was black, and everyone has the same ethnicity. So people started moving around 1 lakh years back towards Asia, and from Middle East towards Asia, towards Europe, and then around the indigenous population in the America. Not the current population, but the indigenous population of Americas were habited there around 15,000 years back. So the Europeans who migrated around 55,000 years back then invaded America. We are now following the literature of those people who have been separated from us by around 1 lakh years. So a race is not only about the color. The people who moved from Africa to places which had lower UVR, there was a change in the color. But the main important reason was due to changes in the environment, the temperature, the altitude. There was changes in the craniofacial anomaly also. So currently there are 7 races, and one of our race is South Asian, which is different from East Asian, and the Native American, whom the European killed. This is the separate Native American race, which has a higher risk to develop OSA. So currently the concept is East Asian have the narrowest craniofacial, and they are at the highest risk to develop OSA. But what about us? Where do we stand? So I will be discussing about that. So we have a brachycephalic kind of skull. So this is an ethnic spherometry slide showing that we have a narrow and a short skull, short and broad. That was a concept earlier. And the Europeans have a long and narrow skull. This is a recent study on around 200 skulls from various parts of world, and out of those 20 or 25 from India. And they compared the skull density, skull width, skull length. And what they found was the South Asia, that was mainly comprised of from India and Bangladesh, we have the narrowest and the narrowest skull as compared to any other race. We have the narrowest skull that predisposes us to more development of OSA. And why that happens is because in a normal patient who doesn't have any narrowness of the skull, if you add obesity, then they will have narrowing. But an inherent population who has a narrow skull, even in absence of obesity, will have a narrow airway. And if you add obesity on the top of that, we'll have further narrowing during sleep, which leads to significant compromise in the airway. So the existing literature was from India, was mainly from these two papers. Dr. Udvadia did a level 3 home sleep testing in 250, and RES 400 did a level 1 and only in males. And Dr. Sharma from AIIMS Delhi did a stratified sampling in 150 individuals, level 1 PSG. But it was stratified sampling in 150 individuals. So this was a slightly lower sample size, only had some problem with level 3, only males. This had a very small sample size, was stratified. They found the prevalence was around 13%. So that's why it was said that Indians have a lesser risk to develop OSA. So, and worldwide, in the last 2 decades, the population studies have shown that OSA was much more common according to the current definition. If we define OSA as AHI more than 5, the prevalence was 46% in Germany, 72% in Switzerland. So an AHI, if it is defined currently as more than 15, the prevalence was every 4th female and every 2nd male had OSA. So compared to that prevalence, our prevalence was much lower. So that means we are at a lower risk. So we designed a study which was sponsored by ICMI. It took me 5 years to complete this study, and it was why the study was done, because epidemiologically sound studies were not there from our country, and in older studies there was differences in sampling. Level 3 was done in some in level 1, some in males, and none of these used a level 1 PSG in all the individuals. And moreover, the Stopback and Burling, which are the famous and most commonly used questionnaire, had very poor sensitivity in our population. So the main aim of this BLESS study was to approximate the prevalence of OSA in India and to make an indigenous screening tool for OSA. So this was recently published this year, and in this what we did was we randomized healthy volunteers from community from 18 to 80 years, and we invited them for level 1 PSG in hospital. Out of 1,400 individuals, 1,015 individuals underwent level 1 PSG. These were healthy samples taken from population, and after excluding patients who had sleep less than 4 hours, 958 individuals were finally analyzed. So what we found was the median age of this population was 40 years and median BMI was 23. These are very important because this BMI age matched that of Indian population according to NFHS 5. And what we found was that AHI more than 15 was seen in 30% of the individuals. As you can see over here, mild is present almost in 40%. If you add mild AHI more than 15, that means that the OSA was seen in more than 80% of the individuals. That doesn't mean anything because that means everyone has OSA. Because the definition is itself flawed right now and the work is being done on to redefine the definition of OSA. Currently the accepted criteria is AHI more than 15 and in some populations 17, but in our population what we have found is AHI more than 15 or 16 in a level 1 PSG is supportive of OSA. So this table compares the moderate to severe OSA and mild OSA, and obviously in OSA people defined by AHI more than 15, the obesity markers will be higher. But the important point is, kindly see over here, the witness apnea, one of the pointers of stop bang, was seen in only 14% individuals in patients with AHI more than 15. Another important point was ESS, sleepiness more than 10, that is sleepiness, was seen in only 17% individuals, and it was seen in 13% of the individuals without OSA also. This doesn't differentiate. So ESS is not the criteria to score. Now where we stand is, even at a younger age, thinner population, our OSA is almost comparable to that of the worldwide available literature. So the next step was to compare our data with this European and African. So these this is the Benin country from which one of the papers was done, which was published in Lancet, and this is a small country over here from where the original human evolution started. Second group was from Switzerland, third was from us. So we compared these three population-based, this was population-based sleep epidemiological study. Total sample was 4,690. And what we did was to find out the influence of ethnicity on OSA and ethnicity of comorbid insomnia and sleep apnea. So this paper was published just last month, and what we did was we tried to find out COMISA, that is comorbid insomnia, in our country compared to Africans and Europeans, and how COMISA varies in terms of complications. So what we found was for Africans there was no increased risk to develop metabolic syndrome or hypertension if comorbid insomnia was compared along with OSA, but for Caucasians and Indians, the risk was higher to develop hypertension and metabolic syndrome. But the difference was, for Switzerland people, COMISA showed a trend of odds ratio 1.34 for hypertension, and for us it was 3.3. So the risk was significantly higher for an Indian person with insomnia and OSA as compared to a Swiss person or a Caucasian, to say. So that means if any of us will develop a OSA and he will have insomnia also with OSA as a complication of OSA, the chances of complication will be much, much higher as compared to a European developing OSA. The reason which I think is correct is because, see over here, the Malampati. Malampati in Indians from a general population, 80% had a grade 3 and grade 4 Malampati compared to 50% of Caucasians. The Malampati data was not there for available for Africans, but 80% of us had a grade 3 and grade 4 Malampati in general population. I think that is the main reason, but I'm not very sure. So, and this is the comparison of OSA leading to complications. So red is Indian, blue is Caucasian, and African is green. So the development of risk of hypertension, the odds ratio for OSA overall was higher than in Caucasian. Similarly for diabetes and metabolic syndrome. That means as an Indian, we are at a higher risk to develop OSA. If we develop OSA, we are at a higher risk to develop complications as compared to these two races. Next step was to compare why is that happening. Because when the BMI is increasing, our AHI demarcated by the blue line, blue is Indians, red is Swiss, green is African. So as our BMI is increasing, the increase in AHI was significantly more for us. Similarly, when the waist is increasing, the increase in AHI was much more for us. As 1 kg per meter square BMI increases, AHI increases by 8% compared to 7% in Swiss. Similarly, as AHI increase is significantly higher. And the reason is because as the BMI is increasing, the fat is deposited more in the neck and the waist compared to other two races. Because as our BMI is increasing, we are getting more fat in the visceral areas. And this is already known that we are a race which are at a higher risk to develop abdominal obesity. This shows the prevalence of abdominal obesity in India, and this study was done in the places where the abdominal obesity is much less as compared to other parts. So if we replicate this study in patients who are more obese, I think the prevalence will be much higher. And this apple-shaped obesity leads to more complications, and we are at a risk to develop apple-shaped obesity. This is a YY paradox, famous YY paradox published in Lancet, where the Indian guy was compared to a European guy with the same BMI but a different fat, 21% fat in Indian and 9% in Caucasian. Differences in the fat deposition. So the obesity has been redefined this year by a group from AIMS Delhi and associated doctors, and they found that the gold standard was a body fat index, but it is difficult to do in population. So these are the criteria for BMI, and we can see that BMI cutoff was much significantly less as compared to what is there for Caucasians, because we are at a higher risk to develop complications. But in India, this paper says waist circumference is the best cutoff to say who is obese and who is not. And the second best indicator is waist to height ratio. So the last part is screening questionnaire. So ideal screening questionnaire is not possible. So the Berlin questionnaire, which was talked about, is a cumbersome questionnaire. How it made is a story in itself. 100 people underwent a level 3 PSG, level 3 polygraphy, and pre-selected questions were there, and they made a questionnaire. For stop bang, patient undergoing surgeries were evaluated a day before surgery, and pre-selected questions, STOP questions were selected, and then 200 individuals underwent level 1 PG, and AHI more than 5 was defined. The bang questions were added later on. So this was a scientifically flawed kind of way to make a questionnaire. The better way how a questionnaire will be made was like NOSA's was made, which is a better questionnaire for Europeans. So what we did, why it is different is because stop bang, snoring is a good indicator, but tiredness is a very non-specific question. Observed apnea was seen in only 14% of us. BMI cutoff are very vague. Neck is not a good cutoff in Indian population. And for females, it gives less point for females. That itself is, that's why it doesn't work in females population. So we found the sensitivity of stop bang more than 5 was only 5% in population. That means out of 100 patients with OSA, you will detect only 5. So that is a very poor sensitivity if you take a famous questionnaire. So what we did was we made an indigenous questionnaire depending on pre-selected questions. That was 40, and out of those biological plausible questions, with a complicated thing, we did ROC curves, urine index, and this we had made a questionnaire, SONA questionnaire, which consists of 4 questions, which are simple as compared to the other one. Snoring, obesity by waist, neck, the cutoffs are significantly less as compared to stop bang, and age, because we saw that for males the prevalence of OSA significantly increased in 4th decade and for females in 5th decade. So out of any 4 questions, any 2 are there, then they are at a risk to develop moderate to severe OSA, and 3 is pretty sure that patient will have OSA. So this is the ROC curve of our SONA questionnaire. It is 0.82 compared to stop bang and Berlin, which are 0.7, which are very poor, and ESS is 0.55. That is just like flipping a coin. So NOSAS is a better questionnaire, but SONA is an indigenously made questionnaire which works better in our population. So this is the total score. As the score increases, the chances of having OSA also increases significantly. So at 2 questions, the score is 5. At 3 questions, the score is 8 and above. And if there is 2 questions are positive, the chances is around 37%, and it should be good enough to screen in community. And if you have a resource constraint setting, you can have 3 questions. Then the chances of OSA at 3 questions will be around 55%. And if all 4 questions are positive, the chances of OSA is around 80%. So each state in our country is a country in itself. We differ from each other by our race, by our beliefs and religion and appearance. But most of us are more similar to each other. Our looks might be different, but our craniofacially, morphologically, genetically, we are more similar to each other than to Caucasians. So, without identifying our native cutoffs, the questionnaire, it should not be used it should be used properly and interpreted with caution. So, to summarize, OSA is very prevalent in our population. OSA is associated with more complication in Indian compared to Caucasian and African. Craniofacial features and visceral obesity plays a major role. ESS, Staubbach and Berlin have very poor sensitivity in our population. NOSAS and SONA are better questionnaire, and SONA is a better screening tool in our population. I thank my collaborators, without whom this could not have been done. Thank you so much.
Thank you, sir. That was an exhaustive talk and a very detailed talk indeed, especially the SONA questionnaire, which most of us were unaware of. So, Dr. Vishwanath sir is asking some questions.
Hey, Dr. Abhishek, thank you for the excellent talk actually. So you highlighted about the role of Malampatti actually, and you said that our Malampatti 3 and 4 are very common in the cohort which you have shown actually. Unfortunately, Malampatti is not included in any of their scores like Staubbach, like Berlin questionnaire or any other thing actually. Even in the SONA questionnaire which you have done, have you included the Malampatti?
We tried to use it, but it was so prevalent that it was not discriminating between OSA and non-OSA.
Okay. In a clinical practice, we always feel that
yes,
when the patient
but
has
it was present in 80% of the population.
Okay.
So it was not good. We found it not helpful because it was so prevalent.
Okay. Since you just pointed out, I'm just asking this. Thank you.
Thank you, sir. We'll take other questions at the end of the session.
Okay. Thank you.
Hello, 1 minute.
Thank you, Abhishek. It was a very nice talk. I have a quick question. Central obesity and the visceral obesity is now being focused. Now they propose BRI, Body Round Index, which is a better parameter, better than the BMI. BMI, the central obesity, central fat was not being taken into consideration to predict the future cardiovascular risk. Now they have included the BRI, Body Round Index. You have nicely shown the shapes of abdomen, apple and pear. So BRI, I think it's a more an authenticated, strong predictor of future cardiovascular. What's your take on this?
So actually, I'm not aware of this index, but I think that is closely that mimics that of waist circumference and waist to height ratio. The paper I was mentioning from the AIMS Delhi group, they have also shown from the epidemiological studies, from 5 or 6 big epidemiological studies from India, that waist was a better indicator. I think they have not mentioned about this body round index which you are mentioning about, and they said that waist is a better indicator even than BMI and waist to hip ratio. And according to them, probably waist to height will be a better indicator, but right now we don't have evidence for that.
Thank you.
Sir, one more question. Sir, can a person with low BMI can have sleep apnea syndrome?
Yes. So there is a recent paper from 4 population-based studies of 13,000 individuals from Caucasian population. And they found that if the cutoff of AHI more than 5 was taken, then the prevalence of OSA in non-obese individuals was 65%. So that means out of 100 OSA individuals, 65 will be non-obese. If we take a cutoff of AHI more than 15, that will be around 50-50. If we take a AHI of more than 30, then that will be 30% who will be non-obese and 70% will be obese. So obesity is definitely one of the important criteria, but obesity is not the only criteria.
There are no questions. We thank you, Dr. Goyal, for the excellent talk. Next, we'll move on to the next topic is going to be understanding basics of PAP therapy, what every clinician should know, by Dr. Chandana Reddy ma'am. Dr. Chandana is a senior consultant and head of the Department of Pulmonary and Critical Care Medicine at Star Hospitals, Hyderabad. Her areas of interest are ARDS, NIV, HFNC, sepsis, ECMO, and critical care nephrology. Wow. She is a teacher and examiner for DNB Critical Care, IDCCM, and IFCCM. She was awarded as the best teacher by the National Board of Examinations at New Delhi. Congratulations, Dr. Chandana ma'am, and mic is yours.
Yeah. Thank you, Dr. Vishwanath and the AIG group for inviting me for this talk. So I'll be basically talking about PAP therapy in OSA. There are a few questions. I think all of you can just sit for a minute, and then I'll go on to my talk. And later, end of the talk, probably will be able to answer them better. Okay, so why are we interested in treating sleep apnea? Because of the adverse effects that it has on every organ in the body, including the cardiovascular, renal, diabetes, neurological, everything. So before going on to the management with PAP therapy, I think we should understand the pathophysiology of sleep apnea. So there are anatomical problems and there are certain physiological traits which are the reason for the development of sleep apnea. The anatomical is, of course, the resistance and collapsibility of the upper airway because of morphological abnormalities, compromised cranial structures, adipose soft tissue deposition, fluid accumulation, and also mucosal edema. In addition to that, there are certain physiological traits like decreased arousal threshold or loop gain, increased loop gain, or the decreased activity of the dilator muscles. All these together will contribute to the development of the sleep apnea. So this Starling resistor model is normally used to understand the physiology of development of OSA, where the critical pressure in the pharynx, the closing pressure, if it normally it is negative, so if it becomes positive, it leads to collapse of the pharyngeal airway. So it should be negative, and the inner pressure, inside the lumen pressure should be more positive compared to the peak rate. So the time when the peak rate becomes more than the intraluminal pressure, the airway will collapse. This is what happens in OSA. So in addition to the anatomical predisposition, the patient may also have certain physiological traits which together will make the patient more susceptible to development of OSA. So with the development of OSA, the patient first has a airway collapse leading to hypoventilation, leading to development of hypercapnia and hypoxemia, which leads to arousal, and that will lead to again increase in the ventilated drive. The patient becomes awake, then gets hyperventilation, again goes back to sleep. So this is a cycle which goes on, and this leads to development of the OSA. Central sleep apnea, again, the different mechanisms are slightly different. We are not concentrating much on the central sleep apnea this session, but mainly because of absent respiratory efforts along with symptoms, and there's respiratory instability with the episodes of both hypo and hyperventilation followed by episodes of apnea, central apnea. So this is mainly occurs because of absence of respiratory drive, commonly seen in conditions like heart failure and high altitude or opioid induced, or sometimes patients on OSA being treated with CPAP also can develop treatment emergent central sleep apneas. So where does the PAP therapy have a role here? So in dilating the upper airway, which is collapsed, PAP therapy helps to dilate the upper airway and then prevent the episodes of OSA. So how does positive air pressure help? It's actually delivery of a pressured air in a continuous or pulse fashion to a patient's respiratory system via a non-invasive patient-device interface. It is the gold standard and the most efficacious therapy, least toxic, least side effects, and the most well-studied therapy for OSA. It maintains a positive pharyngeal transmural pressure so that the interluminal pressure exceeds the surrounding pressure or the peak rate. And the elevated air pressure acts as a pneumatic splint to prevent the upper airway collapse. So again, going back to this model, so like I told you, the peak rate should be negative. The minute it becomes positive, it compresses the lumen, and when it crosses the upstream pressure, which is in the nose, and the downstream pressure is in the trachea, so once it crosses the peak rate crosses the upstream pressure and the downstream pressure, the airway will collapse. So when we give a CPAP or a positive pressure support, we are increasing the inner pressure. So if I give 50 centimeters of CPAP here, that causes the inner pressure to increase or luminal pressure to increase and overcome the peak rate and maintains the airway open. So how does CPAP or a positive air pressure help? The most important thing is it increases the positive airway pressure in the airways, leading to sprinting of the airway. Second is it increases the intrathoracic pressure and also increases the lung volumes. This increase in the lung volume causes a stretch on the airways and the lung, leading to a traction of the airway or the trachea and leading to opening of the airway. In addition to that, it also has the benefits like it decreases the venous return and decreases the afterload, so helps in cardiac patients where there is cardiac pulmonary edema, or in patients with central sleep apnea also. But the negative side of the risks of using a positive air pressure are, of course, decreased venous return can lead to hypotension and cardiovascular instability, and increased abdominal muscle efforts because you are breathing against an expiratory resistance can cause some amount of anxiety and also some respiratory distress, and decrease the PCO to below apnea threshold sometimes, which can lead to ventilatory instability and the development of central apnea when you are using a CPAP for a obstructive sleep apnea. And of course, all the interface related side effects, I'll come to that later. And it can also, because if you are using dry air or positive pressure air, that may also cause some airway inflammation. So what are the benefits of CPAP? We've seen the physiological benefits. What are the clinical benefits? Clearly, it's proven beyond doubt that it decreases the AHI, improves the daytime sleepiness, it improves the cognitive impairment, mood, and the quality of life. And among the cardiovascular risk factors, it definitely decreases the blood pressure. There are a lot of other things which we don't have data for, but definitely there's a trend towards improvement in the mortality, stroke recovery, of course, other cardiovascular risk factors, dementia, atrial fibrillation, arrhythmias. But we don't have strong data, and they're not in clinical studies. And PAP therapy effectively across a range of disease severity. So whatever disease severity you have, the PAP therapy is going to be helpful. And benefits correlate with the duration of use. The longer you use the CPAP during night, the better benefits you're going to have. So what are the PAP components of PAP therapy? It consists of a PAP device, which such as a fan-driven or a turbine system, which draws in external air to deliver pressurized airflow. And it contains a flexible hose, which is usually a single limb, which connects the device through a mask to the patient. And the interface is usually a mask, which can be either, I'll come to those later. And then you have a headgear securing system, which holds it all together. And you can have accessories like the humidifier, which helps in the comfort of the patient and improves. So based on flow pressure sensors, that's the device input, a microprocessor-based controller algorithms adjust the turbine speed to reach the preset airway pressure, whatever you set for the patient. So positive airway pressure targets the most relevant physiological trait, that is upper airway compromise, and is the first line therapy for treatment of moderate to severe OSA and mild OSA if they are symptomatic or if they have concomitant cardiovascular disorders. So if the age is less than 5 and the patient is symptomatic, then definitely we have to go for a more than 10, then we go for a PAP therapy. If the patient is between 5 and 15, that is mild this thing, if the patient is symptomatic, then probably you can consider going for PAP therapy. If the patient is more than 15, definitely you have to go for a PAP therapy. The various PAP therapies that are available are CPAP, bilevel positive air pressure, automated positive air pressure, automated bilevel positive air pressure, adaptive servo ventilation, and IVAPs. But the commonest and 90% of the time we'll be using is the CPAP. Others also will be using certain cases based on their indication. So what is CPAP? CPAP is nothing but a continuous positive air pressure, which was first described in 1981, and it's a single continuous positive air pressure in both inspiration and expiration, given to spontaneously breathing patients, and patient has to initiate all the breaths, and no additional pressure is given during the inspiration part. Additional support is not given to individual breaths. The CPAP works to split the airway open and prevents collapse of the upper airway. And the pressures needed varies with the severity of OSA, and higher pressures needed in supine position and REM sleep, and in those who are obese, more obese compared to the non-obese OSAs. In contrast to the OSA, CPAP is only partially effective in central sleep apneas. For only 50% of patients it may help, and may be harmful in those where the CSS is not suppressed. And the long-term compliance, unfortunately, with CPAP is only around 50 to 60%. It ranges from 30 to 80%, but most often we see not more than 50% people being compliant with the long-term use of CPAP. Coming to bilevel positive air pressure, here there is a varying pressure in both the inspiration, which is higher, and expiration, which is lower. So the IPAP, you can give up to maximum of 30 centimeters. It mainly helps to prevent the hypopneas, raras, and snoring by preventing the upper airway closure. And it augments the tidal volume because it gives a pressure support. It reduces the respiratory rate, work of breathing, and decreases the carbon dioxide. So it can also help in non-obstructive hypoventilatory conditions. EPAP, that is a lower pressure in the expiration, it stabilizes the upper airway, and this is the main thing which helps overcome the obstructive apneas. It also helps triggering of the ventilator, and it recruits and improves the extended respiratory lung volume. So it improves also traction and opens the airways, and it also. But the problem with this is, and one more advantage is that you are giving a lower pressure compared to the IPAP, so the patient has to expire against a lower pressure compared to CPAP. So it causes less respiratory discomfort. And the difference between these two is what is the patient gets as the pressure support, and greater the pressure support, greater the tidal volume, less the work of breathing. And you can set the pressure support, and you can set the inspirated time. If you use a time mode, all that you can do. So then among the bi-level posterior pressures, we have several modes. We have the spontaneous mode, time mode or spontaneous time mode, auto mode, ASV and EVAPS. Spontaneous mode is where the patient has to breathe, and then it is sensed by the machine, and the machine synchronizes IPAP and EPAP with the IE of the patient and provides support only the effort is present, and there is no backup rate. Whereas time mode is where the spontaneous breathing is not very good, and the machine triggers the breath. It is time cycled, and there is a fixed respiratory rate, and because the patient does not have a good respiratory drive. In ST mode, the patient will support or augment the patient breaths which are initiated by the patient, but will wait for some time. The patient does not breathe. A backup rate will be given, and patient will be supported by those backup rate. And these two I'll come to later. What are the indications? So 90% of the time I told you you tend to use CPAP only for sleep apnea, but there are certain indications where we will be using bi-level posterior pressure, where patient is failing CPAP or auto PAP, or where the patient's requirement is very high. So if it's more than 20 centimeters pressure requirement is there, the patient will not tolerate the expiration because he has to breathe against the 20 centimeters. And whether intolerant to CPAP or high pressure, or patients who have a component of hypoventilation, like restrictive lung diseases, obstructive lung diseases, or obesity hyperventilation syndrome. Here also, probably, especially in OHS, you can try CPAP first. If they don't improve with that, then probably you can switch to bi-level PAP. And of course, in central CPAP apneas and periodic breathing. But the problem with this is, of course, the cost. And sometimes they feel that the EPAP, if you keep it too low, it may not be sufficient to open up the airway, and you may have your obstructive events persisting. So when you compare the CPAP with the bi-level PAP, of course, this is continuous level, and this has inspiratory and expiratory are different. And you can set the rise time, IE ratio, trigger and cycle sensitivity to make it more comfortable and synchronized for the patient. The CPAP does not help much with the patient's work. It does not provide adequate ventilation, or it does not give extra rate. It does not augment the breath, but mainly it keeps the airway open, upper airway open. And you can develop central apneas. Whereas the bi-level, it provides some amount of ventilation, it augments the tidal volume, it decreases the work of breathing, and also helps in hypercapnia. But the problem always will be because of cycle dysynchrony and can cause hyperinflation. And I told you cost, and if the EPAP is not adequate, you can have the problem. Then auto PAP is again a form of CPAP or a BiPAP, where the PAP will sense the SDP events, and according to the SDP events, it will increase or decrease the pressure required for the patient. And they'll take a decision on what to do. Okay, the range set will be around 3 to 4 centimeters to around 15 to 20 centimeters. So like for example, here the patient is breathing well, so the pressure is on the lower side. The minute they find that the flow is coming down and the patient having an event, then automatically the pressure will start increasing, and it will adjust according to the requirement of the patient. So this is an automated titration of the pressure, and the patient will have the fluctuating pressure being given to the patient throughout the night. So and where is it used? Where do we use the auto PAP? Basically, where we use it when the patient is intolerant of a fixed PAP, because the patient is not able to sleep with such high pressure coming. So the pressure will start at a lower level, and then as the patient requires during the night, they will increase. And we don't need to titrate. If you don't need to titrate for a auto or CPAP, we can just directly go for a patient can start using it. And the patients, the night, the machine will adjust the amount of pressure based upon the requirement. Like in REM sleep, the patient may require more pressure. Like in supine position, patient may require more pressure. So accordingly, the patient ventilator will adjust this thing. But the problem is that leaks may be interpreted as events, and you cannot differentiate between central and obstructive sleep apnea. And in comorbid conditions, you should not use the auto PAP. But they found that there is no difference between advantage using BiPAP versus CPAP or auto PAP for routine management of OSA. So CPAP is always the first still. Titration already they've discussed. And about ASV ventilation is mainly used for central apneas or chain stroke respiration, where there is a combination of pressure support, change in pressure support, backup rate, and they also have an auto EPAP where they adjust it according to the requirement of the patient and make sure that the patient does not have hypoventilation or hyperventilation. Again, same thing for volume assured pressure support, where the patient will be provided a particular volume or a tidal volume or a wind ventilation by adjusting the pressure support. This is more useful in patients who have obesity hyperventilation or sleep-related hyperventilation or any other hyperventilation related to medical disorders. Whereas ASV is mainly useful for central or mixed apneas and periodic breathing. And you should not use ASV in patients who have hypercapnic respiratory failure or low drive, or patients who have less than 45% EF. Coming to the interface, so there are different kinds of interfaces we can use. We can use a nasal mask, we can use a nasal pillow, full face mask, or a oronasal mask which covers both the nose and the face. The main advantage of a nasal mask is it remains very stable and there is minimal movement. So there is a chance of leak are very less unless you open the mouth. But then also for patients who have nasal obstruction or facial deformities or facial paralysis. Nasal pillow, again, least contact with the skin, no problem with the facial hair, better field of vision, they can read, they can use glasses and everything else, no claustrophobia most importantly. But again, problem is that if it's very high pressures, the patient will not be able to tolerate it. And if they may open the mouth, they'll have a very high risk of leak. Oronasal mask, in those especially with nasal obstruction and in mouth breathers or with a large leak on nasal mask, this will be useful. But again, they're more prone to leak surface because the surface area is larger and they're bulkier, costlier, and claustrophobia is the main problem. One important thing is that therefore what they've recently saying that now is the nasal mask is better because they find that, for example, here this is a collapse when there is no PAP, positive pressure. The minute you give nasal PAP, only if you use a nasal mask, you're giving 15 centimeters and it's overcoming the peak rate. But when you're giving it through both the oral and the nasal route, what they found was that the tongue actually and the palate actually is being pushed back because of the air which is coming through the mouth. And this is causing a partial obstruction. So they recommend that probably a simple nasal mask is the best as compared to oronasal mask. So again, choosing the right mask is very important. And we have ways of measuring what size is particularly suitable for that particular patient. And we should always check the device when the patient is supine position and adjust the mask properly. These are all the problems with the PAP therapy. Of course, air leaks, nasal congestion, claustrophobia, dryness of the eyes, pressure sores, dry lips, chest discomfort, aerophagia. And we always have to put the stabs properly so that we don't cause leaks at the same time we should not cause too much pressure on the skin. And the leaks can be intentional through the exhalation port of a single limb tube, or they may be unintentional. These are all the causes of the extra leak from the mask. And we can, in a nasal mask, we can prevent the mouth opening by using a chin strap. Or we can use a support for the mouth where you can prevent the mouth from opening. Humidifier is another thing which can improve the comfort of the patient, where you can use a cold or a heated humidifier where water goes, air goes across the water and it's heated. Or you can use a HME filter also. This prevents the damage to the mucosa, reduces side effects and increases comfort, but not found to improve the PAP compliance. We can even have heated tubes also which can improve the humidification. So this is how we decide. So we do a sleep study. If it's simple OSA, we go for a CPAP or an auto PAP at home. And then if the patient is not improving or the patient requires high pressure, we go for a BiPAP, bilevel positive pressure. The patient has central apnea, we go for a ASV mode. The patient has hypoventilation, try first CPAP. If not improving, then we can go for a BiPAP or a VAPS. Adherence, I think Dr. Rakesh will be talking about it. And how we improve adherence by doing all ramp and this thing. So finally, I just conclude with this. So this is the guidelines from the American Academy of Sleep, where they recommend regarding the use of PAP therapy in sleep apnea. So you should treat all patients of sleep apnea, should be based on diagnosis of OSA using objective sleep apnea testing, follow-up and including troubleshooting and monitoring of objective efficacy. You should use CPAP compared to no therapy to treat OSA in adults with excessive sleepiness, impaired quality of life or comorbid hypertension. You can use either APAP at home or in laboratory CPAP titration for fixed CPAP. CPAP or APAP for ongoing treatment of OSA in adults is a strong recommendation. And you should do CPAP or APAP over BiPAP. So no recommendation for BiPAP in the initial part of OSA management. You should have educational interventions, behavioral interventions, troubleshooting interventions, which all will help you to improve the adherence of the patient to PAP therapy. And for additional consideration, you use an nasal mask rather than a oronasal mask for CPAP because that seems to be more efficacious compared to using a nasal mask, unless the patient has a lot of obstruction in the nase and they are not able to tolerate it. And you suggest generally using heated humidifiers with PAP devices to reduce the side effects. Thank you.
Thank you, Dr. Chandana. You have a question on the screen. I think you can take it up.
Let me go back to that. It's not showing here. It's not showing on the screen. Questions. 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 No, paper. No. It's in my presentation, not presentation. Yeah, I think I asked one question about what is the interface of choice in a patient with CPAP, OSA. Yeah, point. Okay. So first is, what is the mechanism of action of positive airway pressure therapy in sleep apnea? All except. Anybody from the audience can answer this?
Anyone?
Yeah? Anyone? Yeah? Answer is C. So basically it's pneumatic splinting, I told you it's already there, and traction on the airway because of the increase in the lung volumes. And there's no, it does not increase the pharyngeal dilated muscle tone. Nothing to do with the tone. It probably decrease the edema a little, because by the positive pressure it may decrease the mucosal edema a little. So that's the answer for that. And next one, interface recommended for use with CPAP in a patient with moderate to severe obstructive sleep apnea. So it will be a nasal mask or a nasal pillow. Is recommended over a nasal mask for the reason I already told you just now. Okay, thank you.
Done. Thank you very much, ma'am. We'll take questions at the end of session. Please be available for us. Thank you.
Thank you, ma'am. So, with the basic knowledge of the CPAP therapy, let us now learn what are the benefits of CPAP therapy over different systems, especially the cardiovascular system. To present on that, we have our next speaker, Dr. Raghav Rao. He's our consultant here at AIG. So, over to you, sir, please.
Thank you. Thank you all teachers, seniors, colleagues and friends for being here today. I would like to discuss between obstructive sleep apnea and the cardiovascular benefits which we have. Though there is a lot of controversy in this area. Cardiovascular morbidity and mortality as such are leading causes globally still. And one of the most overlooked contributors to it is treating sleep apnea. Today at the end of this talk, we would be able to say treating sleep apnea with a CPAP therapy is just not another sleeping aid, but it would be a very critical intervention to improve the cardiovascular outcomes. Disclosures pertinent to this are none. My outline of this talk, I would be discussing regarding the problem statement between these two, impact of treatment, and trying to make a meaningful statement from evidence which we have. The rationale by which cardiovascular outcomes, morbidity and mortality improve are by decreasing hypoxemia and hypercapnic episodes, decreasing the current microarousals, increased sympathetic activity which happens, and loss of nocturnal decrease in heart rate and blood pressure. All of these seem very much plausible biologically. And almost all the outcomes have been described epidemiologically, and epidemiological studies with respect to sleep apnea and cardiovascular outcomes are huge. A simple untreated severe sleep apnea, when they are followed up for 10 years, the incidence of fatal cardiovascular outcomes is 1 per 100 person years, and non-fatal outcomes of 2 per 100 person years. 100 person years here might seem a big thing, probably if you consider one person living up to 100 years. But imagine it the other way. 100 people in this room who are having severe sleep apnea, if they are left untreated, one of them is going to develop a severe cardiovascular event, and 2 of them non-severe fatal cardiovascular events. It's quite significant that way. And again, the risk in other sleep heart health cohort which has followed up for nearly 8 years, it increases by 1.5 times. So if we say all of them were recruited primarily, maybe they were having cardiovascular disease at the time of recruitment, then there are very big incident analysis studies, cohort studies for the sleep health heart study and the Wisconsin health cohort study, where people were followed for 8 years to 25 years. And again, the risk increases by nearly 60 to 70% in the sleep heart health study, and in the Wisconsin sleep cohort by hazard ratio of 2.6%, which again translates to 50 to 60% increased risk. Though this risk is not translated with people having mild OSA. So if there is an increased incidence, if there's an increased prevalence, people who already have a cardiovascular disease, the risk of further worsening the pre-existing cardiovascular disease increases by 11 times. Compared to those people who were, the incidence of prevalence was just 2 to 3 times. Those who already have a pre-existing disease, it increases by 11 times, which is huge. Coming to hypertension with obstructive sleep apnea, there's definitely increased prevalence, nearly 15%. With an AHI of more than 15, it increased by 3 times. Another very important aspect is understanding arrhythmias associated with sleep apnea. Again, there is an increased incidence, there is an increased prevalence, and also recurrence of atrial fibrillation is high once we don't treat patients with obstructive sleep apnea and AF. All the other arrhythmias, bradyarrhythmias, ventricular arrhythmias are also increased. Same is the data again with heart failure, where the prevalence is 50 to 70%. And if we don't treat them, heart failure with reduced ejection fraction who have sleep apnea, the event rate per 100 years actually doubles again. And so sudden cardiac deaths, again an increased risk, and people who are adherent to treatment of sleep apnea, who continue, the sudden rate of sudden cardiac death decreases from 7 to 0%. Similarly, data with pulmonary hypertension suggests same. Survival is less in people who have OSA and pulmonary hypertension who are left untreated. So to summarize, almost all these risk factors are high for people who are having moderate or severe sleep apnea. There's an increased incidence, increased prevalence, and increased recurrence if we don't treat them. Maybe this boils down to some of the phenotypes. But then when you try to look at the evidence, as ma'am was saying, there is no strong evidence is what she was saying. It also looks upon to how we are reading this evidence, I would say. All the observational, retrospective or prospective data, they really show a strong impact of treatment. Randomized control trials, the SAVE, Ricketts, all the landmark trials, they don't show any benefit. Meta-analysis show a mixed benefit. Meta-analysis which were a decade earlier show no benefit. Those which have recent onset again show significant benefit. So if you try to understand this, why this is happening, I mean, whatever evidence we have, without any evidence, if you are trying to say this is helping it, it's probably only whims, fantasies, and speculations. So we try to understand what is actually happening with this evidence. This meta-analysis was published last month in Lancet of nearly 11 lakh patients of 10 randomized control trials and 20 non-randomized control trials. Here again, the all-cause mortality has reduced by 37%. This data here is not reflected in the randomized control trials, but in the non-randomized control trials, it is again reflected here with the hazard ratio of 0.6. That means almost 40% reduction for people who are treated with obstructive sleep apnea. And both together, it reduces by 37%. And this effect also is lasting when the largest trial of 9 lakh patients was excluded from the study and analyzed. Now coming to the cardiovascular mortality from the same meta-analysis, it reduces by 55%. Again, randomized trials are not showing benefit here, and non-randomized trials are showing benefit. So to understand why this is happening, the difference between cardiovascular outcomes between non-randomized control trials and randomized control trials, the basic thing which we are facing here is a lack of statistical power. And the number of events which have occurred in these randomized trials compared to the non-randomized trials is just 200, well compared to nearly 140,000 events. So to reach a adequate sample size, considering the hazard ratio of 0.87, which was showed in the randomized trial in the last meta-analysis, at a power of 80 and an event rate of 3.3, we need a sample size of nearly 24,000. And till date, all the randomized trials which were published have sample size maximum up to 5 to 6,000. So this is where we are really lagging behind. Then for a person to really have benefit while using CPAP and sleep apnea, the minimum time duration to be used is at least 4 hours. This was answered by the Ricketts post hoc analysis, where on using for at least 4 hours, there was a hazard ratio reduction by 0.29. And this was found in the multivariate and not the univariate, again, probably due to confounding factors. This was further supported by the meta-analysis, where people using CPAP for at least 4 hours, the reduction was 42%. And the impact of treatment on hypertension numerically seems small, but decrease in mean systolic blood pressure of 2.6 mmHg and so on. It is not comparable alone with the antihypertensive medications, but in uncontrolled hypertensive people, add it on to the conventional treatment measures like antihypertensives or weight loss, it really has a huge impact again. Moving on to the impact of this on atrial fibrillation, I mean, this is another meta-analysis which was published, The CPAP reduces the rate of atrial fibrillation by again 40%. In the general population in these meta-analysis, the association of atrial fibrillation and CPAP was 35%. If I take the liberty to extrapolate the hazard ratio of 0.58 here, we can probably say like CPAP must have prevented nearly 17% of cases to have AF. Another important thing again with respect to atrial fibrillation here, after ablation, when they were followed up, a very interesting observation here is people who were compared with sleep apnea and no sleep apnea, there was an increased risk of nearly 30%. People who are having sleep apnea and who are not being treated with CPAP, and compare them to those who don't have sleep apnea, the risk is 57%. Now when these people are treated with CPAP, the risk is almost zero here. It's comparable to those, not zero, it's comparable to those who are not having sleep apnea, the recurrence risk of atrial fibrillation. Similarly, the benefit is extrapolated to other arrhythmias, nocturnal arrhythmias, NSVTs, and so on. The risk of sudden cardiac death and pulmonary hypertension, the reduction is probably not to the impact which we have with atrial fibrillation or other cardiovascular outcomes. To summarize, I mean, the outline of topic, we have a significant association between sleep apnea and cardiovascular morbidity mortality. We do have a significant impact of treatment, especially with moderate and severe sleep apnea. And to make a meaningful statement, probably our RCTs are lagging behind because of the sample size which we included them with. So if again I have to crudely compare this treating sleep apnea to other outcomes, if we are able to accept aspirin as a secondary prevention for vascular events, if we accept treating hypertension in general population with antihypertensive, if we are really accepting treatment of heart failure with reduced ejection fraction, which is to the tune of 20 to 35%, which are cornerstones of treatment, then we can very comfortably or very convincingly say it might be equally effective, if not more efficacious, to treat sleep apnea in patients who have sleep apnea to prevent cardiovascular mortality and morbidity. So I think a pertinent question here is not if we have to really treat sleep apnea, pertinent question is how do we ensure our patients are offered this and how do we ensure they adhere to this treatment? Thank you.
Thank you very much, Dr. Ragharam. You have a question on the screen, you can take it up. Can someone help, please?
Okay.
Yeah.
Okay, the question I actually put up was, which of the following statements are true with respect to majority of the evidence treating sleep apnea with respect to cardiovascular outcomes? Chandana ma'am, do you still say no benefit?
Anyone can answer. Even if it is wrong, it's okay.
Okay, the answer here is probably which is not true. Which of the following statements are true? So RCTs, they definitely didn't show any benefit. Most of the major RCTs, and probably the meta-analysis there of the new ones show benefit, the older ones do not. So probably B and C both are correct. To have a meaningful benefit of using sleep apnea for outcomes, here probably we need to use it at least for 4 hours, which is from the meta-analysis and from the Rickettsize trial. Thank you.
Any quick questions from the audience? 1 or 2 questions, please. Yeah. Chandan, you allow 1 or 2 questions or you're done? So I have one just comment, Dr. Ragharam.
Sir.
The atrial fibrillation and other arrhythmias of heart, is it only hypoxia related or anything, any extra mechanism? Because it is involving the conduction system of the heart. So is it only that low oxygen level that is causing arrhythmias, or is there any other mechanism involved?
The main predisposing factor for these atrial fibrillations and other arrhythmias were nocturnal hypoxemia, sir, and autonomic system dysfunction.
Oh, autonomic, sympathetic and parasympathetic.
Yes, sir.
Okay. If there are no questions, I think I hand over the mic to Dr. Chandan for the concluding.
So I
Yes,
have,
sorry.
I don't have a question, I have a comment. Excellent presentation.
Thank you,
Excellent summarization of the evidence we have. I just have a comment that the RCTs had not shown the benefit, but post-hoc analysis of Rickettsize trial, when it was separated by heart rate variability and by hypoxic burden and p-VAT index, it was shown that if we choose our patient correctly and not on the basis of AHI, post-hoc analysis have shown that even RCT have shown the benefit, mortality benefit have been shown. Thank you.
Can you take the mic, please?
If the heart rate variability was more than 10 during the apneic episode, then the mortality benefit was seen. That's what I remember from that study actually.
I have a question to Dr. Chandana. Ma'am, can you go to the mic, please? You spoke very well on central sleep apnea. We are seeing in report that even young people without any cerebrovascular disease are being diagnosed with central sleep apnea. So is it not age-related degeneration of the cerebellum, or is any other factor that young people are also coming with central sleep apnea?
I don't know about this. We have not seen any cases, sir, central sleep apnea in young patients. We've seen mostly obstructive only. We have not seen central. So only in heart failure we've seen it most often in heart failure or strokes, but not in young patients. I don't know if anybody else. Abhishek, anything?
You also say there's a mixed variety, right?
Yeah, have you seen central apnea? He's seeing more commonly now in young patients, central apneas. No, sir was asking that it's more commonly seen nowadays in young patients, so he's asking for.
Thank you very much. Dr. Chandan, over to you.
Thank you, sir. So I believe all of us, that was very wonderful talks in the first session. So we come to the end of the first session here. I would request Dr. Vijay sir to kindly hand over the mementos to the speaker. Kindly come on. Dr. Gautam, please come and accept the mementos. Vijay Mohan sir. I request Dr. Goel sir to take the mementos. Dr. Chandana ma'am, kindly I request you to take over the handles, a memento. Dr. Raghav, kindly accept the memento. Thank you, sir. Thank you to all the speakers and thank you to Chairperson. So we break here quickly for a very small tea break. On the other side of the tea break, we have very interesting session, which includes a debate as well. So I request everyone to kindly assemble within 10 minutes. Thank you.
Thank you, Dr. Chandan. Thank you, AIG.
Thanks.
And thank you, Vishwanath and your team. Thank you for having me here this morning. Thank you very much.
Thank you, sir.
Just have a word with you.
Um, I'm Dr. Vishwanath from the Department of Pulmonology. Next, we have a very exciting sessions. We have one pro-con debate and also panel discussion and one interesting talk on CPAP troubleshooting and other things. This session is going to be very, very interesting. And to chair this session, may I request Dr. Paramjyoti sir to come on to the dais. He will be the referee for the pro-con debate. And can I also request Dr. Ramesh Kumar sir, he's the professor and HOD at Bhaskara Medical College. And Dr. Paramjyoti sir, all of you are aware, he's the head of the department at NIMS and also the academic dean. Thank you both of you sir for coming to the conference and also accepting to be a part of a conference as a faculty. Thank you sir.
Very good morning to all of you. In fact, I'm very much delighted and hearty congratulations to Dr. Vishwanath Galla and his whole team for organizing such a good conference, CME program. It's in fact the best practices in management of sleep apnea. Thank you once again to all of you. So I request Dr. Paramjyoti to do the proceedings.
Once again, good morning to everyone, and it's really nice to be here attending this best practice management sleep apnea. Very informative so far, great lectures by all the speakers so far, and by now we are aware that OSA is a common condition that gaining its importance, and awareness is there among the general public and more so among the physicians as well. So we are seeing more and more of OSA patients. And earlier, when we say OSA, the picture that would come to our mind was an obese male patient who is sleepy. But now we know that OSA can happen in non-obese, it can happen in women, it can happen in children, it can happen in non-sleepy patients also. So, and the mainstay of treatment as of now for once you diagnose moderate to severe OSA, it's CPAP. And now we have an interesting debate. Two legends in the field of pulmonology. R. Vijay Kumar sir is one speaker. He's going to talk on auto CPAP is better, that's for the motion. And Dr. Abhishek Goel, manual CPAP is better. So he's against the motion of auto CPAP. I mean, he says manual CPAP is better. So we're going to listen to both of them. First will be Vijay Kumar sir.
It's indeed my pleasure to introduce one of the senior most faculty member, our teacher and mentor, Dr. Vijay Kumar sir. Presently, he's a director and he's also running and you all know he's always on, first thing would be his preference is to always go for the academics. So he's now the chairman of the Hyderabad Chess Center, where every month there's a chess conference for the postgraduates. You will see that the best speakers come and participate. A quiz conference to see that the current trends are being updated. And his area of interest is pulmonary medicine and also critical care. He was one of the finest bronchoscopists and also airway management specialist, as I know. Needless to say, he has made many publications. He was awarded many awards, and he has been writing a couple of chapters in many textbooks. So he has also published a textbook on mechanical ventilation, an international edition on 2020-25. So I request sir to please come over, and I'm sure you will be enlightened by his discussion. Welcome, sir.
Dr. Paramjyoti and Dr. Ramesh, the chairpersons and the referees for this debate. I'm a basic country doctor. I've been practicing for the last 50 years. And I keep treating all varieties of pulmonary problems. Got interested in critical care because of my international fellowship in critical care in the United States. Got interested in sleep medicine. I went for a fellowship to Sydney, Professor Sullivan, and started practicing even that. I was thoroughly impressed with Dr. Abhishek's presentation on the epidemiological and anthropometric variations of different countries. Very nice data. I'm not as deep into sleep medicine as he is, so he has nothing to fear from the debate. And I know these debates are fun, some humor, some satire, but most important is an exchange of information and education for the audience. So I will start by saying the debate is over. It is auto-positive airway pressure, of course. So the advantages of this is very obvious, auto-adjusting positive airway pressure. That's the reason why it is called auto-PAP. And compared to the fixed pressure CPAP devices, and even in the market, when you say we need a device, the company is first presenting the auto-PAP rather than the fixed PAP. And the reasons are not very difficult to see. It adjusts the pressure according to the requirement and improved comfort for the patient. Adaptability is superb, and there is no need to keep titrating with in the lab or anything. It titrates automatically. There is a huge amount of data it collects, which is useful for us. And based on this data, we can always make changes and improves all the outcomes. And there is a maximum comfort because it delivers an average lower pressure compared to the fixed pressure of the fixed CPAP. And the variable pressure needs of an average obstructive sleep apnea patient, whether it is body composition or whether it is a position, the way the patient sleeps, the peak rate keeps changing. As the peak rate keeps changing, we have to adjust the pressure accordingly. But the most important area where an auto-PAP scores over the fixed CPAP is pregnancy. As the lady's pregnancy progresses from month to month up to the delivery, she starts retaining water, the diaphragm goes up, the thorax volume comes down, and the peak rate values also keeps changing. This is for obstructive sleep apnea in a pregnant lady. So the auto-PAP automatically does everything that is required to be done. So when we said the OSA keeps changing, we are talking about weight fluctuations, alcohol consumption, which most people into this category are, the body position during the sleep, and also the different sleep stages. And like Abhishek mentioned, the upper airway anatomy, mostly the Mallampati scores in the Indian population, which is very, very different from the European ones. So auto-PAP has got the ability to adjust to these constantly changing pressures. We know the 4 pillars of therapy success: low leakage, AHIs, and restorative sleep and compliance. Compliance and low leakage are linked to each other. When a patient buys a PAP machine, and if there is a lot of leakage, he is not happy and he is not compliant. He doesn't adhere to it. There is a beautiful review article in the chest which talks about unintentional leak. They have gathered something like 121 publications. Of that, nearly 20 or so RCTs they have managed to evaluate, and they have identified certain important things, of which leakage is a very important area. So let us spend 3 or 4 slides on the leakage. Auto-PAP measures and compensates the leak better than the manual CPAP. More advanced leak detection, and it is real time. There is a continuous feedback loops to monitor the airflow, the pressure, and the resistance. And they precisely estimate the unintentional leaks by comparing the actual leak to expected intentional mask vent rates across a range of pressures. They can log the leak data and give it to us, to the clinician. And very smart responses to the leak. It can adapt to the leaks by adjusting the pressure delivery to maintain an effective therapy. It modifies algorithms to avoid false detection of apneas caused by leaks. Some machines detect these leaks as apneas, whereas the autopaps, they know that it is an unintentional leak and accordingly it will adjust. So manual CPAPs cannot respond automatically. If there is a major leak, the therapy may become ineffective and without alerting you immediately. And better leak reporting, documentation. APAPs offer detailed leak reports, on-screen summaries, SD cards, and cloud-connected apps, whereas manual CPAPs may only offer basic leak data or none at all, depending upon the model. Now, there is another publication which says when you treat obstructive sleep apnea, less pressure is better. So they titled it as less may be more. So I've been saying the automatic PAP devices, they adjust. This is based on advanced algorithms. When I say algorithm, they measure each breath, flow, relative minute volume, and the mean pressures are lower than the fixed pressure. It detects leaks better and compensate appropriately, and it measures 2 minutes, which is an epoch. Epoch of 2 minutes are evaluated for flow and obstruction. So another 3 or 4 slides on the APAP algorithms. So it uses forced oscillation technology, and it can differentiate between central apnea and obstructive apnea. When the low reflection of the pressure wave is there, but the strong airflow response is there, it detects it as central apnea. Whereas when there is a strong reflection of pressure wave and low airflow response, then it becomes an obstructive apnea, and accordingly it treats. Now, we can look at the algorithm, how it responds. When there is an apnea or a hypopnea or even a RERA, it increases the pressures. And when there is a flow limitation, it maintains that particular pressure and it waits that there is no further events. If there are no further events, the pressures gradually come down in the third phase. And if the patient starts snoring, the pressures goes up again. So the algorithm is designed to cater to the needs of different stages. It has got 2 APAP settings, the standard and dynamic. Most people require the standard settings, but wherever the high pressures are required and they benefit from high pressures, the dynamic settings can be placed. This is how some of the advanced auto-PAPs are designed. The severe obstruction, mild obstruction, and flow limitation. And accordingly, based on the algorithms, it measures each epoch as 2 minutes, and pressure change happens at the end of the epoch. For severe, it waits for 8 breaths per epoch, and for mild, it waits for 4 breaths per epoch. And if there are more than 2 events in one epoch, that is when the algorithm kicks in. And the goal is that the patient gets acclimatized quickly to the new pressure and sees that there are no events and no arousals. Basically, the algorithm will divide the entire pressure requirements and the flow requirements into the 4 quartiles. I will not go into the details, but sufficient to say that these 4 quartiles are based on the different pressures requirement. And when the pressures have to decrease, again these quartiles are used, and if no events occur, the pressure is decreased gradually. There is a beautiful paper where forced oscillometry technology is based and auto CPAP device was used for the treatment. And they found that the central apnea or the treatment emergent central apnea is more or less very similar to the mixed obstructive sleep apnea before doing the devices during the polysomnographies, very less. And for the audience, there were a few questions in the last session about the central sleep apnea. It is just 0.9% in the population. So the rest is obstructive sleep apnea. Autopaps, they use, as I said, less pressure. In this study, the mean therapy pressure was mostly between 7 and 10. And you can see the blue shade, that is a leak, is also very less. So higher the pressures which the machine doesn't use, the pressures are likely to be more. And with autopap therapy, the slow wave sleep, the REM part, and the arousals index, all are less. And autopap titration efficacy is very good. How good it is? There was a study, 100 patients of obstructive sleep apnea, both moderately severe and severe OSA, and optimal outcomes 52%, good outcomes 41%, adequate outcomes 7%, unacceptable results were none. And the prevalence of persistent sleep apnea with the regular fixed CPAP is quite common. Even after using the regular fixed CPAP, patients come back and then say their problems are not solved. Here is a study where 101 patients were confirmed who had obstructive sleep apnea, and the CPAP was used for 3 months. And after 3 months, again, the PSG was repeated. What they found was 17% had persistent sleep apnea, and there was need for higher pressures. They got up with early morning headaches, non-restorative sleep, and the air leak was unresolved. What is the satisfaction level of using the autopap? Again, there is a small study of 15 patients where they used one night the autopap and the other night they used a fixed CPAP, and they did a visual analog score, and it showed that the visual analog scores were better with the autopap, 10 out of 15. So compliance and adherence improve when the leaks are managed and when the pressures are less. So here is a study again of 139 patients where it was very severe sleep apnea, and they were evaluated at the 3rd month and also at the 6th month. And this is how it goes. Let us look at the last column, that is apnea hypopnea index, compared to the blue column, which is the initial stage, then the orange one, 3rd month, and the yellow one, 6th month. All seem to be decreasing very rapidly. Patient expectations from the device, they want an economical machine, relief from day one, and so on and so forth. And new autopap devices are coming which are smarter, sleeker, more AI-based chips, use algorithms, better leak detection and compensation. As clinician, we are happy if the patient is happy. Now the cost. The initial cost of a fixed CPAP may be economical to look at. Auto CPAP may be little more, autopap may be little more, maybe about 5,000 rupees. If the patient is using this machine for about 10 years, that means he would be spending 1 rupee 36 paisa per night extra. So, friends, autopap, of course, Well, I've been using fixed CPAP in the beginning when autopaps were not there. To quote Julius Caesar, not that I loved CPAP less, but I loved APAP more. We need to adopt the technology. If we don't do that, we may go the way the dinosaurs went. They became extinct. Thank you.
So that was Vijay Kumar sir. As usual, he's always the best speaker. And the next speaker would be Dr. Abhishek Goel, and he will be against the motion. He is in favor of manual CPAP titration. And Dr. Abhishek Goel is currently professor and head James Dehradun. He is a giant in sleep medicine. Out of 100, he has 100 publications, out of which more than 50 are in OSA, and he has got 4 ICMR grants in sleep medicine. And over to you, Dr. Abhishek.
Thank you, sir, and thank you, Vishwanath, for giving me an easier topic to defend. I'm a manual CPAP guy at heart, and I don't believe that auto CPAP is the current way of treating the patient. Maybe in the future, but not currently. So I will be saying with the evidence. And auto CPAP, I think the debate is currently not limited to complicated OSA. I think what we are very clear is that auto CPAP is not the preferred mode for treating complicated OSA. That means any patient with heart failure, CAD, CVA, COPD, any other comorbidities, you should not use auto CPAP. I think that thing is very clear. What we are debating over here is auto CPAP versus fixed CPAP for uncomplicated OSA. I think that is very clear. Because most of your patients will have some comorbidities. For those patients, level 3 is out, auto CPAP is out. That is very clear. So auto CPAP is not like an automatic car. It is like a driverless car. It is like a doctorless machine. You have prescribed it, you have forgot it. So I will be summarizing in these topic, in these headings. Is auto PAP better? Why we are giving the therapy? We are giving therapy because we need the patient to improve. Of course, we want the patient to be comfortable, but main aim of treating OSA is to decrease cardiovascular complications. That is the most aim. We are not bothered about AHI. I think the aim is to decrease the cardiovascular complication. Is AutoPAP better at that? Regarding adherence, cost, and the ease of advice, I will also cover the topics. So, all the PAPs looks like the same. The difference is in the algorithm of AutoPAP and PAP, and the sensor. That is the only difference between an AutoPAP and PAP. Sorry. So, with the help of FOT, pulse oscillations, the microprocessor detects whether there is a flow limitation, and on the basis of its own algorithm, its own intelligence, it detects whether there is an hypopnea or apnea, and it thinks that there is an apnea, I will increase the pressure. After some time, again, there is a decay pressure. After some time, it will decrease the pressure. And depending upon the manufacturer, the algorithm, which is proprietary and it is not disclosed to anyone, the machine proprietary algorithm decides whether to increase the pressure or decrease the pressure. So it is just like a stock market. It is going up and down throughout night. And just like stock markets give you sympathetic activity, heart rate variability, similarly, for fixed CPAP, the sympathetic activity is less as compared to AutoPAP, where the variation is more and the sympathetic activity is more. So this is a very beautiful paper written around a decade back, which I always quote. And if you are interested, go through this paper, in which 11 auto CPAP manufactured devices was compared to each other in a bench study. And what they found was, all the 11 manufacturer studies were compared, and what they found was, kindly point to the CSA detection. Whenever the artificial center sleep apnea was there, only 4 machines did not increase the pressure. Rest 7 machines increased the pressure, when the pressure should not have been increased. When there was snoring, only 5 machines were effective in increasing the pressure. Rest did not increase the pressure when it was subjected to increase. Regarding the treatment efficacy, how much they increased the pressure, was this sufficient or not? See, some machines had a very poor efficacy in terms of abolishing the apnea or hypopnea, and the scoring accuracy. So previous speaker was talking about the accuracy of the AHI download, that the AHI has improved. So the machine is saying that we have treated the patient. Machine is saying AHI is less than 5, patient is okay, patient is less sleepy, that means patient is healthy. So because of the different devices, different algorithm, machine has different response to the same kind of event, and they have a different download report from the same patient. So in this study, same patient was given 2 different auto CPAPs, and the download data was significantly different from one group to, from one machine to another, from the same patient. So this was a study on 70 around individuals. So that, 3,000 individuals for 70 nights. So that means there is a huge discrepancy in the downloaded data. So we should not rely only on the download data, because the machine is telling you what it is thinking it is truth. So in this paper, the auto CPAP downloaded data or fixed CPAP downloaded data was manually scored, and it was seen that the machine was saying the AHI is more than 5 in around 30% of the individuals. When it was manually scored, it was seen in 60% of the individuals. When AHI cutoff was used for 15, the downloaded data said 1.8, and actually on manual scoring it was 7.8. So the machine is telling you that patient AHI is low, patient has improved, but it is far from truth. It is as true as Pakistan saying that we have won the war last month, because they believe that they have won the war. So that's why the machine is believing that it has treated the patient, and now the truth is we have to find what is the truth. So the next important question, and I think the most important question is decreased cardiovascular complications. So whether this auto PAP decreases the cardiovascular complication more. So, and apart from the cardiovascular complication, the data for sleepiness is same. I am not going to touch upon that. The sleepiness improves in both auto PAP and CPAP, fixed PAP. The cardiovascular effect, there is no head-to-head trial. But for hypertension and autonomic system control, fixed PAP has been shown to have significantly more better results than auto PAP. So this is one of the slides taken from my students who was doing some work, and we are compiling a data for same patients. So this is a patient in which auto CPAP was given during night titration in hospital. So this is auto PAP titration. So you see this pressure, 13.9, 14, 15, it is going up. So whenever there is an apnea or a hypopnea, there is a arousal, there is a sympathetic activity denoted by plethysmography. There is a variation in plethysmography. This is indicator of sympathetic activity. So you see the variability in the pleth. So at a pressure of 13 to 16, the variability is there. When the pressure on auto PAP is 15 to 16.9, even then the pressure variability is there. At a pressure of 15.9 to 16.9, still we are having flow which is abnormal, which is slowing, which is going up and down, multiple arousals over here, and sympathetic activity which is going up and down. In auto PAP, for the same patient, when it was shifted to a fixed PAP at 15, similar pressure, the variability of PAT flow was same, leak was same, variability was less as compared to what we see over here at a similar pressure. Why does it happen? Because the patient is getting a constant up and down pressure, so the body is not getting adjusted to the pressure. Similar studies have shown that heart rate variability and sympathetic nervous system control denoted by cardiovascular coupling was better for fixed PAP as compared to auto PAP. So next, this is a study which has been published. An abstract is going to be published this year by the Grenoble group in France. That is the only group which believes that fixed PAP is better than auto PAP. They have published few studies, so I will show another study also. But this group has what they have done. The gold standard for sympathetic control, sympathetic activities, MSNA burst. So the same for the patients, they randomized, and they found that MSNA burst was much better controlled by CPAP as compared to auto PAP. So these are the summary of the same paper by same group, in which 5 studies were compared. Only 2 studies found that CPAP, fixed PAP was better than auto PAP, and 3 studies did not find any difference. The reason was the difference in the methodology how this study was done. Because in this study, the APAP was selected randomly in all the studies, in the 4 studies, only the study was Petrino. They did a manually titrated pressure, and what they found was significant better benefit with blood pressure in fixed CPAP as compared to auto PAP. They randomized 30 patients into 15 and 16. So 2 studies right now have the evidence. This study by Petrino randomized trial, fixed pressure was found to be better than auto by 6 millimeter. This study by the Grenoble group in France found that fixed pressure was better in reducing 24-hour diastolic blood pressure. This was an automated generated CPAP pressure. That is, after giving autopap for 2 weeks, they determine the fixed pressure and then they give it. They did not do a manual titration. So we also did a similar kind of study, but with a better design. This is going to be published this year. What we did was we took 40 patients of hypertension with OSA, moderate to severe. We double blinded the study. Same patient was crossover to fixed pressure and autopap. So same patient first received autopap, then after washout received fixed PAP, and the same machine with the different modes, and ABPM was done and sympathetic activity was done at 4 times to see which machine works better for that particular patient. So this is a kind of gold standard to see which patient is getting better with fixed and which is getting better with auto. So this is the same patient, we saw much variability, and just to summarize, for the results were that fixed pressure decreased the blood pressure by 8 millimeters and autopap decreased by 3 millimeters. So difference of systolic was 5 and for diastolic was 3 for same patient. So I think that is clear that fixed is better than auto. Now coming to adherence, I think there is no confusion that adherence is almost similar in both auto and fixed. I am not going to debate for that. Regarding the cost, so sir told that cost is slightly increased. So why this cost issue is there? Why the guidelines are saying you have to see this column. The USA level 1 PSG cost $4,000 compared to a level 3 cost $800. So if you give an auto PAP after level 3, the cost will be $1,300 compared to a $4,500. So that's why the guidelines are saying reduce the cost. Insurance companies are saying reduce the cost because it is so prevalent disease. That's why they are pushing level 3 followed by a home sleep testing. That is to decrease the cost. But what happens in India, the cost of PSG is not that high. There's not much of a difference. So even if you give an auto PAP after a level 3, which is a slightly costlier, still it will be almost comparable in Indian settings. So we should not blindly follow what they are saying. We should use our brains also. So the next important question is why we are using auto PAP? Because I think because it is easy to advise. You give it, you forget it, that you have given it. Because we don't have labs, we don't have technicians who are trained to do titration, and we don't know how to score. So what about the comorbidities? Because patients of OSA will not have only OSA. If he has any other comorbidity, just like mentioned, COPD, heart failure, CAD, CVA, you should not use auto PAP. This is contraindicated. So if the patient is there with these complications, auto PAP is out. So in a real world scenario, this is not my slide, this is I've taken from some other lecture. So this is a real world scenario in Europe where 60 patients have some contraindication because of associated disease. For this, those patients you cannot do a level 3 study. If you do a level 3 study in 40, supposedly out of 100, 16 will fail home sleep testing because of technical issue, because of removal of leads. 24, if they have been detected OSA, 4 will develop CSA, central sleep apnea, with autopap. You should not give autopap if they have developed treatment emergency sleep apnea. Out of 20, 4 will develop failure because we know that 20% of the patient require BiPAP. So out of 100, only 16 will get benefit with level 3 followed by home sleep testing in real world scenario. Because when we are doing a level 1 PSG titration, we are seeing the problem right there. We are treating the patient, we are knowing the mode, the pressure, we are seeing the central sleep apnea, position therapy and the mask. So I believe auto PAP does work, but it is not superior to fixed PAP. The blood pressure and autonomic system control is better than fixed PAP. 20% will require bilevel PAP. So again, auto PAP patient will have some sham benefit. The sleepiness will improve. It is going to improve, but the patient cardiovascular complications are not going to improve. Thank you so much.
Thank you, Dr. Abhishek, for your excellent points that you have presented in favor of manual CPAP titration. Now, quick rebuttal from Vijay Kumar sir, if he has.
I congratulate Dr. Abhishek Goel for trying hard to disprove. One of the studies where they compared the 13 autopaps, but then there were 2 which succeeded in doing a good job. That is because they had a good algorithm. I am sure, just like the phones, iPhones set the benchmark, and very soon the other companies, they follow suit and they also come to the same standards. And trials about the cardiovascular risk, too early to say, because fixed PAPs have been around in use for the last 60 years, and auto PAPs are just coming out of the market in the last 5 years. Trials will come. I request Dr. Abhishek to undertake a trial with auto PAP to evaluate the cardiovascular risk. Newer algorithms, I said, are on the way, and better compliance is better adherence, and that happens with the auto PAPs. And with regards to the comorbidities, yes, they are very less when compared to the obstructive sleep apnea without comorbidities. They are not congestive heart failures, they are not severe cases of renal failure, or etc. So majority are like the regular OSA who have no comorbidity. So where autopaps are a wonderful machine. For OSA with comorbidities, of course, we have to treat them with very gentle hands, and we have to treat them very carefully. And level 1 studies have to be done, home studies cannot be done, and they have to be watched very carefully. I agree that autopaps very soon will be able to take care of that also very soon with better algorithms. It's on the way. Thank you.
Now it's time for Dr. Abhishek to rebut.
Thank you. I have, I think, sorry. Can you please show the slides? So I have just few points. I will just give you analogy for the pulmonologist over here. If you have a mediastinal patient with a mediastinal lymph node, what will you do? Will you advise him a blind DBNA? Or in Hyderabad, the land of intervention pulmonology, you will advise him a EBUS? Because just like an EBUS, we are seeing the problem, what is happening. We are doing guided diagnostic and guided therapy. So if there is a patient with a small nodule, we compare a 6-year-old smoker and a 6-year-old snorer. If the patient has a small nodule, if he lands up in Hyderabad, you will have every kind of gadget over here to find out the cause, because it is associated with complication with mortality. But what about a poor snorer? There the cost is an issue because we don't have labs. So importance is that with the current upcoming evidence of decreasing complication with fixed PAP, I think it is better to have a driver car versus a driverless car. Because with a driverless car, I think some of you might have the courage to walk on the to drive on these roads. But on the difficult terrains, I think it is very difficult to use a autopap with associated comorbidities. So future, yes, I agree with sir that future is going to be of artificial intelligence, but currently our machines are not that well tuned. So we have to be intelligent enough to use the machine properly. And currently we need sleep lab and trained technicians. And just to summarize, I think fixed PAP is easy to advise. That is the most important reason why we are advising. As far as complications is concerned, there is no doubt that fixed pressure works better. Thank you.
Thank you, Dr. Abhishek. And once you say fixed CPAP is better for our Indian population, for most of the OSA patients, do you go by any equations that are available? Does it help? And there is a recent publication from Korea, I guess.
From Korea?
Yeah, yes. For Korea, where there is no difference between split night titration or full night titration or home auto titration, unattended home auto titration. That's one. Second thing, another paper from Saudi Arabia, as I said, For most of the patients with obstructive sleep apnea and complicated, CPAP with 10 centimeters is good. 10 centimeters of CPAP for most of the patients is good. It's neither more nor less. So it works for most of the patients with CPAP of 10 centimeters. Unattended CPAP, you can just simply advise auto CPAP for most of the CPAP. So your comments on that.
So the literature says that most of the CPAP pressure requirement is less than 10, as you are mentioning.
Yeah.
But the practical things I have seen over last 10 years in a titration of more than 2,000 Indian patients, I will see the minimum pressure, the median pressure is around 12 to 13. Most of your patients will require pressure more than 10. The difference is probably because in the craniofacial anatomy. And I have checked with that with the colleagues who in India are working on manual titration. Their experience is the same, that we require a higher pressure. And I have published a paper in Lung India where we saw that 20% of our patient required BiPAP because of the failure of CPAP. So if CPAP pressure up to 18 it is not working, we shifted to BiPAP. So AutoPAP is definitely not going to improve in those patients. For 20% of the patient, your pressure requirement is very high. For 10% of the patient are developing central CPAP in India. Why that is happening, we don't know. But around 30% of the patients will definitely not improve with the fixed PAP in a normal setting. We require either a BiPAP or ASV. And for auto CPAP, because there is huge variation, the chances of improvement, in my opinion, in my experience, is around 40 to 50% in general population in India.
Okay. So does it correlate with DNS? The higher pressures is because of the DNS in our population more.
So,
correlate with the
I have not done, unfortunately.
That's the Saudi Arabian
DICE for these patients. Yes. That question can only be answered by doing a detailed DICE in all the patients who require higher pressures.
Okay. So, and I agree with Vijay Kumar sir, so that with the newer machines that are available, results are better because we have this SERV-HF trial and then Advent-HF trial. Even though the patient population was a little different, but still the machine also was different. The EPAP was a variable in the Advent trial. That's where there is, you can still be giving CPAP in adaptive servo ventilation.
Sir, that trial you are mentioning about, it was CPAP, not CPAP trial, that was ASV trial.
Yeah, ASV trial, yeah, that's what. No, the point is, even the EPAP is variable.
Yes.
With the newer machines. So fixed is not that good. Yeah.
So that is a different mechanism because of central CPAP apnea. Your airway is closing and opening, and your high loop gain is there. So that is a different etiology than obstructive sleep apnea.
That's true. Yeah.
And definitely, even in those patients, I will say, if you give CPAP properly, then most of your patients will settle with CPAP. You need not to have a auto CPAP. Oh, sorry, ASV in those patients.
That's true. So even I am of the opinion that majority of our patients will be requiring CPAP. If they can afford, APAP is better. And if you want to blindly give a pressure of CPAP of 10 centimeters with a nasal mask. Yeah. Dr. Kishore has a point here.
Just a question and one comment. Question is for Sir Dr. I think both of them were excellent. I think the evidence shown was brilliant. So my question is pretty basic. So the basic tenet of a AutoPAP machine is to keep going down to the lower set pressure, isn't it, sir? So if, for example, you set a pressure of, let's say, as sir said, 12, supposing, let's say, the patient's 95th percentile pressure is 10, and you put a set of pressure of maybe 12 to 8. And every time the patient is requiring pressure of, let's say, 10, or it increases the pressure, but its natural tendency of the machine is to keep going down to the lower set point. Isn't that a big inconvenience for the patient in terms of, if the pressure keeps fluctuating like that, in terms of adherence, because we're all talking about adherence, and what do you think about it? Yeah. Yes.
In fact, it is the other way around. In the sense, when the patient requires a lower pressure and the machine is constantly delivering, there is a fixed CPAP, constantly delivering a higher pressure, patient is uncomfortable. So when the patient requires a lesser pressure because there is no snoring, there is no hypopnea, there are no RERAs, no apneas, machine automatically looks at the epochs, measures the flow by delivering a small burst of forced oscillatory, and then it says, okay, this patient doesn't require so much, the peak rate values, so it reduces the pressure gently over a period of time. And that is what the patient wants in sleep. He doesn't want to get up because there is suddenly a very high pressure which is disturbing him.
Sir, I will like to disagree with that. The trial which I was mentioning about, we also saw the comparison of auto-PAP pressure, the randomized trial which I showed, versus fixed PAP pressure. So we found that, as he mentioned, that auto-PAP was 2 centimeter less than fixed pressure.
Correct.
So the same patient, the comfort level was same for the patient. We have also filled the questionnaire. Patient felt same with auto-PAP and fixed PAP. There is no difference in terms of patient quality of sleep, quality of life. We have done all the parameters. So the only difference was blood pressure control. So what we want, even if you say that it is a more comfortable therapy, which I disagree, even if the comfort is more than auto-PAP, say, but what you want a more comfortable therapy or a more effective therapy? That is the question.
So, and the second comment was about the pressures you said, sir, about deviation and all that.
Yeah.
So, which I think I will cover in my talk.
Okay.
But so now what we are doing is what we call as airway characterization or interventional dyes, sir. So what we have found, it's just not the nose that causes increase in pressure. It's also structures like, supposing you say 10 is the ideal pressure at which the airway opens. So we have found when you do dyes that it is the lateral pharyngeal wall and the soft palate that opens at 10. So if there is an obstruction somewhere lower down, say a lingual tonsil or an epiglottic collapse, the pressure is much higher. So the lower the obstruction, the higher is the pressure required to open up the airway.
I know. As surgeons, I think you will go for DICE study and DICE titration. And yeah, that's also required for hypoglossal nerve stimulation studies. So DICE is that way mandatory there. Well, if there are any more comments, we still have time. Oh, yeah.
Be it a CPAP or auto-PAP, one of the biggest drawback for these things are claustrophobia. Can we change the interface from a fixed interface to the Ram's cannula, where there is a control leak? The idea behind is preventing the airway collapse, right? The CPAP is a pressure which prevents the airway collapse, and the other limitation is they have claustrophobia, nasal injury, mucosal injury, and all these things. Why can't you people as a pulmonologist think in terms of Ram's cannula being attached to that machine where you can deliver a reasonably good pressure with a controlled leak? Some amount of leak will be there. When you are looking at this, there is some, it is going up and down, it is oscillating. Ram's cannula ventilation, people are shifting to Ram's cannula, and which is much economical and a better device where you can do a better ventilation. And a second factor is obesity is one of the important risk factors. This what do you call that? GLP-1 agonist or tirzepatide or semaglutide, all these things can be used because the underlying pathological mechanism for these OSA is obesity reduction. If they have a good BMI and a good weight reduction, they will feel much, because we need to look at the underlying reason than treating this OSA. That's my just comment.
Sorry for ignorance. I don't know about that cannula which you are saying regarding. Okay. So, but that doesn't create so much pressure which is required to open the airway. So, I don't think that will work. So, the second point is the tirzepatide you say. So, yes, tirzepatide, the SURMOUNT trial have shown that the OSA decreases significantly, around 50% decreases there. But the problem with tirzepatide, it decreases only obesity and also decreases the skeletal muscle mass. But apart from that, studies have shown that whenever you stop this GLP-1 analogs, obesity recurs. So in Indians, obesity is not the only cause, and also the now studies from other ethnicities are also showing that obesity is not the only cause. So if the patient is obese, definitely it will help, but it will not be a alternative to CPAP. That's my opinion.
That's true. And now, in days to come, maybe we're going to have pharmacotherapy, atomoxetine and oxybutynin in combination. So there, maybe only pharmacotherapy might work in some of the patients. So, yeah. So, any more comments on? Yes. The pressures will. Correct. Correct. The genioglossus, yes.
Yeah, especially the genioglossus. And any drug which can selectively increase the tone of the genioglossus and also the surrounding pharyngeal muscles automatically will open up the nasopharynx during sleep, and there is no sleep apnea.
Yes, these
Just
two drugs,
one tablet per day.
Yeah.
And of course, we have to take care of obesity, hypertension, and all the other things, sleep hygiene, etc., etc., etc. Since we are talking about only the devices, then probably the pharmacotherapy is just round the corner. It may hit the market anytime soon.
I had one question to Abhishek. In what percentage of your titration studies you don't get an optimum titration? That you have to repeat the study once again?
So, sir, optimum is we don't we try for optimal, but I think around 50 to 60% of the time we settle for optimal. We achieve optimal titration, but even good and adequate titration is sufficient. If patient is very obese, I am going to talk about that in the titration also. So.
Okay.
Anyway, that's a great talk from Abhishek Goyal and also Dr. Vijay Kumar sir. But let us summarize. See, most important things would be is what we are familiar with, what the patient is accepting, and ultimately what are the predisposal conditions. Probably you have comorbid conditions and a severe obstructive sleep apnea, COPD, heart failure, and neuromuscular conditions. Most of the experience goes that manual BiPAP is much better. But the auto CPAP is a new advanced machine, high technology is there. And in fact, one of the things I would like to tell you, especially it adapts to the positional changes, REM sleep, alcohol use and nasal congestion, improved comfort, and definitely higher compliance rate, and especially in mild and where you have simple CPAP. And portability is very good. So, and one of the important findings Dr. Vijay Kumar highlighted was in pregnancy, definitely probably yes. So thank you very much. Both of you have spoken very well. The pros and cons are very taken. But from the postgraduate point of view, I would say is we should definitely know everything about manual BiPAP. And wherever the specific conditions are there and advantages there, we can go ahead and start using with auto CPAP. Thank you, all of you.
Thank you all the speakers and the moderators. Now proceeding further, we have a brief inauguration of the our sleep lab clinic. For further proceedings, I would like to invite Dr. Vishwanath for.
At the outset, I would like to thank the excellent faculty who have actually agreed to be a part of this one-day event actually. Nothing is possible without the support of our great administration. We always thank our Chairman Dr. Nageshwar Reddy, Vice Chairman Dr. Mr. PVS Raju, and Dr. G.V. Rao sir, our Director, for giving us this great platform to conduct a lot of academic activities, workshops, and other things actually. And thank you, sir. Both of them are here today. And I'll also let you know why we had this idea of conducting the one-day conference and also launch of the CPAP clinic. Lot of times when patients are prescribed auto CPAP machine after the sleep study, most often they would actually do not initiate the CPAP device, or even after initiation they would stop it immediately because of either lack of motivation, because of fear of mask, pressure, dryness of throat, and inability to tolerate the pressure. And lot of these patients actually drop using the CPAP in the first 3 months. And this is the time when patients actually require support for them to maintain the CPAP regularly. And then we have also seen in the talks from the morning that adherence to CPAP is definitely associated with decreased mortality, cardiovascular complications, hypertension, and so on and so forth, actually. So that was the reason which made us think of conducting this one-day event and also having a conference to deal with the CPAP non-adherence. What we are going to do in this dedicated CPAP and the sleep clinic are that we'll assess the patient and give customized therapy according to the patient's condition, actually. So these patients are actually reassured, motivated, and told them about the benefits of CPAP machine. And in the sleep lab, we'll give them a trial of CPAP in the daytime, which is called as an PAPNAP trial, which actually makes them more comfortable to use the machine at night time. And also, we can also, nowadays, we have telemedicine technologies which are able to help us in identifying the events which the patient is facing or any leak which is happening, so that we can remotely monitor the patient and also help them in adjusting to the CPAP machine. So in addition, we'll have a dedicated structured follow-up scheduled visit. If the patient is not able to tolerate the machine, or if there are issues with that, probably we can collaborate with our ENT surgeon, Dr. Srinivas Kishore is here, or we can address the root cause issues like obesity with the help of our bariatric surgeon. He's here, actually. So lot of things, collaboration requires a structured follow-up, and then also collaborating with other departments to troubleshoot things which are happening to the patient, actually. And this will also help us maintain and training for the residents and also for the technicians who will become better at scoring sleep studies and also helping patients to adapt to the CPAP well, actually. And I would request our Vice Chairman, P.V.S. Raju Garu, Director, Dr. G.V. Rao Garu, Dr. Paramjyoti sir, Dr. Vijay Kumar sir, and our Pulmonology team to come over to the dais. And I also request Dr. Srinivas Kishore sir to grace the podium for the lamp lighting. Raghav. And in addition to this, this was also an effort at educating ourselves and making our care better, actually. We have created some leaflets, brochures, and also some videos to help the patients understand things better, actually. Nishant, come. Dr. Anuj, please come. We have created a night brochure which will help the patient in troubleshooting when they're using the CPAP, about all the instructions, and also for the clinicians also when the patient is coming back to us, actually. We have created what all to monitor. There will be a chart in that which will help us in monitoring the patients well and suggesting the patient accordingly to troubleshoot. We'll have the, we'll launch this brochure, actually. I request everyone to be seated. Can I request our Vice Chairman, Mr. PVS Raju sir, to address the gathering and give us a message.
What I heard briefly, I think the discussions are very interesting, and then the diagnostic methods and the treating protocols are getting a new direction. So being a non-clinician, I would like to only step into the shoes of a patient. And what are the expectations? Public awareness of sleep apnea is very low in India, and a lot of people they are not even aware what kind of complications they can cause. It's important to raise awareness about the conditions and its ill effects. Physicians across the departments in the hospitals should be vigilant and in identifying early symptoms, and they recommend for further action. Sleep apnea screening should be integrated into master health checkup. That's what I suggest to our departments. And then the most important thing is these new techniques should be user friendly, and all these health check programs can be done at their residences in a cost effective manner. Thank you.
That's a great suggestion, sir. We'll try to include the sleep apnea questionnaire in the health check so that we can actually screen them and make these services available for those patients actually. Can I now request Dr. G.V. Rao to address the gathering and give us a message? Thank you, sir, for coming for this occasion.
Good morning, everybody. On behalf of the faculty, staff, and the board of AIG Hospitals, a warm welcome to all the faculty and the delegates to this beautifully orchestrated meeting on sleep apnea. I mean, even for us, surgical surgeons like us, we used to believe that snoring is a sign of good sleep. The entire science of sleep seems to have changed over the last 2 decades, and we seems to be learning a lot of things which are going to change the entire outcomes of patient, how they're going to live in future. Surprisingly, actually, our team, congratulations to Vishwanath, his team, Srinivas, the cardiology department, our bariatric department. All of them have come together to formulate guidelines for this, which are helping our patients to a great deal. Kudos to the entire team who are doing this. In fact, even for surgeons like us, we never believed whether this is important for surgical patients. Still recently, we operated on a major surgical procedure. This patient, we thought, as per the data we had, this patient would have a lot of complications in the post-operative period. Surprisingly, this patient had an uneventful surgery post-operative period. Even the anesthetists were quite surprised. And when we took back the history, this patient has underwent surgical procedure with Srinivas Kishore for a sleep apnea before. And we realized this, and actually, in fact, only yesterday, I think day before yesterday, we had a journal club wherein people are talking about sleep studies for patients undergoing major surgical procedures. This not only should involve the clinicians, surgeons, but also the intensivists and the anesthetists together so that they evaluate the thing properly. So that I basically feel actually it is going to improve the outcomes of these patients, especially in the post-operative period. I think we'll take this forward. I think very soon we'll take help of Srinivas, Vishwanath, and make sure that our anesthesia teams also coordinate with you so that any of these patients who plan for major surgical procedures can get help from this. Wishing this conference a great success. Thank you so much once again for making it to AIG Hospitals. Thank you so much.
Thank you so much, sir, for the very important and excellent message. These are some of the videos which we have created recently on how to address mask intolerance and what is PAPNAP trial, which will help the patient in getting adapted to the PAP device as well. And we also have created one video on myofunctional therapy, which is often underused technology actually, which will alleviate the severity of the sleep apnea. And all of these have been uploaded into your YouTube channel, and you can also use this QR code to actually download these videos. And thank you once again everyone for gracing this occasion. Thank you so much. We'll restart our academic session actually. The next talk will be by Dr. Rakesh Kodati. Can I request Dr. Paramjyoti and also sir to come on to the dais? Ramesh Kumar sir to come on to the dais.
Good afternoon everyone. Today's my talk is on CPAP adherence and troubleshooting the CPAP challenges. First of all, how many CPAP hours is sufficient for a better clinical outcomes? There is no standard definition of optimal hours, how much CPAP to be used. Require at least 4 hours for improvement of sleepiness, 6 hours for at least for objective alertness, and more than 6 hours to improve memory and neurobehavioral performance. It is very evidence-based that there is a dose-response relationship with the amount of night CPAP use and the clinical outcomes. Here we can see the number of patients improving in sleep quality and objective alertness and quality of life with increase in usage of night CPAP. However, this is not mandatory. That is, more the CPAP we use, more better clinical outcomes in different clinical parameters we achieve. So coming to definition of non-adherence, the definition is largely arbitrary. The duration is if at least usage of average 4 hours per night with a frequency of at least 70% of nights usage is defined as an adherence, because this is the cutoff which many clinical trials have used to define non-adherence. However, this is just an arbitrary limit, and more the CPAP we use, more better clinical outcomes we achieve. Coming to prevalence of non-adherence, nearly the estimate is around half of the patients usually have non-adherence. This definite exact value is debated. That is, it ranges from 29 to 83% depending on the cutoff use. But however, we can roughly say that around 50% of the patients whom we prescribe CPAP usually do not adhere to the pressure therapy. The main point is the pattern of CPAP use will be established early in the first 2 weeks. So the first 15 days of initiation of CPAP is very crucial because it determines the long-term adherence. What happens if we non-adhere to the CPAP? We already listened to the previous talks. They will have poor cardiovascular outcomes and other worsening of comorbid conditions. This is a trial from Switzerland done in 40 subjects where they have withdrawn the CPAP in one group and continued the CPAP in another group. They have seen that after withdrawal of the CPAP, that is giving subtherapeutic CPAP in one group, there is increase in AHI within 1 night of stoppage. You can see increase in AHI and increase in oxygen desaturation and worsening of blood pressure and heart rate and increased urinary catecholamines. So even this study highlights the profound importance of adherence to the treatment. That is, even skipping a CPAP for 1 day is known to have getting back our OSA back. Coming to risk factors for non-adherence, there are a lot of, it is usually multifactorial. Coming to patient-related risk factors, basically they don't understand the importance of therapy. Then with patients with low socioeconomic status, alcohol use, physical limitation, those who are tied to use, younger age, those who have smaller nasal volumes, those who have comorbid insomnia tend to non-adhere to therapy more. And coming to therapy-related, the cost is a major issue in our country. and the patients who have high residual UHA are more likely to be non-adherent after usage of CPAP. There are problems with the first night use. That is, if those patients who feel better in the first night of CPAP usually have longer adherence, and a lack of troubleshooting and having device-related complications also have linked to non-adherence. And moreover, there's a part to play in health professional also, because of we need to educate them well, unwilling to educate the patient, poor counseling, and when physician himself or herself express the doubt regarding the therapeutic potential, then that patient is going to non-adhere. Coming to disease characters which which are linked to adherence, we all know that severity of OSA with a higher AHA more than 30 has a positive correlation with adherence. That is, patients who have severe OSA are more likely to adhere. However, this effect is not consistent across various studies. The more consistent parameter is subject to sleepiness. Those who have more sleepiness, they are more likely to adhere to the therapy. ESS at the time of diagnosis more than 10 is shown to be an independent predictor of long-term CPAP use. And initial exposure to CPAP and psychosocial factors also play a crucial role in maintaining adherence. Those who underwent attended PSG and in-laboratory CPAP titration tend to have better CPAP compliance. And those who have benefit, as I said previously, during first night of use is very important. And there a lot of psychosocial factor also will link to adherence. That is, individuals who cope up with challenging situations, who are motivated towards health behavior, those who have positive perceptions regarding CPAP use and better social support tend to adhere better. Coming to adherence in India, this is an Indian study done from AIMS Bhopal, where they have shown that in 79 subjects, the adherence rate is around 30%. That is, 70% of the patients did not use CPAP or non-adherent. The major factor which were responsible for non-adherence is cost in our country. That is, enabled to buy CPAP and financial constraints are the main reason what people in our country are not using CPAP. However, the adherence rates are higher among the buyers, and patient behavior and attitude are important in our country, where they are not at all they are willing to use CPAP and they don't believe that CPAP works. Coming to how to evaluate non-adherence, first 2 weeks of initiation is crucial, and we need to follow them up for non-adherence in the first 15 days. And every visit thereafter, and it can be done by in-person visits, telephone or telehealth counters. At every visit, we need to check for the efficacy of the CPAP use, troubleshoot the CPAP problems, and encourage and reinforce them for using CPAP. Coming to measurement of non-adherence, we need to, previously there were self-reported measures with diaries and verbal recall. However, right now we have microprocessor chips which define the objective measures for there in current CPAP machines. However, subjective measurements usually tend to overestimate the CPAP use by at least an hour. So currently we need to take objective parameters in defining the adherence. How to check the adherence? This is a CPAP download report which we usually see at the follow-up after using a CPAP machine. Initially we need to confirm the non-adherence. We need to check the duration of CPAP use. In this we get the number of days where patient is using more than 4 hours and the average use. And how first we need to check the duration of CPAP use and confirm the non-adherence. Then we need to check the what pressure is set and whether additional settings like EPR is being used. And we will get a clue based on the therapy also, where we can identify the air leak and AHI flow. These are two parameters we can suggest the factors for non-adherence also. If the patient is having more air leak, then we need to check for the mask discomfort and mask fit, or whether the patient is breathing through mouth, whether we need to change the interface or not. We'll get to an idea based on the assessment of the air leak. Coming to events per hour, this is the AHI flow, that is the events measured by the algorithm in the CPAP machine. There we'll get whether the patient is getting benefit from the CPAP, whether there is any residual AHI which is responsible for non-adherence. So how to improve the adherence? There are a lot of interventions required, starting from behavioral interventions, motivational enhancement, troubleshooting the problems, medical and surgical therapies. So the most evidence-based intervention to improve the adherence is behavioral interventions. These behavioral interventions should be started before prescribing a CPAP machine during the first month and throughout. This includes videos of usage, benefits of CPAP, electronic information, relaxation techniques, mask fitting sessions, and involvement of bed partner. And we need to encourage and motivate the patients at each visit during the follow-up, either through person or telephone use. And you need to resolve the perceptions and behaviors and assist the patients. This can be done by nurses or trained psychologists. And the other main thing is troubleshooting. Early troubleshooting of side effects within the first few days to 2 weeks is known to improve the CPAP adherence and increase the comfort and self-efficacy. Main thing in troubleshooting is we need to choose the interface which suits the patient well. These are the 3 common interfaces which are available in our country, that is nasal mask, oronasal mask and nasal pillows. Nasal mask and nasal pillows are the initial preferred interface because they require lesser pressure, they are more tolerant, the patient will have better sleep quality, high REM sleep with nasal mask. Oronasal mask will carry higher pressures and they are less tolerant as compared to nasal mask. Coming to best mask is that one that patient will use and which will suit for him. Nasal mask and nasal pillows should be the initial choice of interface, and oronasal mask should be prescribed only when nasal masks are not tolerated or there is persistent mouth leak. There is a caution that pressure requirements may vary with the type of interface. It is standard that oronasal mask requires higher pressures as compared to nasal pressures. Coming to addressing the air leaks, usually when we see a CPAP download report, we'll have the 95th percentile, the amount of air leaking through the mask. If it is a large air leak, we need to check the proper fit of the mask. We need to, whether it is snugly fit or it's comfortable or not, or we need to change the interface sometimes to improve the mask fit. When the patient is a mouth breather, we can try a chin strapping along with the nasal mask, which will keep the mouth closed during the therapy. Or if the patient is not improving with this, we can change to oronasal masks. There are other mask related issues which we need to address. First thing is claustrophobia. This claustrophobia is more with the oronasal mask and less with the nasal pillows. In such patients, we may counsel them properly. There are relaxation techniques, positive reinforcement, and we can use a trial of mask desensitization where we apply the mask when he is awake, starting with the low pressures and having a graded exposure to the pressures. Like in a PAP-NAP trial, we can try to improve anxiety and claustrophobia. Snugly fit and proper cushioning is important to avoid facial discomfort and pressure ulcers. The next other than the mask related issues, pressure intolerance is the main complaint which we need to troubleshoot. The first thing we do for pressure intolerance is expiratory pressure relief, where we reduce the pressure. There is a setting called expiratory pressure relief or C-flex, where the pressure will be reduced by 3 to 5 centimeters at the initial part of expiration, and it will gradually increase so that patient can exhale comfortably against the pressure with this setting. The other feature is using a pressure ramp. In the pressure ramp, usually we start with a lower pressure at the onset of sleep and gradually increase the pressure to the therapeutic level in the next 30 to 45 minutes as set by the prescriber, so that patient will get adapted to the pressure during the initial sleep, and he will tolerate the pressure, therapeutic pressure better. The other thing we can do when he is not tolerating pressure is switching to auto CPAP if the patient does not have any comorbid conditions, where the mean pressure delivered will be very low as compared to CPAP, and it fixed CPAP, and the pressure will be fluctuating according to the requirement. Coming to nasal problems are more common. Nasal dryness, epistaxis and pain, which can be reduced with usage of heated humidification. This heated humidification will improve the adherence in patients with nasal dryness. Even the patient is having nasal congestion, we can try topical nasal steroids, antihistaminics or oral antihistaminics. There are other side effects of CPAP also due to pressure and mask fit, ocular and ear, that is conjunctival hyperemia, ocular irritation, middle ear pain, and facial hypoplasias when we use the CPAP therapy in children. This can be improved with a proper mask fit, artificial tears and humidification. Coming to aerophagy, which is more commonly seen with the oronasal mask, where we can switch the patient to nasal pillows or nasal mask, or use a auto pressure device, or allow the patient to sleep in left lateral decubitus position to reduce the aerophagy. There are other many complications, minor complications, which has to be addressed accordingly. That include infectious complications, device noise, cosmetic issues and headgear placement difficulty. Coming to pharmacological therapy to increase the adherence, this is not routinely used because they have greater side effects and conflicting data. Only it should be used as a last resort to improve the adherence. There is some evidence with the usage of non-benzodiazepine sedative hypnotics. The most studied drug is ezopiclone, zolpidem, zaloplan, where initiation and usage of these drugs for the initial 2 weeks of therapy is known to improve the adherence. Coming to surgical therapy can improve adherence in patients who have high nasal resistance, which is responsible for CPAP failure. In patients who have nasal obstruction, septal deviation, and inferior turbinate hypertrophy, we can do a nasal surgery so that they can have good adherence with the CPAP. Coming to take-home points from this adherence lecture is at least 4 hours per night for at least 70% of the nights is arbitrary cutoff used to define adherence. More the usage, the better clinical outcomes we will see. Inability to buy the device due to financial constraints is a major cause of non-adherence in our country. The only evidence-based intervention to improve the adherence is educational and behavioral therapy during the CPAP use. Nasal mask and nasal pillows are the initial interface choice. And troubleshooting the CPAP side effects will help the patient to improve the adherence. Thank you. This is the advanced lung function assessment workshop which we are conducting in Nizam's Institute of Medical Sciences next Sunday. Those who are interested can register for the workshop.
Thank you, Dr. Rakesh, for your excellent presentation. I'm sorry I didn't introduce him. He's my colleague at NIMS, and he is the go-to person in our institute for any interventional pulmonology, critical care, or sleep. So he's doing an excellent job. He, along with Narinder, they're doing an excellent job in our institute. Coming to the, adherence, that's the definition for the insurance companies. So we should advise patients to sleep for 7 hours per night, and all those 7 hours patient should be using CPAP. So 7 hours, and all 7 days in a week. So that should be the goal for CPAP prescription. And we talked about ramp slowly increase, but some people, especially severe AHI and obese and with DNS, upfront you can give pressures, that optimum pressures. You did not go for ramp, so they tolerate better, they feel better. And pharmacotherapy, you talked about increasing the arousal threshold with zolpidem. Madam was talking about loop gain also. So if there is a high loop gain, again, acetazolamide and oxygen can be the pharmacological management of for better adherence CPAP machines. Yeah. Any question? Yeah, Vijay Kumar sir has a comment or a question.
Just a comment. I think doctor counseling goes a long way for adherence and compliance. We need to spend a lot of time before the sleep study. We need to spend a lot of time after the sleep study, and also constantly keep in touch with the patient who is using the sleep device. And I know a lady doctor who is head of pulmonary critical care in one of the premier institute in the United States, the Baylor. She uses a AutoPAP, and she has tried all the masks, all varieties of interfaces, and she found that the nasal pillows are the best. It suits, and she keeps on advising everybody else. And although you have put ENT as a last, I would say that we should first send the patient to the ENT surgeon to evaluate for any anatomical obstructions like polyps, etc. Because if we advise the device, while there is a severe nasal obstruction which can be remedied, adherence and compliance will come down drastically. And I remember Amitabh Bachchan giving advertisements for tuberculosis and shingles vaccine. And there were suddenly patients who came and said, "Sir, it seems there is a shingles vaccine for diabetics." So it works so well. So I think something like that, We are a country of celebrities. You know, we love celebrities. We die for them. You know, we have seen the news very recently where in Bangalore, the cricket stadium, it happened. So film and cricket celebrities, they should probably roped in for the sleep apnea and things like that. And I think lastly, insurance. I think the government has to cajole them to support CPAP machines, and maybe the companies can give the CPAP machine at EMIs so that it becomes easy for the patient to buy. Thank you.
Thank you, sir. Very well said. Thank you.
So now we move on. Thank you very much for the great lecture, sir. Now the most important topic is coming. It's going to be a panel discussion. The moderator is Dr. Abhishek. He is the Chief of Bariatric Surgery. He would introduce the panelists. And the topic is Insights into Weight Loss for Sleep Apnea. Welcome to Dr. Abhishek, sir. Please take over.
A very good afternoon to all of you, and thank you so much Dr. Vishwanath and his team for giving us this opportunity to conduct this panel discussion. And since morning we have been hearing it's all about the multidisciplinary approach, which matters a lot when we are talking about anything which is related to metabolism. So I think sleep apnea is one of these metabolic problem. It's a constituent of metabolic syndrome. And for that, I would like to welcome my distinguished panel. All of them are very well renowned and they are very expert in their field. So I would like to welcome Dr. Anuj Kapadia. He is a well-known cardiologist, and the way he treats his patient, and in fact, he's referred a lot of patients to me, and we have been coordinating with such scenarios where we have done surgeries for the most difficult ones also. The another one is Dr. Radha. She is the chief of nutritionist, and she's been great help to manage pre-op and post-op diet counseling for all our patients. Then we have Dr. Anand, who is a hepatologist, and we work very closely because mostly our patients who come for bariatric surgery, they have some kind of fatty liver or NFALD. Then we have Dr. Kiran, who is the endocrinologist, and we have been doing few trials together. Then we have Dr. Ram, I'm sorry I can't see with my glasses, who is the chief of physiotherapist, Dr. Ramakrishna. So in my personal experience of last 15 years, what is the best, I want to ask this question to everyone, what is the best compliment you have received from your patient? So I will share my thought because we are running short of time, so I don't want to take a lot of time. So the best compliment I received from one of my patients was this. Look at the big scar he has, and I was expecting after bariatric surgery he would come and say, Doctor, thank you so much, I'm losing weight, everything is great. But what he said, Doctor, you saved my married life, and for the last 15 years, every night my wife will push me out of the bedroom and she would ask me to sleep in the next room, and she would curse me for the whole night for my snoring. So that was something which was different, and I was so happy to hear that I could save his married life, and he was not cursed for being a person who would disturb somebody's sleep. We all know about what is OSA, so I won't take much time. But the important thing here is 85% of people are not diagnosed with sleep apnea. So it is something like depression, wherein you're suffering with a problem, but you're not aware of it, and you take it as part of your life, which is really, really concerning. And when we talk about obstructive sleep apnea, these are the comorbidities or health risks which are associated with sleep apnea. Now, when we talk about obesity and sleep apnea together, these are some important facts. With every 10% weight gain, the apnea-hypopnea index increases with almost 32%. However, if you lose just 10% of excess weight, it will decrease the AHI with 26%. And obviously, obesity is essentially the only reversible risk factor we have with obstructive sleep apnea. We know that sleep apnea can be because of the many reasons, but obesity is the only reversible factor. Now look at this data wherein if your BMI is more than 40, then 1/3 of people will have AHI of more than 15, which is a moderate sleep apnea. And in fact, almost every person who has a BMI of more than 40 has mild to moderate sleep apnea. So what comes first, obesity or sleep apnea? And that's why we are all here to discuss how we are going to manage this problem together. So my first question is for Dr. Radha. How does obesity and dietary habits influence the risk of developing obstructive sleep apnea?
Okay, thank you so much for your question, sir. Dietary habits are the reason for obesity. So you need to correct them to kind of correct the risk factors. What is more important is it's about the diet which you take, a high calorie, low fiber diet which you take that results in putting on weight, and that is what is the risk. But what is essential is trying to understand who these patients are. Not all obese patients have OSA, but it is the metabolically unhealthy patients also have OSA. So BMI is no more an indicator or is a less indicator to say the impact on the body and the organs. It is the body composition which dictates who you are. So we got to know what is the percentage of muscle, what is the percentage of fat in these patients, and more about what is the visceral fat, what is the subcutaneous fat, because most of our populations are at risk for central obesity, and so these are factors which actually dictate the risk of developing sleep apnea. So that's something that we have to relate
we know
to their
that
diet intake.
obesity is an inflammatory state.
Yes, yes.
So do you feel there are certain dietary factors which can reduce or which can increase the inflammation?
Yeah, what is important is, yes, obesity itself is an inflammatory factor. Continuous energy restriction will help in weight reduction. As you said, 5 to 10% weight loss also would bring in a positive change in most of the cardiometabolic factors and even OSA. But important factor in regard to this diet, we have to know what is the kind of diet and when do we take it. These are two components which we have to see. What is the kind of diet? There is a lot of research which says that diets like the Mediterranean diet, diet like the DASH diets do help in weight reduction. So what are these diets? These are diets which have high amount of fruits and vegetables and nuts, which are actually an advantage to kind of reduce weight. And when? So there is a lot of research which tells that time restricted eating can help in reducing the risk of sleep apnea. So these are two things that you can actually follow. But then whatever is the diet, the diet prescription has to be individualized to who we are giving. It's not about just telling about the calorie and protein or whatever fiber and all that, but it has to be a balanced diet for weight reduction, which can be done by a trained dietitian to help the patient.
So whenever we are talking to anyone about lifestyle modification, it's not the problem of motivation, it's a problem of dedication. So something has to be done to keep that dedication alive. So my next question is for our cardiologist. So recent, large-scale studies correlate OSA severity with increased incidence of atrial fibrillation and resistant hypertension. And being a cardiologist, how do you feel that this would influence the screening protocol in your cardiology practice or in general practice?
Yeah, actually, AF is seen in almost 18% of people who have sleep apnea. And I think it's the nocturnal hypoxia that triggers it, in addition to also the sympathetic surge that happens, the hormonal imbalance that happens, the renin-angiotensin system is triggered. So that actually increases the hypertension. Also, because of the hypoxia, there is fibrosis that starts in the left atrium that actually triggers the atrial fibrillation as well. Now, coming to resistant hypertension, actually using a CPAP has shown that patients who are on multiple drugs, including aldactone, it has actually helped in breaking the resistance in the hypertension. And that has actually helped us in scaling down medication. And people who have been on almost all the dietary restrictions, multiple medication, despite which they don't respond, CPAP does help in these patients who have sleep apnea. Now, I don't know how they say that it doesn't affect cardiovascular mortality, but I think it will. I think there are too many confounding factors that are probably there, including drugs, which confound the results. But then there is no way it could not help in reducing cardiovascular mortality. AF also, AF and sleep apnea also actually increases the inflammation. So if you look at the inflammatory markers in these patients, they are high. So we screen them for these patients who are a little obese or even non-obese, who have high risk of higher inflammatory markers. I think it's important that we screen them for sleep apnea and then go forward.
I remember when we were discussing about, you mentioned something about the early morning strokes, which are very common in people who have sleep apnea and atrial fibrillation.
No, I think this is understudied, and it needs a lot of more studies to be done, where early morning strokes, early morning MIs, early morning unstable anginas that come, I think we should screen them for sleep apnea, because the sympathetic surge that happens early morning because of the sleep apnea can actually trigger vascular strokes and CVAs as well.
Okay. So, since we have, because physiotherapy is one of the most ignored, but I think that's the most important branch in our practice, because all our patients, pre-bariatric surgery, we send them to physiotherapy department for rehabilitation. And in fact, what I have observed and what is my experience is, if you prepare them well before any procedure, the recovery is much faster. That is what we call enhanced recovery after surgery. So my question is for you, Dr. Ramakrishnan.
Sure.
What are the latest rehabilitation strategies we have for improving sleep apnea? And that's why we call it, sleep hygiene and improving sleep quality.
So physiotherapy can actually help patients with a mild and moderate sleep apnea. And the modern physiotherapy basically doesn't just concentrate on the airway maintenance, but our focus is more on a holistic approach, and focuses on better quality of sleep, and so that the patient breathes easier. So what we advocate basically is, first is your sleep hygiene. Basically tell the patient about which position to sleep, and basically the screen time, avoid the screen time and caffeine. These are very, very important. Exercise therapy plays a very important role as well. Patients who are obese, they have more chances of apnea. So proper exercise training along with strength training will reduce the severity of, as well as we can also teach them the specific breathing training exercise and breathing retraining, basically to improve their airway patency, to improve the airway patency, sir. So these exercises basically not only improve the patient's health, but also help the patient to sleep better and breathe easier.
So we are in the era of influencers, and unfortunately I see so many non-medical background influencers. So I'm so grateful that Dr. Vishwanath Gela has launched this short videos on YouTube, which I always share with my patient to get rehabilitated before any procedure we plan on them. So next question is for you, Dr. Kiran. How does OSA contribute to insulin resistance, diabetes and metabolic syndrome? But we all know about how weight, diabetes and all these things related, but does it have an impact on sleep apnea also?
Thank you, sir. Thank you for giving me this opportunity to speak on obstructive sleep apnea and obesity in relation with the insulin resistance and diabetes. So usually whenever we see obesity, so we see obesity, diabetes as a similar terms like diabeticity or like that. So obstructive sleep apnea, irrespective of obesity, it can disrupt the metabolic factors. For example, as already we discussed, so it's an inflammatory condition. So OSA, irrespective of obesity, will cause increased inflammatory cytokines. So that nighttime hypoxic spells, so will increase the inflammatory cytokines, will increase the mitochondrial dysfunction and oxidative stress. So apart from this, sympathetic system will be activated, so which will in turn increase the catecholamine excess, so which will act on the insulin receptor at the receptor level and makes the insulin action to get blunted. So that's how this obstructive sleep apnea, because of the inflammatory markers and catecholamine excess, will act at the receptor level for insulin to have its low action. Apart from this, obstructive sleep apnea acts on the ACTH and cortisol axis also, hypothalamic pituitary and cortisol axis. So if you see the cortisol levels in the obstructive sleep apnea people, so there will be around some 12 to 20 generation cycles will be there. Whereas in a normal people, you will not see that many cycles. So obstructive sleep apnea, irrespective of obesity, you will have more cortisol. And this cortisol is responsible for the excess body fat accumulation over the abdomen, that is called as visceral fat, and on the larynx and in the chest. So these things will increase the sleep apnea further. And this abdominal fat, visceral fat, in turn increases the triglycerides, LDL levels, so leading to the metabolic syndrome. And I forgot to tell the catecholamine excess, which is because of the sympathetic activity. So it will increase the gluconeogenesis also. So that gluconeogenesis will increase fasting sugars and diabetes. So these are all the mechanism, interrelated mechanisms between obstructive sleep apnea, obesity, and leading into insulin resistance, diabetes, and metabolic syndrome in turn.
So in human evaluation, the three things have remained same, which are sleep, food, and reproduction. But unfortunately, we have corrupted all of them. And now we feel proud in saying that I sleep just for 2 hours and I'm so hardworking. So that's a wrong message which we are giving to the society. And now we should focus on telling people, in fact, in Japan, people are paid for sleeping. If they sleep on their workplace, nobody asks them a question. But unfortunately, as an Indian, we have been always, it is in our genes that if you sleep more, then it's a bad habit you have. But I want you to spread this message that sleep is one of the most ignored and at the same time most important part of our life. So since we have Dr. Anand, and he has published more than anybody else in the whole house, I believe, and that's why I have this question for you. How is obstructive sleep apnea is linked to liver disorders, and now we have this new term which has come for non-alcoholic fatty liver disease. What is your thought on that?
Thank you, Abhishek. Thank you so much for the kind words. In collaboration with the Pulmonology department, we conducted a small survey on around 300 patients of fatty liver, including both obese and non-obese. And we found that more than grade 2 fatty liver have higher prevalence of OSA. We assessed based on the stop bank score. 60% had score more than 4 and 15% had score more than 6. So quite high prevalent. So if a patient with fatty liver comes to me, I would suggest to undergo a sleep study. And these patients who have OSA in fatty liver, the enzyme levels are pretty high. So if an OSA patient has come to you, we check his LFT. His LFTs will be showing that his AST/ALT is pretty elevated. The relationship between OSA and fatty liver is again related to inflammation, as he said. It is the hormone which drives here, that is hypoxia-induced factors which lead to increase in ischemia and inflammation in the liver. And conversely, the prevalence of the presence of fat in the liver increases the leptin hormone, which causes abnormal distribution of fat in the oropharyngeal area, increasing the risk of OSA. It is bidirectional relationship between OSA and fatty liver. I see a patient of fatty liver, he should be sent to OSA. If a patient of OSA comes to you, check LFT, look for fatty liver.
So in fact, previously we used to say if somebody has fatty liver disease, there are 2 risk factors, obesity and diabetes. But now I think we have to include sleep apnea also. And in fact, as we were discussing, it is the most ignored part. So we should be paying more attention. It's very simple. Just use stop bank questionnaire in your clinical practice and you will be able to diagnose most of the sleep apnea. So as we were discussing about the dietary part, just 10% weight loss can improve the sleep apnea symptoms. So even the 13% weight loss decreases the nasopharyngeal airway collapsibility, and it improves the sleep apnea symptoms. Also, unfortunately, as I was telling you in the history, great eaters and great sleepers can't do great things. That has been fed into our mind, and which I call as a biased. We are biased towards people. So that should come from the clinicians like you to spread the right message to the society. Now, coming back to the lifestyle, this is a very common question which we get from our patient that, I tried everything, I lost weight, I tried Machinini diet, I tried that diet, I tried intermittent fasting, but after a certain time, I don't lose weight no matter how hard I try. And most of them fail to follow the diet plans, whatever we give to them. So my question is for you, Dr. Radha, what is the nutritional strategies which can support and which can improve the sleep quality in individuals who have obese sleep apnea?
See, the answer is something that you already gave. No matter how we talk, how much you talk, what is more important is the patient should follow. So there is a saying which goes that you can take the horse up to the water, but the water has to be had by the horse. So that is what is most important. So the role of giving a diet, making it more balanced in all the macro and the micronutrients is essential to give. But along with that is the counseling. The time that you spend with the patient is most important to convince the patient on why you're giving that kind of diet and how long does it, initially itself you got to tell them that how long it's going to take them to come to an appreciable amount of weight loss. And most of these patients will come to you after they have actually tried on their own. It's like a yo-yo syndrome that they try, but there's some reason they get down and again they gain that weight and then they come to you, and then so you already have to know what are the roadblocks that they faced with their previous strategies, and then how do you address them. So these are all, it's a comprehensive thing that you have to give, and no matter what you do with regard to diet, it needs a little amount of behavioral therapy that is required. And with regards to the diet, we do make an essential component on trying to meet certain amount of foods that would provide especially tryptophan in these set of patients, because that helps in kind of introduction or increase in the production of melatonin, which probably sets the sleep. That's one part, but not the only part. The overall approach is diet with exercise, where you lose weight and then see how it can have an impact.
So we are in the era of 2020 and 60 minutes reel, where instant gratification is more important. So one need to understand that patients should have realistic expectation out of whatever you are advising. They should not feel that things will work within 1 day or 2 days. It's a long-term program. I always give this example. It's like an SIP which you put and you get the return after 20 years.
Now here, can I just add on one thing?
Yeah, please.
I myself was around 89, 90 kilos at one point in time. I used to snore, and I think took my own health for granted at one point in time when we were a little younger than what we are now. Ate whenever, ate whatever. So I started having back pain. I tore my medial meniscus. That's when I realized that some things are not right. And I got onto I did intermittent, I did keto, I did everything, but I think none of them were something which was consistent and sustainable. So I came to a situation where I have now come to things. I finish dinner before 7:30. I eat more protein than carbs, wherever and whenever possible, whatever is available normally and more comfortably available in our Indian scenarios. And I'm able to maintain my weight now, and also exercise probably 1.5 hours a day. So it's not that it's not possible, but just that we need to have something which is more sustainable on a long term, because this is something which we will have to do all our lives. So that's something which we need to do.
Yeah, very true, because no two individuals are same. So things which might work upon you may not work on me. So we have to find our own mojo. What is working best on me? And that's why we tell them to keep trying. That's how things should work. So we'll remain on to you only, and we'll ask this question. So recent, lot of meta-analysis which have come and which says that CPAP therapy reduces blood pressure. You already mentioned about it. So what is the current understanding of its role in primary and secondary prevention of cardiovascular events? So because we are seeing a lot of people who are undiagnosed, no matter how hard, because we have seen a lot of people who never had any cardiovascular event and suddenly something happened, and it is very difficult as a clinician for you to counsel the relatives that what's the reason for that?
Two important things here. One is nocturnal dip of blood pressure, which I think gets blunted in patients with sleep apnea, which once we use CPAP therapy, it helps in restoring the nocturnal dip. Nocturnal dip and also heart rate variability. Both of them actually have been shown to actually be obtended, and both of them are actually predictors of cardiovascular events. So these two things, along with the surge of sympathetic, as we already discussed, the inflammation that actually occurs because of this, will definitely help in reducing cardiovascular events. Basically, I think we need to study it in a very different way by probably removing the confounding variables. We will see when we say that blood pressures, when we reduce by drugs, we reduce cardiovascular events and mortality. When we say that we reduce diabetes or controlled diabetes, it translates to cardiovascular events becoming less. How is it that we cannot reduce cardiovascular events by CPAP? Because CPAP will reduce blood pressure. CPAP will help in controlling diabetes. I have patients where they're off insulin now. They are on only oral hypoglycemics because the insulin resistance is gone. So I think these are things that will definitely help in reducing cardiovascular mortality.
I think speaking of prevention, I think here comes the roles of good quality variables, which can predict your sleep quality, which can continuously monitoring your saturation, how many times you're turning, and all those things.
Absolutely, and I think initially the major problem is in compliance. What I tell my patients is to start using it during the daytime when they're actually watching television, so that they get used to it. Maybe use it for an hour, take it out, so that they slowly start increasing the time which they can use it when their actually mind is diverted. Get used to it, they understand the benefits of it, after which they will automatically turn to it.
These variables, I agree, but sometimes it becomes an obsession to some extent.
It can
you
fire
wear
back.
it and you just, I slept only for 4 hours, my REM sleep is so slow. It's little risky for me.
Yeah, it's not everyone's cup of tea, but it is one of the method one can use to analyze. If the problem is denial. If somebody is denial, they need to have an evidence to understand that okay, they have a problem. So for some people who are gadget freaks, they can use variables to understand how is their sleep quality. So again, coming back to physiotherapy, Dr. Ramakrishnan. In patients who are intolerant, because this is a very common problem and we have been hearing this, the dropout rate is very high with these machines. So are there any rehabilitation, because I have that video clip also, but because of short of time, I'm not going to play that. But we have another session also, I think later on this rehabilitation. So what is your thought on that?
Sir, patients who are intolerant to CPAP, for them physiotherapy offers a sustainable non-invasive solution, sir. So there are many things. First thing is posture therapy, wherein we advise the patients not to sleep supine because the tongue and your soft tissues get pulled up, and that it may cause severity in OSA. Then we have got myofunctional training, which is very, very important. Basically, what we do is we train the airway. We train the muscles to keep the airways open. So the muscles of the upper airways, like the soft palate, the tongue, the pharyngeal dilators, all of the tone of all these muscles are improved by exercises, and they keep the airway open. Along with that, if you couple the breathing retraining as well, which enhances the nasal breathing, so it will make breathing much easier for the patient, sir. And also weight training and also proper diet can also play a very important role, sir.
Okay, thank you so much. Because of short of time, we would like to end this discussion here. If anybody has one question, we can allow just one question. Or else we will end it here. Yes, please go ahead.
Not question, sir, it is comment. It is very pleasant to listen to the perspective. In 2025, bariatric surgeon giving realistic expectations for the patient, a perspective of realistic expectations from the patient and of the patients from the treating team. it's something very pleasant if it comes from the dais. Otherwise, most of the times it feels that everything which is discussed on the stage is completely unrealistic.
I'm glad you came out with these words because in India we are the only center where we have Center for Obesity and Metabolic Therapy, and we, along with a team of multidisciplinary people, we work together to manage obesity, and that's why we are very successful in not only managing difficult situations, but the patients who were denied surgery at different parts, and they came to us and we could help them out. I would like to thank all the panelists. Thank you so much. Yeah, anybody wants to say anything? Yes.
No, just to spread the awareness of OSA in other specialty like ophthalmologists. So we get referral from L.V. Prasad Institute for two conditions. One is if the patient has uveitis, it is TB or sarcoid, go to NIMS. The second thing is if patient has a normal tension glaucoma or a proliferative retinopathy, go to NIMS for OSA. So if you can pick up and treat OSA in this group of patients, if we have prevented blindness, that was, so we have to spread the awareness among the ophthalmologists also for sleep studies.
Yeah, thank you for your kind words. So we are still trying because thanks to Dr. Vishwanath for organizing this event, wherein we want to improve the quality of life in people who have sleep apnea. Thank you so much, all the panelists, and we can continue with the next proceedings.
Apologies for the delay. Thank you for all our panelists for that engaging and insightful discussion. Now moving forward, it is my pleasure to introduce Dr. Tejas Suri. He is a distinguished expert in sleep medicine. Now his talk is on for monitoring CPAP compliance, telehealth tools and techniques. Over to Dr. Tejas Suri. Followed by lunch.
Compliance remotely, telehealth tools and techniques. In this session, we will talk about CPAP compliance, telehealth, the various tools and techniques available for monitoring the CPAP compliance using telehealth, the benefits of remote monitoring or telemonitoring along with the evidence, and the practical considerations for daily usage of these technologies. Now, as all of you know, CPAP is the most efficacious therapy for OSA. But to be effective, it needs to be used every night. What do we mean by CPAP compliance? We say that CPAP compliance is adequate if the patient uses the CPAP device for at least 4 hours a night for 70% of nights. Why is this definition used? It is because the subjective sleepiness, as measured by the Epworth Sleepiness Scale, plateaus beyond 4 hours of nightly usage. But is 4 hours enough? What we have found is that in trials of CPAP for cardiovascular health, we have not found positive results. And this has been to a large extent because CPAP compliance has been less than 4 hours in these trials. When you have CPAP compliance of more than 4 hours, in fact, we have found that the risk of cardiovascular events decreases by 36%. Furthermore, objective measures of sleepiness and memory continue to improve with increasing CPAP usage of 6 hours and 7.5 hours per night respectively. That is why we want that patients should use CPAP for almost the entire night or the complete sleep duration every night. The major limitation of CPAP therapy is that 46% to 83% of the patients remain non-compliant to therapy when we use the 4-hour definition itself. And furthermore, patients tend to overestimate their PAP usage. In fact, we need objective monitoring to actually know how much compliance is actually there, and that is obtained using the PAP data downloads, which can be transmitted wirelessly and through telehealth, and that is what we will talk a bit more about today. Now, before we move on, let us talk about telehealth. Telehealth is defined as the application of telecommunications and digital communication technologies to deliver and facilitate healthcare. And you know, sleep medicine has always been at the forefront of telehealth, being one of the most rapid adopters of telehealth technologies worldwide. And in fact, telehealth has been used for the entire range of clinical services in sleep medicine, from clinical evaluation, diagnosis, therapy initiation, follow-up, and monitoring the CPAP compliance. Among these things, today we will focus upon the telehealth tools and techniques for monitoring CPAP compliance. This monitoring is that of the CPAP usage data or the CPAP downloads. Secondly, based on this monitoring, certain interventions can be implemented to enhance the CPAP compliance also. For example, phone calls or video consultations for personalized care or personalized follow-up. And then we can have web-based applications or mobile applications which alert the patients about their usage and encourages them to use the device. Thirdly, the devices or the softwares which can be used for monitoring the usage of the device can also be used to change the settings of the device. I will talk a little bit more about this. And fourth is CPAP education can be delivered using these telehealth platforms, such as how to use the CPAP correctly, etc. Now, CPAP usage data which we can monitor using telehealth is basically what we get as the CPAP data downloads. And this tells us not just about the CPAP compliance, but can also give us clues regarding the reasons for non-compliance. For example, excessive leaks, residual AHI or events, etc. To access the CPAP usage data, traditionally we have used SD cards or modem, and also we get limited amount of data on the device display window. But nowadays, with the advancement in wireless transmission, we can get this data, in fact an extensive amount of data, in our clinics through telehealth. And how does CPAP actually capture this usage data? The three important things that we get from this usage data is the adherence. So adherence is captured both as the machine on time, which is the duration the machine is on, and the mask on time, that is the duration when the machine detects that the mask has been put on the patient's face and the patient is actually using the machine. Secondly, we get the CPAP effectiveness, which is in the form of residual AHI, and this is detected using the forced oscillation technique. Mind you that arousal and SpO2 is not captured for CPAP effectiveness. So you know that hypopnea definition requires either arousal or desaturation. So the CPAP usage data tends to underestimate the hypopneas. Thirdly, the usage data tells us about the leaks, which can be intentional as well as non-intentional. The intentional leaks are the desirable leaks which have to be there when we use CPAP, and these are basically the leak which occurs through the pores in the vented mask, and they help in generating adequate amount of pressure for the usage of the machine as well as prevent rebreathing. On the other hand, there can be unintentional leaks which reduce the efficacy of therapy. These unintentional leaks happen from the sides of the mask or from an open mouth when you use a nasal mask. How are these CPAP leaks measured? Well, various manufacturers have their own proprietary techniques, and it varies from manufacturer to manufacturer. But what each manufacturer will tell us through the data download is whether the leak is excessive or not. In case of the ResMed devices, the leak is considered excessive if the 95th percentile leak is more than 24 liter per minute for a nasal mask or more than 36 liter per minute for a full face or oronasal mask. In the case of Respironics, you get a data or a readout that what percentage of the night or how much time in the night the patient had excessive leak. Now what you can see here is a curve is a graph, sorry, with pressure on the x-axis and leak on the y-axis. Now, as the pressure which we set on the CPAP increase, as the pressure that we set on the CPAP increases, what we have to see is that the intentional leak, which is represented by this blue line, also increases. But in addition, there may be some unintentional leaks. However, the machine can compensate for these unintentional leaks. But if the unintentional leaks exceed beyond this purple line, then the machine can no longer compensate for these leaks. So when the sum of the intentional and the unintentional leak reaches this yellow zone or a large leak, that is detected as a period of excessive or large leak, and if it is more than 1 hour or more than 5% of the night, then the patient is said to have excessive leak. Now that we know what kind of data we can get for monitoring CPAP compliance as well as the leaks and efficacy, now let us see what is the benefit of remotely monitoring this kind of data. So the benefits are, of course, that we can do interventions to improve the CPAP compliance based on this data. These interventions could involve CPAP or sleep education, where we share educational material with the patient. However, this has not been found to be beneficial in improving CPAP compliance in literature, because patients usually do not change their usage based on knowledge alone. Rather, we have to bring about a perception of benefit in them, which can be done through special forms of counseling like motivational enhancement techniques, which can be done using telephone calls or video consultations. Additionally, telephone calls or video consultations can also be used for troubleshooting or providing personalized advice to the patients regarding improving their CPAP compliance. And in fact, data suggests that telephone calls and video consultations can improve CPAP compliance over the short term of 3 to 6 months, but long-term data is not yet available. Next, wireless transmission of device downloads can also improve compliance, and in fact there are techniques by which we can remotely change the settings of the CPAP device, or we can advise the patient to change masks, etc., or give other interventions, and that can improve the CPAP compliance. Finally, web-based applications have also been found to improve CPAP compliance. Let us look at some of the data. This is a systematic review of 16 RCTs with more than 3,000 patients, and what they found was when they used telemonitoring interventions or telemedicine interventions, they found that there was an increase in the CPAP adherence by 29 minutes per night, and the rate of adherence for more than 4 hours per night improved, and the relative risk for this was 1.09, and it was significant. Next, let us see this interesting study of patient engagement using new technology to improve adherence to positive airway pressure therapy. In this, they studied active patient engagement using mobile or web-based applications like these proprietary algorithms or these proprietary applications which were used. So these devices, these applications, what they will do is they will monitor the patient's usage, and then they will provide the feedback to the patients, give them alerts, as well as help in collaborating with the clinician in giving personalized care. And in more than 1 lakh patients this was studied, and it was found that active patient engagement was associated with more adherence and higher usage per night of CPAP. There is some early evidence from India as well. For example, this study by Haldar et al. From Calcutta, on which we had also written an editorial. They had done a retrospective study of 100 patients, and they had found that they achieved good compliance in 66% of the patients using telemonitoring. And in fact, they reported that some patients improved their compliance after 60 days of use, and they remarked that telemedicine interventions were made. However, we need more prospective studies to comment further on this. Now, coming to practical aspects, this is the kind of information which you will get on your, for example, this is ResMed AirView software. So if you have patients who are on CPAP devices of this particular company, you will get this kind of information. Here you see Each row represents one patient. It will tell what device they have, then the patient's name is blanked out, then how many days they have used it, and average usage, and then you get this kind of single blue or red box for each night of use. So this is like, you can see each night for each patient you get the data. So to make this simple, let us look at this legend. We get a green square if the patient is compliant to the device, red square if patient is non-compliant, which means they have used the device for less than 4 hours, and you get this empty red square if the device is not used that night. Then you can get these horizontal bars. On the lower side, if you get a horizontal bar which is yellow in color, it means high leak. White bar means leak data was not adequately recorded that night. Then if you get this horizontal bar on top, that if it is yellow in color, it means that there were residual events that night, and if it is white, it means that the AHI data was not supported. Ultimately, if you get this green color tick, it means that patient is compliant to therapy over the period of monitoring, whereas a cross means that the compliance conditions were not met. And then you can also know if there is no monitoring on a particular night, or if a device has a fault, you get this kind of a blue caution icon. So now let us look at an example output of this software. So here you can see that 10 patients data has been monitored over 31 days, and here you can see the information from 24th March to 2nd April. So over 10 nights of usage, you can see a snapshot of how 10 patients have been using it, and you can see that 9 out of 10 patients are compliant to therapy, whereas one of them is not and has been using it only 37% of nights. And you can see here that this patient consistently has this yellow bar on top which indicates high leak, and it would help if we can contact or reach out to this patient through a teleconsultation, give them motivational enhancement therapy, see if they have residual leaks or residual AHI, maybe advise them to change their mask, and if nothing works out, you can call the patient in and evaluate them further. Of course, you can troubleshoot using these PAP downloads also. This is an old guideline, so this was based on 2013. So here they say if the patient is not compliant, you can do clinical follow-up. Nowadays, this can be done through telemedicine. Furthermore, if patient is not compliant, you see if there are residual events. Residual events means that you check for mask leaks, and if required, you have to increase the pressure. Finally, you can see if there is a large mask leak, you can encourage the patient to change the mask, or you can bring in the patient to the clinic for fitting. Final word regarding telemedicine, that all of you who are using telemedicine in your practice should be aware of the legal regulations in the particular territory where you are working, and the Indian telemedicine guidelines serve that purpose. So to conclude, CPAP is the best therapy for OSA, but compliance is a major limitation. Telehealth can be used to monitor CPAP compliance remotely. Telemedicine-based interventions such as video consults and app-based engagement can help improve CPAP compliance in the short term, but more data is needed for long-term outcomes. Thank you.
Thank you, Dr. Tejaswari, for your crisp and clear talk on the compliance and telehealth and CPAP monitoring. So, any questions from the audience? So, no questions from the audience. So, Dr. Tejas, so though not related directly to this topic of discussion, so I would like to ask a question about the recent buzz around weight loss, tirzepatide, amounts, or what we commonly call. So on recent FDA approval for tirzepatide in obstructive sleep apnea as one of the indication for starting the treatment. So what's your take on tirzepatide and improvement of sleep apnea in terms of discontinuation of CPAP machines? And so what's your take on that, tirzepatide and CPAP compliance and approval of sleep apnea and discontinuation of CPAP machines, and your experience if you had any?
And for inviting me for this talk, and I really apologize for not being there in person. And as far as tirzepatide is concerned, yes, it's a wonderful addition to the armamentarium that we have for treating OSA. But let me also remind you that tirzepatide does not cure OSA. It only reduces the AHI by around 50%. In some proportion of patient, less than half of the patient, it may lead to resolution of OSA, but in a majority, it will not lead to resolution of OSA. So CPAP is the only therapy which leads to resolution of OSA in most patients, and that remains the first line therapy. But given that CPAP has low compliance, definitely, as I said, tirzepatide is a good addition. But there are 2 or 3 important caveats. First is, of course, that tirzepatide has to be taken indefinitely or potentially for a lifelong period, because when you stop the tirzepatide, then you will have rebound weight gain, and you may also gain fat mass more than muscle mass. So that may actually, over long term, the issues are there. Second thing is cost. If you look at therapy over 5 years, CPAP is a one-time investment which may cost anywhere between 30,000 to 60,000 rupees depending on fixed or automatic, whereas tirzepatide is monthly cost. I'm not sure how much it is, but I'm sure that the 5-year cost will be astronomically higher than what CPAP is. And the third issue is there are a lot of side effects. CPAP is a very safe therapy for people who use it, whereas tirzepatide has GI side effects are very common, and then rare side effects like pancreatitis, retinal hemorrhage, etc., etc. Many side effects are being reported with that.
Thank you.
Dr. Tejas, on CPAP, how much?
Nothing works in a day or a month. For the tirzepatide also, we have, if you do a resistance exercises, you can keep your muscle mass. If you have a good hygiene and habits, hydration, nutrition, exercise, and sleep, good sleep plays a very important role in the management of this CKM, cardiorenal metabolic syndromes. So if you do a good amount of resistant band exercises, you can maintain your muscle mass. At the same time, you can imbibe the benefits of tirzepatide. Tirzepatide definitely in the future, it is going to play a major role in the cardiorenal metabolic syndrome. It is a wonderful drug. It is going to sweep up like anything. That's my just impression. And you have presented in a very beautiful way the telemetry definitely improves the adaptability of the CPAP, which everybody should implement in their hospitals or whatever they. The major drawback for CPAP non-compliance is this thing. So if we can improve them at the home level itself, no need to come back to the hospital and do all these things. It definitely plays a major role where it can improve the outcomes and ultimately get the benefits. Thank you, Teja, for your wonderful presentation. Thank you.
Thank you for your comments, and I fully agree with you that tirzepatide has many other benefits apart from just OSA. So yes, as long as the patient is fully aware of all the risk and benefit, I say it's a good addition that we have for the management.
Dr. Tejas? Dr. Tejas?
Yes, I'm there.
Question for you. 67-year-old male has been using auto PAP with a nasal mask for OSA for the past 1 month. He complains of difficulty in using the PAP device throughout the night. Based on the following wirelessly transmitted data download, which of the following statement is correct? Can you explain this one?
Okay, so although I do not have the photo very clear, but I think since I had only sent you this question, so I think it is the same one, right?
Same.
Yeah. So in this download, as you can see, the patient's compliance is we say compliance if the usage is more than 4 hours on 70% of the night. But in this case, I think it is less than 70% of night patient is using 4 hours. So that is why the patient is not compliant to therapy. So the first option is out. So clearly patient is non-compliant. Now you have to see option B and C. So when you have non-compliance, you may see there may be some clue why patient is non-compliant, and we can know about two things. One is the leak and one is the residual AHI. In this case, the leak, the 95th percentile leak, since this seems to be a ResMed report in that for a nasal mask it is more than 24 or oronasal mask more than 36 means that there is excessive leak. So that seems to be the case here. And the third thing is the residual AHI, I believe, is 13. Am I correct? It's 13.
Yes.
So it is more than 10. So given the fact that both the leak is high as well as the AHI is high, so both option B and C are correct. So the answer becomes option D.
Next. On CPAP, how much residual AHI is accepted?
So generally we want no residual AHI. In fact, that is the good thing about CPAP, that it almost makes the residual AHI less than 5. So that is the ideal, but up till 10 we consider acceptable.
Thank you.
Thank you for the session. So we can close the session here and we can go for lunch.
Thank you.
We'll assemble in 45 minutes in the hall actually. Can I request the faculty to stay back actually? Just Dr. Abhishek Goel. Sorry, please.
Paramjyoti sir, please come on to the dais. Dr. Rakesh Kodati, please come on to the dais.
Hello. Hello.
Yeah. Shivana, ఒకసారి display.
Okay, so just close this. One second.
It's gone.
Just close it. Done. Close it. Thank you.
Change.
Mute here, no? Yeah.
Shivana.
It's okay. Okay. It's like this. Okay.
Done.
That's great. Thank you.
It may take 10 to 15 seconds to connect. It will
Okay.
connect.
Okay.
Shall I disconnect
Sure.
now?
So I'll come when mine is ready.
Done.
panel discussions.
Welcome back. Our next session would be practical insights into enhancing CPAP adherence. It will be a panel discussion. Now invite our moderator, Dr. Ashfaq Hassan sir, to introduce the panelists.
Can you change the slide to the... Okay, sorry, you can carry on. The panelists are there now. So, good afternoon and welcome back. This is a full session, and in spite of the time constraints, we will be trying to shorten it, but don't know how it goes. We have some wonderful panelists here. Most of them have been really, really very close to excellent experts in their own domain, and I don't think they need too much introduction. All the slides have been shown. All right, so please, panelists, I invite you to the dais. Rajiv, Srinivas, Rakesh, Srikar, where is Srikar? Srikar, yes. And Chandan. So let's start. This is going to be a practical discussion, and the thing is that most of the speakers have covered this topic at some point, at some stage, and therefore I request the panelists to be brief and add on their own version of what they feel. So 35 years, standard of care CPAP still counting. Things are, standard of care is actually becoming a better standard of care. However, the discontinuation rate is disconcertingly high, and although adherence is integral to the success of the CPAP, it's necessary to know where we go wrong, and this is precisely where this is heading. So sleep medicine has evolved. Now it's multidimensional, multidisciplinary, and now we are at the intersection. Sleep medicine is at the intersection of a large number of specialties. So we've discussed almost everything, but we are placing a value on personal practical experiences in this discussion in the Indian context. And with this panel of ordinary professionals, we will start the discussion. So I'll start with Dr. Rakesh. We had the discussion about the definition, but let's start. Could you just repeat the definition and how you feel about it? Are you okay with the definition?
Coming to the fixed definition of CPAP adherence, it is usually an arbitrary definition. It is not this thing. Usually the 4 hours per night on an average in usage of more than 70% of the nights is considered to be adherence. Currently, this is taken mostly from the insurance companies in Western countries, where they need to reimburse the CPAP machine based on the adherence. And many clinical studies which have been conducted on the adherence also have taken the same cutoff. So the same cutoff was proposed by AACM, but the amount of benefit we get, it depends on the hours of usage.
Exactly.
This is like a dose-response relationship. Yeah. The more number of hours we use the CPAP, the more clinical outcome benefit we get. Usually for improving sleepiness, at least 4 hours per night is required. So that cutoff seems reasonable for to improve the sleepiness symptoms. But if you want better neurocognitive improvement of memory, maybe long hours, more than 6 hours of usage will be better.
Yeah, thank you. So that's precisely the point, because we have spoken about the Ricatsa trial, but it's important to note that these people took the cutoff from the insurance companies and then started. So this 4 hours is no gold standard, and you have to aim for higher. Now, staying with you, Rakesh, when does one suspect non-adherence in the pulmonary clinic? Does one specifically look for it when the patient manifests certain problems, or is it uncovered systematically by following some kind of a checklist or SOP whenever the patient presents for a review? How would you go about it?
Usually when we prescribe a CPAP, we usually call the patient after 2 to 3 weeks for a follow-up to check for the adherence. It is routinely, we need to check at every follow-up visit, either by person-to-person contact or telemonitoring or by telecommunication. So we need to interview the patient regarding the usage of CPAP first of all, whether he is having any complaints regarding the usage, whether there is any symptoms of OSA persisting, to check for the efficacy and adherence. We need to interview the patient at the follow-up visit.
So let's say you have a patient and he's not adherent. Do you use some kind of a checklist? Do we find it somewhere online or do we create it ourselves?
There is no, as of I am aware, there is no checklist to check for adherence. We need to review the symptoms, whether there is persistent sleepiness and early morning headaches, whatever the symptoms he had previously before starting CPAP, we need to check with that. And moreover, we also check for the CPAP download summary when we call the patient at the back to check for adherence.
Okay, thank you. We'll come to that. So Rajiv is up next, and I'm asking this question is that a while ago we did a study of consecutive patients for sleep apnea and cardiac failure, and then we had to stop and restart the study because even in patients with cardiac failure, those patients who are obese and snorers are more likely to be selected for CPAP PSG studies than our patients who have congestive cardiac failure or cardiac failure of any sort, and then who are more likely to have central sleep apnea. So I just want a brief answer from Rajiv here. What is the ratio, approximate ratio of OSA to CSA in your practice?
Yeah, if you look at the overall population, I think the CSA is very, very less. But primarily, if we are...
We can barely hear, but if you hold it closer, I think you can.
This is better, yeah. So overall, if we look at in cardiology practice, because still the commonest reason why we advise sleep study is in patients with uncontrolled hypertension or arrhythmia. So if you take the entire population, the central sleep apnea, I think practically we don't see. But if you look at heart failure patients, then yes, probably about nearly 40% of the patients whom we send for a sleep study, we do get a central sleep apnea. But there is a caveat here. Most of the times, these patients get their sleep study at home. So the number of patients who actually get a proper sleep study in the hospital are very less. That might be one of the main reasons why we significantly underestimate the CS.
Excellent, excellent. So 40% is the number that I think we should remember. So I just want to ask Dr. Rajiv, let's say a colleague of yours picks up an arrhythmia, maybe atrial fibrillation, sends the patient to your OPD. Patient is slightly overweight, history of snoring is there, but not too bad. Now, what would you do in such circumstances? How aggressively would you pursue a diagnosis of obstructive sleep apnea in the context of an arrhythmia, or even context of a resistant hypertension in a non-obese patient who is not in heart failure? And then after that, let's come to the adherence part after this.
A single line answer would be we are obsessed with sleep apnea, because the more we try to find, the more we get. And the type of dramatic response which we see with giving a proper treatment, contrary to what the literature says, we need to really see to believe it. Actually today I think in our hospital, the maximum referrals for a sleep study and CPAP goes from cardiology department. The reason for that is all the myths of somebody being obese, somebody complaining of snoring, somebody complaining of daytime somnolence, none of those matter. They may not have anything, but still have a significant sleep apnea.
Yeah.
And that's the reason why the threshold to do a sleep study, it is a simple study. The patient is not going to land into any trouble by doing a sleep study. A simple study, but can make a significant difference as far as the management is concerned. You're dealing with resistant hypertension, which might land up with end organ damage, versus somebody who puts a CPAP machine and then gets a perfect control of blood pressure.
Yeah.
So our threshold is very low, and none of the criteria which is generally thought of, we don't take that into consideration. So wherever we feel that it's not fitting into a pattern, then always we make sure that sleep study is part of the evaluation to make sure sleep apnea is not the cause of that particular abnormality.
So excellent. So you mean to say that somebody who comes with resistant hypertension, you have no renal artery stenosis or nothing else to explain, you would probably have a very low threshold for doing a polysomnography there?
I'll give a simple example. Say a patient has an atrial septal defect, and then he has pulmonary artery hypertension, and he has been told that the patient has to be worked up for a heart-lung transplant. you just do a sleep study and patient has severe sleep apnea.
Right.
You start the patient on CPAP, get him back after probably 1 to 3 months, and the PA pressures come down, and you just put a simple device.
Yeah.
And from someone who is looking at heart-lung transplant, here is a person who is normal because after the device, there's no pH, there's no AST left, and patient has become totally normal. And these are live examples. These are patients whom we have seen and who have become totally all right. So by missing that sleep apnea, you are like condemning them to a kind of treatment which is probably beyond their means.
Yeah, I thoroughly agree, because today's experience is tomorrow's guidelines, and even though we may be going slightly beyond the guidelines, I think we are well justified given that the logic is very, very sound, and the point has been made earlier in the day. So I'll come to Dr. Chandan. First, I mean, the commonest cause of non-adherence in your practice, and I probably didn't agree with the point that was made that expense. You know, you haven't started the CPAP because of the expense, so you can't say it's non-adherence. So how would you say, what is the commonest cause of non-adherence?
So what we need to understand is, sir, the factors for any kind of medical therapy, let alone be the CPAP therapy, leading to non-adherence are typically multifactorial. So like low socioeconomic status is a well-established factor for considering the low financial backgrounds. And again, there is also a study where they have shown that biphasic effect is seen in CPAP usage. Younger individuals, though they easily get adjusted to CPAP, but then the adherence over the time gets declined because irregular bedtime schedules, work schedules, excess work schedules, and also the extremes of ages, like elderly ages after the 7 decades, 70 plus age, mainly because of their chronic insomnias, they tend to be less adherent. So these are some factors.
So basically what you're trying to do is you're looking at the patient and you're trying to predict, it's difficult, but you're trying to predict that this guy may or may not be compliant. What about psychosocial profile?
Yes, sir. So like under pre-existing some psychiatric conditions like depression, anxiety, or history of claustrophobia, negative beliefs, they also are the predictors which may tell us that the patient may be non-adherent.
Okay. So how can adherence be measured, Dr. Chandan? I mean, do you use any self-reporting strategies like diaries, or just ask them for verbal recall? And how effective are these self-reported parameters?
So coming to this adherence measurements, so the subjective measurements, like as you told, the verbal recalls during the patient visits and the patient diaries wherein they note down the number of days of usage of CPAP, they are usually prone to errors, or they are more biased. The current gold standard way to measure the CPAP therapy is all these modern PAP devices come equipped with SD cards or the memory cards wherein every data, the hours of usage of CPAP, the pressure, the RAM time, everything is recorded. So they come up with a compliance report. And the earlier talk by Dr. Tejas Suri, we also have a cloud-based monitoring system like AirView.
Yeah, so things are getting better. There was a paper about 20 years ago where these SD cards were there, but they found that there was absolutely no difference between the verbal soft indicators and the hard indicators. But of course, we've come a long way since that time. So Srinivas, I'm asking a very elementary question. It's not really worth your expertise to ask that, but this is a very, very common problem that we see. And how often do you see this problem in your practice?
So dry mouths and runny noses are extremely common. In fact, there are studies that said that for people who have nasal symptoms and for those you have given CPAP, within 1 year, their symptom score gets worse.
Yeah.
And for patients who do not have symptoms of any nasal symptoms, by the end of 2 years, they develop nasal symptoms post CPAP therapy. So this is not good for us, especially because we are speaking about how good the nasal masks are, and nasal masks need to be promoted. Because if these patients are having dry mouths, it's basically telling us that he's a mouth breather or she's a mouth breather. And once there is a dry mouth, the surface tension goes down, and obviously it's getting dry. And what also happens when you are a mouth breather is the tongue is not sitting higher up in the oral cavity where it needs to sit, which does tend to go down and cause problems.
So basically, it's not a kind of a reflexive treatment. You have running nose or a blocked nose, and you put a humidifier and maybe
And another thing which I will also talk in my talk is when you talk about running noses, you would be surprised. It's not allergic rhinitis symptoms patients that are more symptomatic. It is the non-allergic vasomotor rhinitis patients who are the more problematic ones.
Yeah. But at the same time, a steroid spray still works.
We will talk about that.
Okay, so this is for you. While you're talking about the nose, it's like it's a paradox because those patients who get these mask-related side effects are those people who use CPAP regularly. So that's kind of a paradox there. But nasal resistance, as he just said, affects CPAP use, and the initial acceptance of the device is obviously dependent on that. So I want to know from Dr. Srinivas, at the inception, does he do anything about this preemptive thing about the nasal resistance? And how does the dice roll?
So I think it's very important that the moment the patient walks into the clinic, and like how this morning Dr. Abhishek was talking about the Malampatti grading and the facial profile. In fact, as he's walking, and those of us who've been in this, you can tell the moment you see that patient that there is something wrong with him, the face, the body silhouette, so on and so forth. So most of us as ENTs have also become very luminal. And what happens is the moment the patient comes in, we tend to put our scopes in. And what we miss is the effect of the collapse of the external nasal valve and the internal nasal valve. And as we were also talking, allergic rhinitis and non-allergic rhinitis are fairly common comorbidities. So these patients every time he's sniffing, his nasal valve is collapsing. So obviously, that's a static obstruction right there. The second thing is to look at gross septal deviations, because again, there is a lot of data saying that any kind of static obstruction reduces adherence. Then you go down, look at adenoids. Nowadays, we're seeing a lot of adults with adenoids because of bad, again, it's a lifestyle problem, reflux. Again, chicken and egg story, whether the apnea caused the reflux or the reflux caused the apnea. Then going down, tonsils, and more often than not, lingual tonsil hypertrophy. So that's the algorithm that we follow. But what is very important is clinical judgment. Look at the patient, look at the skeletal profile, and then proceed.
Okay, so I dare say you'll be talking about DICE a little later on,
Yes.
so I'll leave it alone at this point of time. Srikar, this is a very difficult question because I'm asking you to summarize something that can't be covered even in one lecture. So we can obviously realize that there's a significant spillover of troubleshooting into the issues impacting adherence, and it's essential to match the machine and the interface to the patient. So here, how can we practically apply all the principles that we've learned in the previous lectures?
Yes. So the thing is, the machine basically, this is not the right term to use. It doesn't have a brain of its own. It's just going to deliver its flow. So it is up to us to check from the machine to the mask interface that whether all these are in a perfect synchrony so that the patient can experience the maximum benefits, failing which non-adherence is going to creep in. So as far as the machine settings are concerned, most of the time, I don't know how many centers would strictly adhere to a diagnostic and then the next trial-based sleep studies. So given that into consideration, most of the practitioners probably just prescribe an auto CPAP with a wide range of pressures. So that probably would kind of curb down the pressure effect. If I give a fixed CPAP machine, then I have to look at two things. The patient may not feel comfortable if I start him off on 10 CPAP, then I'll probably utilize a ramp protocol. So wherein the machine starts off with 2 or 3 and then steps up the pressure to 10 ultimately after the patient has fallen asleep. And if he says that I'm having a difficulty, I feel that when I'm trying to exhale, the machine is delivering air to my nose. So then we can use the expiratory relief maneuvers, which would lower the pressures to some extent. Moreover, the problem comes with leakage because this is one time in the night. Let's say the patient has fallen asleep at 10 p.m. and at 3 a.m. the mask has slipped off, or he had to visit the washroom, put the mask back on. He didn't do a good job at that. So leakages cannot be sensed by the machine. We do have AHI flow, but the machine is going to deliver a disproportionately higher tidal volume to compensate for it. So these are some of the factors which can contribute to this patient and machine mismatch, which we have to look for.
Excellent, because the point was made about the amount of leakage that the machine could handle, but beyond that, actually you could have a bit of dyssynchrony if the leakage extends beyond the capacity of the machine to compensate. So also the point was made earlier in the day about the machine on time and the mask on time. But nowadays these machines are getting cleverer and cleverer, and unless you put the mask on, the machine won't start counting in your compliance score. So I suppose that question will become redundant in the next couple of years. So Srikhar, this is again a very long question, but some patients say they can't breathe with the nasal or orofacial mask on. So is there any physical thing that you check for first before you dismiss it as claustrophobia?
So we'll give the choice, because the mask or faces does not obey the one size fits all, just like how we see for the inhalers. Some are comfortable with dry powder or this. So we'll probably give them a different option. It's more of a cafeteria approach. If I say he cannot tolerate an oronasal mask, and of course taking into consideration what sir has just mentioned, Srinivas sir, that those who are mouth breathers, we have an option of a full face mask, or then a nasal pillows would not be good. So first is, though we start off with nasal pillows or we start with an oronasal interface, we'd probably have to check on that aspect. Then going on to the mechanics part, is the mask fitting him properly? Does he have to disproportionately tighten one or two straps so that there's no air leak? So coming to that, we have further innovations wherein we can use a softer gel forms. We have breathing masks, which can incorporate a mesh fiber so that there is adequate movement, passive movement of air too, so that the patient doesn't feel claustrophobic. Then the other option would be to probably once again combining the mask and the machine interface. So we can just look whether it is the mask which is a problem or is the machine which is causing the intolerance problem.
It's a mask that is too loose will leak. It's a no-brainer. But a mask that is too tight also will leak. So you just have to be able to place two fingers under the strap, and of course these things are getting. I just want to ask you one question before I finish. Do you use a humidifier right from the start, or you wait for a patient to complain before you start a humidifier?
So more than 50% didn't ask for a humidifier, so we just give them that option. We tell them some of the probable side effects, saying that if at all you do apply, have a dry mouth, or do you have a runny nose or a blocked nose, then you come over to us, and based on that we can go for the next step.
So thank you, Dr. Srikhar. Dr. Rakesh, we've learned something about this in the past, just recent talk, but I just want to know how can we infer the commonly the causes of non-adherence, the common causes, from the currently available CPAP parameters, the outputs?
First of all, when the patient comes for a follow-up, we check for the CPAP report downloads. We first confirm the adherence pattern of that patient. When non-adherence is confirmed, we will check the pressure at which he is using, and we'll also check the parameters like residual AHI and amount of air leak through the mask. And if the patient is having higher air leak, then we will ask the patient regarding the mouth breathing pattern, or whether he is intentionally removing the mask, or any breaks in his therapy. Then if there is a significant amount of air leak, then we will correct the a cause for the air leak. We adjust the mask, change the interface, or if he is a significant mouth breathing is still persistent on a nasal mask, we switch over to oronasal mask. That we can do if there is an air leak. If there is a residual AHI, then we need to see if it is causing the adherence, or adherence it is due to lack of adherence. There is residual AHI. It can be bidirectional, which is contributing. We need to check whether there is a residual AHI or it is a non-adherence causing residual AHI.
Okay, so 10 was the magic figure. But let's say a patient with a nasal CPAP gets an air, you see a lot of air leak. Would you first go for something like a chin strap, or then go for a orofacial mask?
First thing, better to try a the chin strap is first preferred. If they are not tolerating or the air leak is still present, then we can switch over to oronasal mask.
Okay, thank you. So Dr. Rajiv, another big paradox here. I'm hurrying through a little bit because of the time pressure. People who have more severe heart failure have actually less severe OSA, and it's been seen in several studies. So although this, of course, this rationale doesn't hold good for CSA. So this is a really tough one. How would you first get an inkling that a patient with CSA is not adherent to treatment?
Again, the clinical response is extremely important. Generally, when the patient has CSA and you have started him on CPAP, when the patient comes back, they say they feel different. They are totally different personality. Their irritability has come down. They feel much more comfortable. Their breathlessness has come down. All the parameters look much better, and there is a brightness on their face.
Oh, yeah.
The fact that there is no change, say you have given enough time, around 3-4 weeks, and the patient comes back, and they say there is no change, the only reason for that is that they are non-adherent. And usually most of the times the person who is accompanying that patient will tell us that yes, this is the reason he is not adherent for whatever the cause of non-adherence. But the clinical response is amazing. The moment they are adherent with CPAP, the way they feel, the way they respond is quite amazing. So that's the clinical picture of the patient is gives us a clue whether he is adherent or not.
Very well articulated, and as you know, man is the only animal that can articulate, and that's the reason a single tube is meant for articulation, for breathing, swallowing, and that's why we run into so many problems with the airway, upper airway. And I want to ask Rajiv, now almost everyone is wearing, you're wearing Meta, right? You're wearing
yeah, actually I got a ring also. And,
okay. And Apple Watch. Apple Watch too?
Yeah. And the reason, but before anyone starts using the ring, just a word of caution, put it on the index finger so that there is no marital discord. But yeah, regarding digital rings, it's just amazing. And though now we still don't have literature to say that this is going to replace some of our management decisions, but the way they are evolving, the way AI is evolving, and this is going to get fully integrated with AI, and the way it is evolving, I don't think in any distant, near future, we are going to have everything which will be dependent on what the ring says or what the watch says. Every day morning it will tell you that, okay, this was your oxygen saturation, this was your non-adherence, this was your adherence, go and meet Dr. Ashwak or whatever. So everything will be on your phone. So
fantastic.
This is an amazing technology.
Fantastic. So last question to you, Rajiv. In person on a pacing device, do you consciously look for metal clips in the...
No, actually not.
No.
Because generally, even if you take the mobiles, it's basically the electromagnetic interference. So anything which is more than about 6 inches, 5 to 6 inches should be safe.
Yeah.
So the pacemaker is somewhere here and the mask is somewhere there, so it doesn't
Fantastic.
matter.
Great.
So we can just forget about it.
Thank you. Last couple of questions, Dr. Chandan. Yes. The relevance of this question is that do we need to consistently monitor for non-adherence with the same degree of vigilance, or is high intensity monitoring only required in the first few weeks? And by the same token, how important is the first night on the machine?
Studies have shown that there is something called as golden window, sir. So first 2 weeks of adherence is very important. So people who are particularly using CPAP on a correct duration for the first 2 weeks are found to be adherent towards after 3 months also. So first 2 weeks is very important for us. So once they cross this initial 2 weeks and they are adherent till the 3 months period, after that we can be less vigilant for the...
Perfect. So, and also the first night is very important to monitor the patient when the patient is using. Great. And another difficult question for Dr. Srinivas. I know he doesn't want to show his hand. You know, he's going to line up everything for his next talk. But see, the thing is, when you're operating a patient for OSA, you're looking for a cure. But how many times are you trying to make things easy so that a subsequent CPAP can actually do its job well?
So, like the mantra goes in the management of sleep apnea. As of right now, there is nothing that can cure sleep apnea. Yeah. We are managing it like any other chronic disease.
Perfect.
So, yes, if you are talking from a very bad static standpoint, supposing we see huge adenoids, a young patient, huge adenoids, huge tonsils, an epiglottic collapse, yes, that will definitely bring a smile to my face. That is the ideal condition, but it's not about ideal conditions. Patient doesn't come with a nice sticker on his forehead that I am an ideal patient. So we will have to try to see how to improve his quality of life, because patient-reported outcome measures are also very important. Two, to try and see how from a disease standpoint we can improve it. So I think the question is excellent and very relative. So curative, I think that kind of thing is for very, very selected patients. Yes, we have seen such magic happen, but it's not the rule.
So let me just reframe it. What percentage of your patients would require CPAP after surgery? I know it varies from surgery to surgery and patient to patient, but so ballpark.
I would still say about 50%.
50%, okay, great. That's a good answer. And would you compulsorily, I mean now as a matter of course, recommend myofunctional therapy for every patient?
It's like anything. I mean, you do a joint replacement, you do physiotherapy. You do anything, you are doing physiotherapy. Myofunctional therapy is, I think, has to be said in the same breath in terms of when you say management, that unless you do myofunctional therapy, there is nothing that you are really doing in terms of managing it in long term.
Sure. Great. So, yeah, I'm done. Last question to Dr. Srikhar, otherwise he'll feel left out. He had very little to talk about. So, actually, I think it was Anuj who was persistently making the point, and to him it applies that absence of evidence is not evidence of absence, because he was talking about cardiovascular disease and then we were also talking about auto CPAP versus manual CPAP, and the fact that the auto CPAP doesn't compare. But there is not much evidence about auto CPAP. It's not that it's not going to work. So I want you to just make a philosophical comment about the technology of today and where are we heading tomorrow.
So the technological advance, apart from providing better therapy, it would be to ensure adherence and to make it more comfortable for the patient as far as monitoring on administered therapy is concerned. So here, if you go at different levels, whether it is utilization of a better fitting mask, as we had just talked about breathable masks, to a more better monitoring system, like maybe using AirView or CloudSync for practical telemetry purpose. But there is one little catch here. If a patient is anxious or is depressed, not all the patients want to share their data. So though telemetry is a big tick mark for all of us, not all patients are happy with it. They do not want their therapist to say, I mean, he comes and says, I used it all month, but the therapist says that, hey, you didn't use it for 10 days in a month. So patients are not going to be liking the reprimanding note of the therapist. So this is the only catch here.
Thank you. Yes.
Yeah.
Please.
So other than that, there are AI apps, there are machine learning apps which are in the pipeline, but the problem is we'll have to get in sufficient number of patients to train the app to give us a better interpretation. So apart from ensuring adherence, it is like passing on, suggestions. So this is one aspect which is slowly coming into the pipeline. So saying that, okay, you're not used, or your machine is not really working, or please consult your therapist, the problem is not with the machine. Right. So these are new technologies which are still coming.
Fantastic. Point well made. And I'm going to skip the summary because for constraints of time. I'll leave you with this slide, painting by John William Waterhouse. These are the sons of Nyx or night. These are the night sons, NIGHT night. The one on the left is hypnos, sleep, and one on the right is thanatos, death. Sleep and death. So that's how closely related they are. Thank you very much. Thank you. I thank all the panelists, my wonderful, wonderful experts, and my wonderful friends. Thank you so much.
Can I request Dr. Telen Swami sir to come on to the dais? Actually, sir, we would request you to give the moment of appreciation to our panelists and moderator. Dr. Telen Swami sir is senior consultant at Care Banjara Hills, and he's friend of a lot of people, a lot of doctors here actually. Thank you, sir, for coming here.
Good afternoon. Yeah, first of all, congratulations to Dr. Vishwanath and the team of AIG for bringing up such a wonderful conference on this particular topic oriented of sleep apnea. The previous panel discussion actually already discussed about this non-adherence. But of course, non-adherence comes after one starts using that. But how many of them are actually able to start it off? Maybe we should call it non-adaptance to the CPAP machine. In fact, I have a recent personal anecdote about it, wherein my brother, who is otherwise fit, was found to be having severe sleep apnea. He lives in US. He was absolutely unable to get in to use the CPAP itself. To start off itself has become a big issue. Of course, he has a issue related to a bit of allergic rhinosinusitis. So in such situations, how do we go about? Rather, how can we make them use the CPAP and then, of course, getting adhered to that? Let's hear it from our beloved friend, Dr. Srinivas Kishore, who is a renowned ENT surgeon. So let's hear from it. Dr. Srinivas.
Thank you, Dr. Swami. Can I have the presentation, please? Good afternoon, everybody. Can you hear me? Can you hear me? I know it's very tough post-lunch and a Sunday afternoon, but really appreciate the fact that all of you are still here. Speaks a lot about your commitment towards the subject. So kudos to you. My role as somebody who will address CPAP or CPAP non-adherence is very clearly cut out. And in the next 15 minutes or 13 minutes, I think I will try and do some kind of justification to this topic. I might need 5 minutes extra with the help of the, thank you. So dear colleagues, these are the words that we keep using when it comes to management of sleep apnea. Adherence, compliance, compliance, adherence. Some papers say adherence, some papers say compliance. But we all agree today on this platform that the most efficacious treatment, where appropriate, is CPAP. And all of us agree. However, many patients do not use CPAP enough to benefit them, and the adherence rates have remained unchanged in the last 30 years. And these are the papers from where I'm quoting that statement from. So in trials, if you really look, 17 to 71% of patients do not adhere to CPAP. No, it's not that technological transformations have not happened. The technologies have changed so much. But the problem is with the human, the person. Anything that you say you do every single day, the human monkey mind will say, no, I will not do it. So it is not the problem with the technique or the technology or whatever. But the problem here is even once on treatment, an obstacle to good clinical outcomes can result in deleterious consequences. And that is how important managing sleep apnea is. So when you look at literature and try to bring all the causes which have actually caused non-adherence, The first statement is sort of racist actually. You know, it has been shown that Caucasians show better compliance, which probably may have many reasons, and probably I'm waiting for Abhishek to do a paper to see how and why that happens. Socioeconomic status also, but what is very important comes in a very not very distant second point is nasal disease significantly impacts CPAP therapy compliance. Now, if you look at this very nice paper that got published in Sleep Medicine Clinics 2022, they have brought very nicely the best predictors, the conflicting evidence, and not predictive at all of adherence. And again, number 2 is nasal volume. Now, why I'm saying nasal volume is because the nose shouldn't be seen as a septal deviation or a turbinate hypertrophy or a sinus disease. The nose should be seen as a conduit that is taking air, which is the preferred way of air entry into the body. And why that is important, we'll talk a little later. So, if you look at and focus on nasal obstruction per se, like as Dr. Ashfaq was alluding to, 65% of patients will complain of dry nose or mouth in the morning after using CPAP. Sneezing and nasal drip were present in 35%, and nasal congestion is 25%. This word nasal congestion is actually a very sort of a very confusing term. What is congestion? If you really ask your patients, right, each one will give you a different answer. For some, it is blockage, but for some, it's secretion. For some, it's some kind of a vague symptom that they cannot explain. But they'll all come, doc, I'm congested. It doesn't mean anything. So it's again up to you to sort of decipher that particular symptom. So if you look at this very nice paper that came out of Japan, they have looked at the influence of nasal resistance on the initial acceptance of PAP. Now why? Because since morning all of us were talking about the simple fact that that initial experience is the most important experience. Because if the first 2 weeks of that patient's experience with the PAP machine is ruined, then it is highly unlikely that the patient would take up the gold standard treatment. And in some cases, that may be the only treatment that is advised for him. They may not be a good candidates for a mandibular advancing device or surgery for that matter. So it's upon us to make that experience very good, right? So what they have done is they have actually measured nasal resistance, and if you see in the last nasal resistance, acceptance and non-acceptance. So why is nasal resistance so important? That is what comes is a measure of nasal volume, right? So nasal resistance, what we measure with the rhinomanometry, is very important to measure the nasal passage per se, and we'll talk about that a little later. So what about, again, nasal function, long-term adherence, and here if you see, supposing you see nasal complaints in a patient and you advise a procedure, how do you know as a sleep specialist that whatever the ENT has said is correct? Maybe it's not correct, right? How would you know as a non-ENT? So what are the predictors? The first thing is severe nasal congestion of bedtime. If the patient is saying that I do have severe nasal congestion at bedtime, probably it will be a good candidate. Number 2, past history of sinusitis, or when you do a CT scan, a slight or an extensive sinus shadow suggesting that, yeah, maybe this guy, if you send for treatment, will do better. And the last but not the least, total nasal resistance supine, which you measure with a rhinomanometry. Because rhinomanometry is the only objective measure of nasal congestion. Because sometimes the patient will complain that I have a lot of blockage. But when you look into the nose is empty. It's fine, the air is able to go in. Now, these cases are very, very carefully managed. These are red flags. These guys might have a condition called empty nose syndrome. And empty nose syndrome is more of a psychological, psychiatric problem than an actual breathing disorder. So again, objectively measuring nasal resistance is very important for further management. And here is another beautiful paper wherein they have shown adherence and non-adherence. The bigger the septal deviation, the poorer the adherence. So when you talk about managing the nose, and that will bring us to this particular topic of the nasal spray, there are obviously not every case that you will not need to go under the knife, right? There is obviously role for medical management, especially in the realm of allergic rhinitis and non-allergic rhinitis. Non-allergic rhinitis is also very common. In fact, this is actually worse in terms of nasal resistance when it comes to CPAP adherence. So this is a very nice paper from 2009 wherein they found out that heated humidification but not nasal steroid medication decrease the incidence of nasal side effects. And the evidence keeps going on and on in terms of this very nice paper again in 2010, which showed that this is a randomized double-blind placebo-controlled trial for fluticasone propionate. It's 100 micrograms per nasal cavity twice a day. That's a huge volume of steroid spray. How much we give now is 26 micrograms, right? This is a huge volume. Again, fluticasone propionate does not improve CPAP-induced unwanted nasal side effects. Again, another paper, again, where more recently in 2020, fluticasone propionate as a topical steroid did not reduce CPAP-induced side effects. But this is all in patients who do not have allergic rhinitis as a comorbidity. If you have allergic rhinitis as a comorbidity, it does help, right? Now, allergic rhinitis as a comorbidity with sleep apnea is a staggering 60%. Somewhere in the line, they do develop sleep apnea. That, of course, is a different story. So, once you have done medical management, it is very important that you analyze the nasomaxillary complex. And here, dear colleagues, I would like to bring in the concept of the container or contents, right? And it's very important that we actually look at computational fluid dynamics to see where the resistance is happening, right? So in this particular case, this is CFD. You can actually see where the volume is becoming or the air is becoming very turbulent, and you can actually say, okay, this is at the level of the nasopharynx, this is at the level of the oropharynx. Now, what is also important is you need to differentiate whether the problem is because of the container or contents. Does it make a difference or no? It does. Because if the nasal volume is less, even if you empty the nose of turbinates and septum, he will still continue to have a nasal obstruction. So these are patients, examples of patients in whom the container is the problem. Because the roof of the mouth is the floor of the nose. If somebody has a narrow high-arched palate, the nose is also going to be narrow. So in such cases, doing an amazing septoplasty or a turbinoplasty or a nasal valve repair will not help. So it's again up to us as guardians of these patients to look at this pathology. So what happens if there's a high-arched palate? There is no place for the tongue to sit in, and you can see how the tongue falls into the oral cavity, and you can see that this causes obstructions. Now in these patients, obviously measuring the nasal congestion or nasal resistance with rhinomanometry is very important. So the idea here is you need to basically, you need to basically make the container wider, and the idea is to make this. So how do these patients look on CT scans? Do you see any floor of the nose here on CT-PNS? Zero. These noses are like chalices or pears instead of them being a nice equilateral or an isosceles triangle. So look for the floor of the nose. If they are narrow, most probably just doing a nasal procedure will not help. What if the contents are the problem? Then yes, there are many ways to do it to improve adherence. There are very good devices that are available nowadays, radio frequency devices. Another important factor here you need to look at is something called as a septal swell body, also called as the septal turbinate, which actually directs air into the middle meatus. Now we know from computational fluid dynamics studies, I'll need 5 more minutes, that it is the air that goes through the middle meatus which is more important than air that goes into the inferior meatus. So if you have a gross septal turbinate here, it will not be useful if you just sort of take care of the turbinates lower below. So this is a picture of a rhinomanometry, how we do it. Now what we do here is we measure flow to pressure, right? If in this box, if the pressure and flow are there, that means the person is able to put very less pressure to get in more flow. That is ideal. But in this case, what is happening? The pressure is so much, but no air is going through the left nostril, whereas on the right nostril, it is good enough. So you can measure it. So normal value is 0.5. On the left side is 1.44 and on the right side 0.24. So you know objectively that this patient is at this level, and post-treatment you have to measure to see how much improvement that you have made. And I love this picture, okay? This is the algorithm that you have to follow. So once you do the clinical diagnosis, you divide your patients into 2 parts, okay? If the weight is too much, if it's a global problem, straight away weight loss, Manjaro, Wegovy, whatever. If it's a gross dentofacial deformity, involve your maxillofacial colleagues because the management again is a little different. If there is a abnormality there, and if you do see that it's a soft tissue problem, you do a drug-induced sleep endoscopy. Based on what is there, you look at the different outcomes that are available. So drug-induced sleep endoscopy is something that we all do for us to identify. So this is the answer to your. So if you look at all the data, tongue base is about 51%, soft palate 84%, tonsil 32%, epiglottis 34%. And there are many, many kinds of scoring techniques, but the most standard is vote. So this is how we do our reporting. I have the document, I can share it with you all. We have an extensive DICE reporting system, but in a nutshell, this is how it is. The level, the degree, and the direction for every level. So for us to understand, for the uninitiated, this is a lateral collapse, and I have marked the posterior pharyngeal wall. This is a lateral collapse. This is a circumferential collapse. This is a anteroposterior collapse. This is at the level of the velum. Okay? Now, we can make out that there is a collapse happening in all directions, whereas here it is only happening in side to side, and this here it is happening in the anterior-posterior direction. How about lingual? So when you look at tongue, see, these are lingual tonsils, but this is how a muscular tongue base looks like. Very different from a lingual tonsil. So you need to know whether it's a lingual tonsil hypertrophy or a muscular tongue base which is causing the problem. And then you have the epiglottis, So it is either an anteroposterior collapse or a lateral collapse, or is a collapse happening because of the tongue crushing the epiglottis. So now we have gone beyond just doing levels of obstruction. We do what is called as interventional DISE, wherein you're putting a PAP pressure and you're seeing at what PAP pressure is the airway opening. So this is very useful to see why a patient is not adherent to CPAP. So at different PAP pressures, we sort of try and see how the airway is behaving. And we also call this as airway characterization. For every patient, we see the palatal opening pressure and the pharyngeal opening pressure. Why is that important? Because we know that pressures of about 8 to 10, the airway is relatively stable. That's the CPAP pressure at which everybody is comfortable. Beyond 8 to 10 centimeters of pressure, the patient themselves may not be comfortable. And the same applies to us in surgery as well. So it's very important to understand this. So what we also do, we have our dental colleague here, Dr. Kranti, who along with us, we do the DISE to actually see and measure how much of improvement are we really getting with the mandibular advancement device. You measure how much of it can be advanced, and then based on that, you can actually lock it at that advancement, and then a customizable device can be made for that particular patient. So for which the dental colleague is also there with us in the operating room, and then we do the evaluation together. So we also have to look at postural therapy. And so there's lots of papers out there talking about DISE and PAP. This is one paper that I'm particularly proud of. This is from PGI, wherein they found out that at different PAP pressures, I mean, if you look at the tongue base and the epiglottis, which corresponds to the hypoglossal area, I mean the hypopharyngeal area, there is more partial resolution or complete resolution or no resolution at all. So no improvement if you see at the level of the tongue base and epiglottis. So what did they do? They took the 95th percentile pressure and applied and did the DISE. And they found out that the velum and the oropharynx is beautifully opening up, but the tongue base and the epiglottis is not opening up. And this is being published in Sleep and Breathing. So again, lots, not only for CPAP, it also for mandibular advancement devices. When you do drug-induced sleep endoscopy and titrate them, it's associated with better outcomes. So I love this picture because I keep coming back to it. And barb sutures have revolutionized the way we do surgery nowadays because it's knotless and the tensile strength keeps getting better and better. So all procedures have now shifted from traditional knotting sutures to knotless procedures. So there are different techniques out there, different ways that you can do procedures, but this is not the platform for that. And now increasing data coming out. This is the SAMS trial, also known as the randomized controlled trial on effect of multi-level surgery versus medical management in not only AHI, but patient-reported outcome measures and the literature supporting surgery. This is the literature suggesting transoral robotic surgery with tongue-based resections when you have sleep apnea. And again, showing that you don't need to have an expensive Da Vinci. You can get the same outcomes with regular tools as well. And there's the fascinating role of epiglottis. Like I showed you before, there is primary and there is secondary. And you can do suprahyoid epiglotectomies to basically see, this is 10 days post-op. And because these are typical phenotypic patients wherein you remove the suprahyoid part of epiglottis, the chance of aspirations are also almost zero. So you need to understand that OSA is a condition that comes with, wherein if you are a guardian of a patient with OSA, bullets come from all over. And they come all over your life. So you need to be like Neo in Matrix, where you are able to control everything. You need to understand that OSA management is a team effort. One person cannot do all of this. So we need to know that the best predictors for CPAP adherence are, we don't know yet, okay? But we are getting close. And we will definitely get close with all our specialties working together. So dear colleagues, when CPAP fails, surgery can be an excellent option. OSA is a chronic disease, multifactorial disease. So careful evaluation, assessment and treatment should be rendered. Site-specific surgical intervention in combination with healthy lifestyle modifications can be the foundation upon which sleep apnea can be treated. Thank you very much. Thank you for your extra time.
Thank you, Dr. Srinivas, for that excellent talk. Now of course, in the shortage of time, we'll maybe take up one or two questions after the session. The next one is a relevant topic. We have already heard the role of surgery in non-adherence, whereas when it comes to rather curing sleep apnea, instead of controlling it with a CPAP machine, of course, CPAP is only a controller. Ultimately, our objective, if at all, if possible, to get rid of that CPAP as well. What is the role of oral and maxillofacial surgeon in the management of OSA? By Dr. Ramakant Dubudu, who is the consultant oral and maxillofacial surgeon here. Dr. Ramakant.
Thank you, sir. Thank you for the kind introduction. A very good afternoon to you all. Is the screen visible? Yeah. Following upon, after Dr. Srinivas Kishore's talk, I'll be briefly covering about the role of maxillofacial surgeons in management of obstructive sleep apnea. Surgery, as we know, plays a key role in the contemporary management of obstructive sleep apnea. And oral and maxillofacial surgeons, with their expertise in the craniofacial region, contribute to this significantly in many ways. It could be early identification of a potential airway problem, appropriate referral to other specialists, or being part of the surgical team which is treating the patient. Now, obstructive sleep apnea virtually affects every organ system in the body. It can worsen existing medical conditions, and it can also influence the onset of new disease. In this way, it is like a cluster bomb. It wreaks havoc in the body. We have covered this. Now, what makes it an interesting public health issue is the fact that it is a very common condition, but it remains relatively underdiagnosed. That's the reason it's a public health issue. And contrary to the popular belief, obstructive sleep apnea is not a modern disease. Kumbhakarna, Ravana's brother, most probably had obstructive sleep apnea along with other attendant medical conditions like hypothalamic obesity. I mean, this is what the current literature speculates, that he is a classic character for obstructive sleep apnea. And obstructive sleep apnea is a rising global problem. And what is driving this increase in prevalence throughout the world is the modern lifestyle. Yeah. You see Bappi Lahiri here, who was a victim of obstructive sleep apnea, and if you look at his facial characteristics or craniofacial characteristics or body morph, he again fits the typical character of a patient with obstructive sleep apnea. Now, broadly, there are 4 phenotypes of obstructive sleep apnea, and in fact, broadly, there are only 2. Either it's an anatomical compromise or there are non-anatomical factors. And what I'm going to focus in this 10-minute talk is, as a maxillofacial surgeon, on the craniofacial phenotype. That's what we are going to look at. Now, to solve any problem, we need to understand it better. And obstructive sleep apnea is not a simple problem. It's not a simple disease. It's a complex, heterogeneous condition in which many factors come into play simultaneously at the same time. So it is not a completely well understood condition even today. And as I said, to understand a problem, there is no better way in biology to understand a problem other than an evolutionary perspective. So, did evolution play a role in humans being predisposed to obstructive sleep apnea? Yes, evolution did play a significant role, because there are certain evolutionary changes like complex speech production or bipedalism, which have resulted in some adaptations or modifications that have predisposed humans to obstructive sleep. You don't see obstructive sleep apnea in many species. Now, as speech production became complicated, what happened was the foramen magnum migrated anteriorly. The maxillomandibular complex regressed a bit. The larynx has descended, because as humans are assumed an upright position, we started relying more on vision rather than olfaction. So once this happened, there was no need for the soft palate to be locked to the epiglottis. So these two got separated, and between the soft palate and the epiglottis, humans developed what you call the oropharynx. Unfortunately, this oropharynx is a muscular structure. It is quite floppy, distensible, and collapsible. So these combination of factors, maxillomandibular retrusion, laryngeal descent, these have resulted in humans being predisposed to obstructive sleep apnea. But even with an evolutionary background, have we understood obstructive sleep apnea completely? No. But what we know that in majority of cases, the problem is that there are anatomically small and collapsible upper airways which are interacting with normal physiological mechanisms. This is a norm what you see in a majority of patients. And in majority of the patient, the pharyngeal abnormalities are multi-level, not at one level. And again, in majority of patients, the airway collapse is in the lateral dimension, not in the anterior-posterior dimension. So with this understanding, another point we need to remember is that upper airway and all its components are directly attached to the maxillomandibular complex. So if we have to encourage an optimal development of a good airway which is non-collapsible, we need to provide conditions wherein optimal growth and development of the craniofacial structures happens. Now, one man approached a gardener and asked how come his flowers are so beautiful or his plants grow so beautifully, and the gardener replied that he doesn't force them to grow beautifully, he just removes any impediment for that growth. And similarly, we don't force the optimal development of craniofacial structures. What we do, or what's our duty, is to remove any impediment for this optimal growth. And the number one impediment, as other speakers must before me have mentioned, the number one impediment at a young age is mouth breathing. We underestimate this problem. Nasal breathing is normal, mouth breathing is abnormal. Nasal breathing will positively influence craniofacial bone growth structure. Mouth breathing will have a negative impact. So if we identify this problem, it's our duty to immediately correct it to prevent any problems later on, especially in adulthood. And if it is untreated, what happens is the child develops a characteristic facial phenotype called adenoidal faces. You'll see these characters. We see a lot of these patients in clinic, and I promptly refer it to the ENT surgeon to look at adenoids or tonsils and treat them immediately. If you don't do that at this stage, then as an adult, we will have to intervene doing a major surgical procedure called orthognathic surgery, wherein the maxillary position and mandibular position, all these have to be corrected. The second impediment to optimal growth of craniofacial structure, again, is a simple problem. Not many people pick it up, the tongue tie or ankyloglossia. Now, again, the role of tongue is underestimated. The position and movements of the tongue are absolutely essential for molding of the palate. If the tongue doesn't rest in the roof of the mouth when the child is asleep, and if the movements are impeded with ankyloglossia, the palatal tissue doesn't get, the palatal bone doesn't get molded. And if the palatal growth is constricted, you will have a narrow airway in the lateral dimension. And this is what a restricted palatal growth due to tongue tie looks like. The palate will be high arched, it will be narrow. And as Dr. Srinivas Kishore was mentioning before me, in this kind of patient, you can easily assume that the nasal airway, the volume will be less, the resistance will be more, they are prone to breathing disorders, and they are prone to obstructive sleep apnea. All this could have been prevented simply if someone had looked into their mouths and diagnosed that they have a tongue tie or ankyloglossia. This happens quite quite frequently. We see a lot of adult patients with ankyloglossia, surprise. Now, when we identify this in a growing child, the correction becomes rather simple. We can initiate a functional therapy wherein you can do a surgical maxillary expansion or just an appliance expansion. And what this does is it expands the airway in a lateral dimension. And if the airway is expanded in a lateral dimension, you are increasing the volume, you are reducing the resistance, and you are preventing any problems with obstructive sleep apnea. Now, hyoid bone is another anatomical structure which plays a key role in airway patency. Now, if the hyoid bone's distance is more than 15 mm from the what you call the mandibular plane, which you can roughly translate it as the lower border of the mandible. If the distance is more than 15 mm, you can assume that they are prone to obstructive sleep apnea. We see this again in a lot of patients. And these patients, the craniofacial phenotype patients with obstructive sleep apnea will have quite characteristic craniofacial features. And in fact, as others were mentioning, when they walk into the clinic at the door, I can make out that yes, most probably this guy is a snorer. He has a classic obstructive sleep apnea with a very high index. Now, we have understood the problem a bit from a maxillofacial perspective in a craniofacial phenotype patient. What about the solution? What about the solution for this problem? Now, again, airway is a cylinder. The upper airway is a cylinder. And if you look at the physics behind it, the resistance to airflow in the upper airway is inversely proportional to the fourth power of the radius. And it is directly proportional to the length of the cylinder. So, if we can increase the radius of the cylinder, or if we can increase the dimension of the airway, we are literally reducing the airway resistance and you're increasing the flow. And this is the rationale behind all these skeletal surgical procedures, what we do for patients with obstructive sleep apnea. Now, the philosophy of skeletal surgery for obstructive sleep apnea revolves around two important concepts: normalizing the form and function. The form is the anatomical form, we tend to normalize it, and if there are any other pathophysiological factors underlying, we tend to normalize that. That's the basis. And international literature evidence, this has unequivocally shown that skeletal surgery or any surgery in obstructive sleep apnea patient will have a positive impact in multiple domains. So, this surgical management of obstructive sleep apnea patient, again, there are two broad approaches. Either we bypass the problem completely, or we try to restructure or reconstruct the airway. Now, if you look at the tracheostomy procedures with the ENT surgeons perform, this is the first approach where you are completely bypassing the upper airway, you are bypassing the problem. Now, this is the only surgical intervention which is 100% effective. There is no other surgery, either soft tissue or skeletal, in treatment of obstructive sleep apnea which has got a 100% success rate except tracheostomy. But we can't advise tracheostomy except in patients who are completely morbid with obstructive sleep apnea. No one is going to accept the idea that they have to go around their lives with a permanent tracheostomy tube in place. So unfortunately, this is not a solution. Now, the second approach wherein we modify the skeletal, wherein we either modify the soft tissue or the skeletal tissue. Soft tissue modifications, as you know, fall under the remit of ENT surgeons. The procedures what they carry out, like polypectomy, turbinectomy, tonsillectomy, adenoidectomy, all these are restructuring the soft tissues of the upper airway. Whereas the skeletal restructuring or the skeletal modifications are what the maxillofacial surgeons do. And the most common procedures we do are the advancement of the chin or the genioplasty, advancement of maxilla, mandible, hyoid suspensions, surgical expansion of palate, either in one step or in multiple stages. These surgical interventions we carry out. But before I describe a bit more detail about surgical interventions, I would like to quickly mention about this mandibular advancement device or mandibular advancement appliance. Now, this is one indication. Is the time up? I'll just take a couple more. This is indicated in patients who have mild to moderate obstructive sleep apnea and who do not tolerate CPAP therapy, or in whom the CPAP therapy has failed. The custom-made one works best. Now the picture what you see is what I commonly do, the mortised advancement genioplasty, which is an improvisation of the traditional sliding genioplasty. Now in traditional sliding genioplasty, the problem is that the surgeon tends to fail capturing the genioglossus muscle, which is slightly superiorly placed at the back of the chin. Whereas if you modify the design by taking the cut a bit higher up in the anterior mandible, you capture the genioglossus, geniohyoid, and if you advance that bone fragment anteriorly, you are opening up the airway at the base of the tongue. Not only that, you also advance the anterior belly of the digastric muscle in this procedure. Now, this is the intro or the end of the surgery procedure. This is a profile view of a mortised advancement genioplasty which I have carried out. You can see how the chin comes forward, and you can either bring it forward by 6, 8, 10 mm, whatever the clinical situation demands. But of course, the BrahMos missile in the arsenal of the maxillofacial surgeons against obstructive sleep apnea is undoubtedly maxillomandibular advancement. Now, this is the most reliable surgical procedure, only surgical alternative to tracheostomy. Surgical efficacy is excellent, mainly indicated in hypopharyngeal obstruction, or what you call the Fujita 3 situations. Now, the advantage about this procedure is that it pulls forward the entire skeletal component and also the soft tissue components attached to the maxilla and mandible. And when nothing works, this invariably works. MMA never fails, but you have to choose this procedure carefully. And in terms of therapeutic efficacy, MMA is very much equal to nasal CPAP therapy. And as the picture depicts, it entirely enlarges the velopharyngeal tissue, pulls forward the anterior velopharyngeal tissues, and it also increases the muscle tone of the genioglossus and other muscles, other pharyngeal dilator muscles. And the best thing about MMA is it also causes lateral enhancement of the airway. As I mentioned earlier, the collapse in majority of patients is the lateral dimension. So MMA achieves that. Distraction osteogenesis, we undertake this when we can't do a one-step correction. There are situations where you have to advance the maxilla and mandible by more than 1 centimeter or so. We can't do it in one step. Or in pediatric age group, when we can't do a one-step procedure, we resort to distraction osteogenesis. Of course, there are challenges in all the surgical procedure. Surgeries work best when the underlying problem is the upper airway anatomy. If the underlying pathophysiology is something else, surgery is not going to be successful. DICE currently is a gold standard for evaluation, but it has its own shortcomings. Okay, so interpretation of DICE data is very subjective. The anesthetic drugs which are given during DICE tend to relax the muscles a bit more. They never truly represent the sleep. And in summary, there are certain craniofacial features which are associated with obstructive sleep apnea, but short airway or a small airway doesn't necessarily mean that the patient will have obstructive sleep apnea. Mouth breathing, if at all noticed, every effort should be made to convert it into nasal breathing as soon as possible. And surgery can achieve important quality of life outcomes. In majority of cases, skeletal surgery results in complete cure. And above all, the key to successful treatment of obstructive sleep apnea is multidisciplinary care. Thank you. Sorry for the slight overshoot of time.
Thank you, Dr. Ramakant. Your talk was as beautiful as the images or pictures that you used.
Thank you.
The other time. Thank you. Any quick question? One question may be taken for you. Okay, then we'll move on to the next session. Next comes the topic of myofunctional therapy for OSA, exercises that support airway health by Dr. Yogita Babani, who is the lead physiotherapist here. Dr. Yogita, please.
Hello everybody, good evening. Today I'll be talking all about the role of myofunctional therapy in sleep apnea. So we know that sleep apnea is a most prevalent and underdiagnosed sleep related disorder where there's a collapse of airway during sleep, and this collapse is majorly due to your tongue muscles, nose muscles and your facial muscles. That means when there's a weakness in tongue muscles, facial muscles and nose muscles, there's a collapse of airway. And myofunctional therapy is a natural and non-invasive way to airway health. So it uses isotonic and isometric form of specialized form of exercise-based therapy where it helps in improving the tone and strength of these muscles, improving neuromuscular re-education. So before understanding what these exercises are, let us know how does these muscles helps in keeping airway patent. So when we are awake, these muscles keeps our airway open because they are stronger and coordinated. But during REM sleep, this muscles tones naturally reduces, and that leads to airway collapse. So somebody who has a facial asymmetry and incorrect tongue postures, incorrect breathing pattern, improper lip seal, already these muscles are weak. And further during REM sleep, this muscle tone gradually reduces naturally and further increases the risk of airway collapse. So why this 4 pillars of patent airway matters? So correct tongue posture, because we all know that it should rest against the roof of the mouth and should not lie or fall low back in the throat. And the exercises to correct the tongue posture is tongue suction holes and tongue push-ups. We have made a special video of all these exercises, so I will not go into detail of these exercises. Now breathing pattern. Nasal breathing is very, very important because it filters and humidifies airs and promotes airway stability. On the contrast, mouth breathing leads to low tongue posture and again airway collapse. So there is other exercises for nasal breathing, that is diaphragmatic breathing and Buteyko style breathing. That is a different new form of breathing where you have to ask the patient to inhale through the nose and exhale completely and ask him to hold the breathing, don't breathe, and ask him to pinch the nose so that he will not breathe for a couple of seconds so that there is no carbon dioxide retention. That is a new form of breathing we have seen in papers. Lip seal. Why does lip seal matters? When the lips are closed, tongue automatically rests on the palate, and again there is a nasal breathing is enhanced. So it prevents mouth breathing. The exercise examples for this is lip button pull. So you give the patient pencil or pen with the button and ask him to pull the button. Then the lip closer. Ask the patient to put the lower lip on the upper lip and ask him to make funny faces. Then swallowing pattern. An improper swallow can reinforce low tongue posture. Normal swallowing pushes tongue upwards, correcting tongue posture. So when we see all these things, swallowing pattern, lip seal and breathing pattern, all of this are enhancing a correct tongue posture. So we should understand how tongue posture is important in managing sleep apnea, and that's how you have to train patients with lot of tongue resistive exercises. So for swallowing, you can improve the swallowing with chewing exercises and effortful swallow. Effortful swallow is ask the patient to swallow as if he's gulping a bigger pill, so that he will contract all his tongue muscles and throat muscles. Now, when we have seen all this, why this is important. So myofunctional therapy can promote everything: nasal breathing, proper lip seal, better tongue posture, and also swallowing pattern. Now, protocol. It should always be supervised with a trained physical therapist. Duration in few of the papers is 3 months, and in few of the papers it is 3 to 6 months. And daily practice is 30 minutes minimum. So in one of the paper I found, when the patient practices it for more than 30 minutes, then there are chances that apnea-hypoapnea index in the sleep apnea is coming down. So common exercises we have discussed. Now, who are the ideal candidates for this? Adults with mild to moderate obstructive sleep apnea. Of course, for the severe sleep apnea, it should be a complement to CPAP. Children with tongue tie, mouth breathing, orthodontic issues, and patients who are not compliant to CPAP. It also helps majorly with the post-operative patients to maintain the airway tone. Now, when it is integrated with CPAP, it complements these therapies, CPAP, oral appliances, and surgical treatments. It should be used before and after the orthodontic or maxillofacial procedures. Now, what are the challenges? I will not tell these are the challenges, but I will tell that you have to counsel the patient a lot so that they will, so that they will adhere to this therapy and give a lot of time to do this therapy. It is less effective as a standalone therapy for severe OSA, but when it comes to mild OSA, it is a standalone therapy. Now, this case we have found, we have seen this patient in AIG, a 45-year-old male with a moderate OSA. Initial apnea-hypoapnea index was 21 in sleep study, and after 3 to 4 months of therapy, it reduced to 11. And additional benefits, of course, when the apnea-hypoapnea index reduces, it reduced snoring and better CPAP tolerance. Now, take-home messages. It's a simple and non-invasive way to strengthen the dilator muscles. This therapy reduces sleep apnea symptoms by improving tongue, posture, nasal breathing. The most important thing is nasal breathing. Then comes the tongue posture and oral musculature. It enhances overall breathing when used with other therapies. So, at the end, when you combine this therapy with the standard treatments like CPAP and surgery, we get better outcomes. Now, there are few evidences. There is a meta-analysis which was performed, and they said that this apnea-hypoapnea indexed 50% it reduced in adults and 62% in children, with reducing all the OSA symptoms. There is one more study which said that it's a very promising adjunct and it improves AHI when performed alone, but when you perform along with the facial release. Facial release is again a new advanced technique for the muscles. When you perform it with facial release, like facial release for your trapezius, for your levator scapulae, that corrects your posture, your facial symmetry, and that's how it benefits the sleep apnea patients. Now, these are the few exercises. I will quickly go on to the video which we made. Physical therapist from AIG Hospitals. In this video, I'll be talking all about myofunctional therapy for sleep apnea patients. So, as we all know, sleep apnea is a problem where there's a collapse of airway during sleep. And this collapse is mainly due to weakness in your throat muscles, in your tongue muscles, and your facial muscles. And myofunctional therapy exactly targets these muscles. It is a set of exercise where it will strengthen and build the tone in these muscles. So once these muscles are stronger and coordinated, it will prevent your airway from collapsing. So let's see what these exercises are. Now, before demonstrating with the exercises, let me tell you, these exercises are very, very safe and easily doable at home. The first exercise is stand in front of the mirror and say vowels clearly and loudly as if you are exaggerating each of them, like A, E, I, O, U. So this will strengthen your throat muscles. Second exercise is you have to open your mouth and make a click sound with the tongue. Third exercise is just stick your tongue out as much as possible for you, hold it for 10 seconds and repeat for few repetitions. Fourth exercise is you have to put the tongue at the roof of your mouth and press the tongue against it. Again, hold it for 10 seconds and repeat for few repetitions. fifth exercise is put the tongue at the back of your bottom teeth, press against it and hold for 10 seconds. Then the next exercise is you have to open your mouth and move your lower jaw towards the right and towards the left. Then coming to your facial exercises, first facial exercise is purse your lips and smile. So purse your lips for few seconds and then smile for few seconds. That will again activate your facial muscles.
All of you can practice, I think, while she's showing.
Next exercise is spoon and tongue exercise. And then you can even try blowing balloons. You can even try drinking water from the straw. Each exercise should be done for 10 repetitions and 30 minutes in a day. Myofunctional therapy can be a great complement to CPAP therapy. In some cases, it also helps in reducing dependence on the CPAP. And at the last, you have to remember, better sleep starts with better function. Thank you. Thank you so much for giving me this opportunity, sir. Really grateful to all of you for listening to my talk. Thank you.
Thank you, Dr. Babita. Just have one question.
Yes, sir.
Do you see any preferential benefit in different category of patients? Like say some people who are having sleep apnea without being obese. So non-obese patients versus obese patients sleep apnea.
Sorry, sir, I didn't get you.
If you apply this myofunctional therapy to say non-obese sleep apneic patients versus obese sleep apnea patients, is there any extra benefit if you
yes,
have any such evidence for that?
So in the non-obese patients, there is early benefit with this therapy. But when you see the obese patients, multidisciplinary approach is a major thing, like weight reduction, strength training for the other muscles, and myofunctional therapy plays a major role.
Okay. Thank you.
Thank you, sir.
Now coming to the last talk, I guess. It is PAP-NAP trial, real-time therapy evaluation during daytime naps. Dr. Dhruva Vinay Kumar Gella. So Dr. Dhruva is a senior consultant pulmonologist at AIG Hospitals with a specific interest in interventional pulmonology and sleep medicine. Let's hear from Dr. Dhruva.
Good afternoon, everyone. We have just heard an insightful talk on myofunctional exercises for OSA by Dr. Yogita. Now I will be discussing practical and supportive intervention for CPAP adherence. For next 10 minutes, I will be covering introduction, what is PAP-NAP, when it is used, indications, procedure, benefits and outcomes, limitations and conclusion. CPAP is a gold standard treatment for the OSA patient. However, CPAP compliance is very low due to fear of unknown or lack of motivation and mask discomfort or fear of new thing and expiratory pressure intolerance. And PAP-NAP trial is a simple, to address all these factors, we introduced PAP-NAP trial, that is simple and supervised NAP trial to break all these barriers. The positive effects of CPAP is reversing the symptoms associated with OSA or daytime sleepiness, snoring, tiredness. And it is a short supervised daytime NAP trial conducted in sleep lab for 60 to 90 minutes. It combines physiological and psychological treatment in one procedure during PAP-NAP trial. It desensitizes the mask and pressure by keeping the mask. This one we can see is it patient is comfortable with full face mask or nasal pillows or nasal mask. And for pressure desensitization, we have to introduce slow pressure with 4 centimeters of H2O, and it addresses anxieties and it increases the future compliance. If the sleep study suggestive of moderate OSA or severe OSA, if the patient's split night study is not able to capture supine sleep or REM sleep, patient who could not sleep during the full night polysomnography, other indications like claustrophobia or anxiety or new CPAP user or CPAP failures or comorbid insomnia or low motivation, and elderly and cognitively impaired individuals need extra coaching. In our AIG protocol, first we have to see the sleep study. If the sleep study is suggestive of any like moderate OSA or severe OSA, after that we have to take a consent. If the patient is willing for the titration study or PAP trial, if the patient is not willing for the titration study, we have done the PAP trial. In the PAP trial, first pre-test introductions, we have to inform the no napping prior to the PAP and no caffeine prior to the study, because it decreases the nap, and arrangement of lunch prior to the PAP trial to induce the sleepiness. Pre-session education, introduce the mask type like full face mask, nasal mask or nasal pillows. Allow the patient choose the mask, comfortable mask. And desensitization, start a PAP at low pressure at 4 centimeters of H2O. If the patient is not convenient, then we have to start with our auto CPAP 4 by 20 centimeters of H2O. And if the patient is tolerating, gradually increase the pressure if patient is tolerating. And relaxation techniques like guided meditation or introducing the music, calming music and mindfulness, it creates the stress-free sleep environment. After this, all this one, we have to see the post-test results. Is the patient is willing for the is willing to use a CPAP, or is the patient is willing to go ahead for the titration study. PAP trial can be done for the patients with which of the following statements is false. PAP trial is done can be done in patients with claustrophobia, motivation, type 2 respiratory failure or mask desensitization. As previously I have discussed, the claustrophobia is indicated and motivation. Type 2 respiratory failure is not indicated because we are not doing the titration study. We are introducing for the mask or pressure desensitization or to decrease the claustrophobia or anxiety. The duration of the PAP trial, is it 60 to 90 minutes or 120 or 160 minutes, 20 to 30 minutes or 120 to 180 minutes? As guideline says, 60 to 90 minutes. Benefits and outcomes, it reduces the CPAP and related anxiety, and it increases the CPAP pressure and mask tolerance, and it enhances the patient's satisfaction. It improves the long-term adherence to the therapy. The limitations, it requires dedicated staffing and resources. Sleep may not occur during the session, limiting adjustment to sleep-specific discomforts. Some of the studies, Victor Ulibarri, he has done the retrospective study. He has conducted on 139 patients who reluctant to the titration study. The PAP trial has done, it improves the emotion and motivation, and the study of the p-value is 0.001. And another study, the Barrow and Carco has first introduced the PAP trial in 2008. This is a pilot study he has done on 99 insomnia patients. He has diagnosed with a sleep disorder breathing, and reduces the anxiety and is improved the CPAP adherence. Our AIG experience, at AIG we have implemented the PAP trial for over 202 patients, especially those refuse titration study or difficulty in adjustment to the CPAP. We obtained significant increase in the acceptance and compliance post-trial. Our total patients are 202 patients. The male are 142 and female are 160 patients. Actually, sorry for there is no audio. I am showing this is our sleep lab. This is our console room. They are doing actually previous sleep study scoring in our sleep lab. When the patient comes, first we have to check the mask size, and after that we have to introduce the patient comfortable mask. And we have to ask the patient, is he comfortable or not, and we have to start a pressure with a low pressure. And before doing the APNEA trial, we have to introduce the hooks like pulse oximetry and respiratory belts and abdominal belts. Why the pulse oximetry is that to look for his oxygen saturation, baseline oxygen levels, and respiratory belts is the patient is having any central sleep apnea or not. In the central sleep apnea, it is contraindicated for the APNEA trial. We have to do the level 1 titration sleep study for the central sleep apneas. To conclude my talk, the APNEA trial is a promising tool to increase CPAP adherence. It is a 60 to 90 minutes of duration, especially helpful in patients with anxiety, insomnia, and CPAP tolerance. Thank you.
Thank you, Dr. Dhruva, for that lucid presentation. Do we have any questions from the audience?
Just a comment actually. We have started using APNEA trial after I visited Mayo Clinic actually. So what I realized that everybody is having sleep labs. In the daytime it's anyway free actually. And most of our patients undergo a sleep study, get diagnosed with sleep apnea. However, because of multiple reasons, they'll not be able to get a titration sleep study. In those subset of patients in whom you're going to suggest an auto CPAP and just send them away, if you have a sleep lab, just send them to the sleep lab in the day, apply the mask and use your machine, and then motivate them, desensitize them to the mask and everything. They'll have some issues, something which they tell us during this 90 minutes trial as well actually. Some dryness, pressure issues or something like that actually. So simply we can make use of this sleep lab in the daytime in a better way. If you are able to do this APNEA trial for our patients whom we are suggesting auto CPAP. That's the comment. Thank you.
Thank you. I have a comment. Actually, we were using APNEA at our place, but we were doing it for patients who have been manually titrated. And those patients who were manually titrated and still they were very, after using their CPAP, they were not very comfortable. To find out the reason, we sometimes use this therapy to, we ask the patient to use the, during the day, and during the day we also see what is the problem which is going on. Some patient, we have picked up that patient might have developed central sleep apnea, and most commonly the patient was not applying the mask properly at their home. There was a lot of leakage. So these kind of problems can also be taken in APNEA trial.
Yeah, absolutely, because I think this has to be kind of made mandatory to say before we suggest a therapy of a CPAP, which is a device which might be uncomfortable, and of course the patients also, they don't know about what they are going to use. Instead of getting it at home or purchasing it and finding it difficult to apply, use, and it's like just when you are discharging a patient, you are explaining the treatment to the person or patient, how to take what treatment and what tablets, when to use. It is something similar to that. Probably it is better to, even if it is for a 1 hour, just so that they can just get some idea about what they are going to use, so that obviously there will be more complying to the treatment. Thank you. So now I think this session seems to be over. We'll hand over this to the organizers.
There's one talk by the rest team actually. I think I'll just, yeah. He's the technical person from ResMed team actually. He'll be talking to us briefly about the cleaning instructions for all the CPAP and the BiPAP machines actually. So if you maintain the machine well, it's going to last for a longer time. If you don't maintain the machine well, you don't clean it, and then you are not aware of the things which can go wrong with the machine, then actually your cost of maintenance will increase actually significantly.
Yeah.
Yeah. Mr. Pushpinderji.
Yeah. Good afternoon, everyone. My name is Pushpendra, and I am heading the After Sales Department here in ResMed. Thank you so much for giving me this opportunity, first of all. Thanks to the organizing committee. So what we are talking about is, it is actually the most neglected part. CPAP doesn't need any maintenance, but if you are maintaining the CPAP device, mask, cushion very well, the machine longevity will be high and the patient adherence will also be affected due to this. So what we need just for the supply is sink or tub, warm liquid quality water, which is like 30 degrees centigrade, mild liquid detergent, and a clean towel. So CPAP mask, cushion, frame and headgear. First of all, we have to unplug the CPAP machine with power adapter. Mask and air tubing should be disconnected and disassemble your mask. By the way, we have organized a workshop also where you can actually do and you can have first-hand experience of the CPAP cleaning. And then disassemble your mask into 3-part: headgear, cushion and frame. So in this, basically the cushion should be cleaned daily, headgear and frame should be cleaned weekly. Just put a gently rub with the mild liquid water generated with the detergent, and we should use the drinking quality water. No distilled water. Whatever we are used to drink, we can use it like RO water. Avoid using strong clinic product as they may be dangerous for the mask and leave harmful residual. Rinse against thoroughly with warm drinking quality water and place the cushion and frame on a flat surface on a top of it all to dry. Avoid any placing them into direct sunlight. Again, the same thing for air tubing. Remove the air tubing from the CPAP machine. Disconnect the air tubing hose from your mask and CPAP machine. Put it into the dishwashing liquid water and clean it from the inside. If you see in the Amazon and Flipkart, we can get the proper brushes also to clean the air tubing. Humidifier, again, we have to, this is like weekly, once in a week, definitely we have to clean this humidifier because there are some white element which actually accommodate, and it actually the therapy will not be good as it is required. So we should not, some of the clinical things to clean the mask, which is like aromatic based solution should not be used, antibacterial soap, dish detergent, alcohol, bleach, strong smelling product, and they should not we should not use these kind of cleaning the mask. Can I use the ozone? They say like very frequently asked question, can I use ozone device with my ResMed machine? No, it is not recommended. If you wanted to disinfect the machine, just 70% alcohol with soft wipe, you can clean the machine, and there is no need for the ozone of this device. So what to look for when checking your CPAP equipment? So these are the things. Every month we should change the mask cushion and the pillow. Every 3 months we should change the mask frame, and every 6 months headgear and chest strap. So what CPAP part do I need to clean and how often? Daily we should clean mask cushion and humidifier water tube. Weekly we should clean mask frame system, mask headgear and air tubing. Like I mentioned, for the CPAP machine, disconnect the power supply, humidifier and tubing from the machine before cleaning. Use a soft cloth to clean the outer machine surface. Of course, don't open any inner body part to the clean. Avoid any solution. Clean, mild wipes can be used for cleaning. If you have any question, you can reach out to this number. You can write us at contact@resmed.co.in, and you can call 1-800-309-1989. So now, globally, we have changed around 178 million people, but counting. We should help 1 in 4 people on this planet. That's ambitious, and we want to be ambitious. Thank you so much. So we have arranged a workshop here. If you wanted to have first-hand experience with CPAP devices, mask, cushion, we can have it. Thank you so much, sir.
Is it recommended to change the mask and cushion pillows every month?
No, the mask is okay. Once in a year we can change.
The pillow, something you said every month.
But if it is like damaged, we have to change.
If it's damaged, not. Okay.
And filter, of course, once in a month needs to be changed. Yes, there is a brushes is coming. We can use it to clean it. No, you just fill the water, clean it, and you can remove it. Just like that.
Can I request Dr. Lakshmikant Tenge and Dr. Kishore Babu sir to come onto the dais once? We want you to give a token of memento to our speakers. Dr. Ramakant sir, I think he has left probably. Who else is there? Dr. Yogita. He's from our hometown. Dr. Lakshmikant is a good friend practicing at Pune actually, in Deennath Mangeshkar Hospital. He's DM Pulmonology from PGI Chandigarh. Next, can he? Dr. Vinay. Yeah. So next actually we have, next half an hour we'll be able to complete it actually. We have the demonstration of titration protocols, case-based scenarios, and also we have 4 small videos which will demonstrate about how you can set your machine yourself. It will be very useful for clinicians actually to how to set your manual CPAP, auto CPAP, and for people who are using advanced machines or who are interested in giving advanced machines like IVAPs or AVAPs machine to your people actually, or BiPAP ST mode for your patients actually. There are a couple of other videos as well which can help you in navigating that actually. So can I request Dr. Abhishek to just showcase 2 cases for titration actually, case-based discussion.
So I will be just briefly talking about how the titration is done. It will be very short talk. So there are many modes, but the titration is basically done for CPAP, and if it fails, we go for BiPAP. There are various modes, but I will be talking only about CPAP and BiPAP S mode. So this is the guideline on which most of the recommendation for titration has been done, and we try to follow this guideline, which is pretty old. Right now, we are not very strictly following it, but for beginners, I will recommend to go through this. So first case is 44-year-old male with typical symptoms of OSA and hypertension, diabetes. So this is a diagnostic PSG. As you can see, there is a significant amount of mixed apnea over here. The saturation is going down, the PTT variance is there. So typical case of OSA. The protocol is very complicated in the diagram, but just to simplify, the pressure has to be increased by 1 centimeter if there are obstructive apneas
2 obstructive apneas or 3 hypopneas. Since we do not score RERA most commonly, so that's why only apneas or for hypopneas, 2 apneas or 3 hypopneas, we have to increase the pressure by 1. That is a simple rule, 1, 2, 3, 1 is pressure to increase for 2 apneas or 3 hypopneas. So we increase by 1 to abolish, this is what we used to follow, we used to increase by 1 to abolish the apnea or hypopnea till the time then there is normalization of flow and snoring. When all the apneas and hypopnea are abolished and still SpO2 is less than 90, only then we add oxygen. And in my opinion, most of your patients, if they do not have associated respiratory diseases, they will not require oxygen. So our target is supine REM and optimal titration. So this was the same patient. We started CPAP at 4 and we further increased the pressure to 6, 7. Still the apnea events were there. Then we increased to 8. There was slightly normalization, but as you see, this is a reverse chair kind of graph over here in the PAT flow. This means that there is obstruction at the palate level. Then and increasing the pressure, we are seeing that the palate level obstruction is getting better. At 11 we are getting REM, there are no events, but as you can see the PAT flow is not good. But at 12 the PAT flow was good, saturation was okay and everything was within normal limits. So we prescribed this patient 12 centimeters with nasal mask throughout to use it for at least 6 hours and follow up the AHI. The machine told that it was 1.8 per hour, 1.8 AHI was there. Patient has significant improvement. So what is optimal titration? This is the criteria. So for optimal, AHI should be less than 5 during titration. For good, if it is more than 5 and less than 10, and if it is more than 10, sometimes if you have very severe cases, sometimes you have associated OHS, you cannot decrease the AHI from 120, so it is decreased to 20, even then it is acceptable. So that is adequate titration. So most often we try to target optimal, but sometimes we have to settle for adequate. And if there is a supine REM, it is optimal or good titration. So another case is for BiPAP. This is a 45-year-old obese patient, BMI of 32 with high ESS of 15. This patient again had significant obstructive apneas with significant desaturation, and also we can see the EtCO2 was going high. So the patient also has hypercapnia. So, and we started at 4, still apneas were there, at even going up to 16. Up to 16, we go from 5 to 12, the events were there, up to 16 it was there. So since apneas were there, so even at 16 we shifted to BiPAP, otherwise we usually go up to 18. So guidelines say we can go up to 15, but usually in our lab we go up to 18 because some of the patient cannot afford a BiPAP therapy, so we have to see that aspect also. So BiPAP is in the S mode is basically a continuous pressure which is given to the patient. So BiPAP S is basically given for OSA and associated diseases like COPD, obesity, hypoventilation, neuromuscular, other restrictive disorder. Then you have to go for BiPAP ST, and if there is a kind stroke respiration, then you have to probably go for ASV if CPAP has failed. So the BiPAP titration protocol is start by 8 by 4. You increase both EPAP and IPAP till the obstructive apneas are abolished. And when the obstructive apneas are abolished, only hypopneas or snoring is there, then you increase only IPAP. You have to maintain a minimum difference of 4, which is the minimum requirement for a BiPAP, and the maximum we usually don't go beyond 10. So suppose we are increasing the pressure from 8 to 4, then 10-6, then 16-12. After 16-12, the apneas are abolished, then we only increase the IPAP, say 17-12, 18-12. That's how we do titration. So for this patient, we started at 8-4, then at 9-5, again the obstructive apnea was there, and then 12-8, 17-13, and at 22-18, even then the pressure had significant obstruction was there. So at the pressure, at pressures of 27 by 21, the maximum pressure, the PAT flow was smooth, and patient had significant stabilization of his sleep. There was no desaturation, there was no arousal, so leakage was on a higher side. but patient was comfortable and patient slept in this pressure for at least 1.5 hours and he achieved supine REM. So patient was given this pressure 27-21 and his EDS improved. His follow-up AHI was 4.5, still it was a slightly higher side, but it was acceptable. So the sleep technologist during the titration has to document few things: when the pressure was started, why it was changed, in which position it was changed, what was the sleep stage. So we have a we have made a we have a documentation program for that, and the technician has to document everything in that software, what kind of pressure is required and why he is changing the pressure during night. So to summarize, in lab titration is an effective way to see what is happening to the patient. In 20% of our patient, we usually see that CPAP titration fails and we have to go for BiPAP titration. And you have to ensure a proper mask fit and leakage value should be acceptable, and leakage value depends upon mask to mass. And with increasing pressure, the leakage will also increase. So every manufacturer, every mask manufacturer has given a table with each mask that at particular pressure, say at 10 centimeters of pressure, the leakage, acceptable leakage is this much. So if you increase to 12, the leakage will be also on a higher side. So on depending upon the pressure, you have to see whether the acceptable pressure leak is there or not. I think we have to now move to the workshop where further questions will be answered regarding titration. Thank you.
Can I have the videos on first on manual CPAP? Can we call our team also? Ask them to play the videos actually. What we have done is actually we wanted to get things here and then demonstrate, but that would be more cumbersome, and then also everybody would not be able to see. So that's why we made some videos so that it can be played on the screen so that everybody can see properly, because all these machines are small. And then so we'll be having brief demonstrations on manual CPAP, auto CPAP setting, BiPAP, BiPAP S, BiPAP ST, and also on IVAPS mode actually. All these presentations club together almost between 16 to 17 minutes actually. And then whoever has any doubts, probably we can ask. The experts are here. And the company people are also there. So at least some of the things where servicing issues.
Hi everyone, I am Dr. Annie Surgeries, first year DNB resident at AIG Hospitals, Department of Pulmonology. I am here to explain one of the PAP devices, that is manual CPAP. So this is a model of manual CPAP. Once the adapter is connected to the power supply, we can turn on the machine by pressing the power button for a couple of seconds. So this device is on now. This is the dial button and this is the home button. So turning the dial button, we can switch the options. This has two options currently now, My Options and the Sleep Report. Going to the My Options settings, we have several options here. So the first one is the RAM time. So RAM time is basically the time taken by the device to adapt to the highest setup pressure from the baseline pressure. So it can be set up by the prescribed time by turning the dial. Next one is the humidity level. Humidity level can also be adjusted by turning the dial button. Actually, we have manual humidity level also can be adjusted, and automatically it can be adjusted. Automatically it can be adjusted by connecting a climate control tube. Next is the pressure setup. It's on now. Regarding the mask, we have a couple of options. Pillow mask is there, full face mask is there, nasal mask is there. You can select the option as prescribed by your physician and sleep study reports. The tube settings, it's always, we'll keep that in a standard setting. So that's all about my options. Going back, we can get a sleep study by this turning on this option. Next, going to the clinical setting, we can go to the clinical setting by pressing this dial button and home button at the same time for a couple of seconds. So we enter the clinical settings. Going to the settings now, we have the mode. It's now CPAP mode activated. The pressure, basically the manual CPAP has a pressure range of 4 to 20 centimeter of water that can be adjusted as prescribed in a sleep study report or as advised by the physician. So turning on this option, we can adjust the pressure by turning the dial. As I said earlier, the next option is mask. It also can be set up by as prescribed by the sleep study report, pillow mask, full face mask or nasal mask. Next is RAM time. As I earlier described, the RAM time is the time taken by the device to achieve the highest setup pressure from the baseline pressure. So these are the available options for the patient to set up. This is all about the manual CPAP device.
Hello. We'd like to answer any questions if you do have one. So we'll proceed to the next. We can play the next video.
We are okay with the AV team. So if any one of you have any question regarding anything related to sleep medicine, I will be more than happy to answer. If any one of you has any doubt.
Sir, what will be the cost of polysomnography overall?
So polysomnography is basically level 1 machine that includes everything related to EEG, EOG. That's what I think you are asking. So currently there are two major players who are selling in India. One is Philips. The cost for Philips is around 19 to 20 lakhs. They have only one level 1 diagnostic device, that is LS6. The second company is Somnomatics. They have 3 models, and the HD machine, HD Eco, is around 24 lakhs. That includes GST, and the higher model HD is around 26 lakhs. So any question, no question is a stupid question if you want to ask any type of question related to sleep. See, if there is a if we have the luxury of doing everyone a level 1 PhD, I will still go for that. But unfortunately, we don't have enough labs. So that's why most of the people in West are moving towards level 3 because of the cost issues, as I mentioned. But given a choice, level 1 is always better than level 3.
The thing is at the periphery, in the district level and all, the thing is when on the clinical base, the patient is obese and has come to the casualty with increased ABG showing 90 PaCO2 and all. So we are treating with BiPAP in the hospital, and we are advising the patient directly without doing the sleep test, because the patient is not obeying for sleep test. He is not giving consent for sleep test, and he does not want to go for sleep test. And directly we are advising CPAP for the patient without doing sleep study. So it is okay because
it is not okay, but that's the best you can do. So if patient is not comfortable doing sleep study, you don't have sleep setup, then what is best is you titrate according to the PCO2 levels and try to achieve as close to normal as possible, and probably that will help in normalization of sleep also, but that is not the right way to do it.
Because after ruling out other causes for increased PCOT, So the last we are left with sleep apnea syndrome only, taking into consideration male patient obese and those considerations and PSO2 and history of snoring and
So in any patient of with obesity hyperventilation, I think you are talking about. So obesity hyperventilation, you should do a sleep study. You should do a sleep titration. That is the guideline for sleep. For OHS, you cannot give auto-PAP because most of the patient will require a higher pressure as compared to the pressure requirement which is usually required by a normal OSA without OHS. So ideally, sleep study should be done, but if you don't have the luxury, give a BiPAP because that will take care of the acute phase, and probably that patient, more 50% of your patient will require a BiPAP. If they are landing up with a hypercapnic respiratory failure and there is no other cause, most likely the patient will require a BiPAP, at least in that particular setting. And later on, after 1 month or 2 months, if patient is convinced that sleep study should be done, at that time you can see what is the pressure requirement. Till that time, BiPAP machine can be given, and BiPAP machine can always be converted to a CPAP machine. CPAP machine cannot be converted to a BiPAP machine. So it is safe to give a BiPAP machine to that particular patient at that time. And later on, if your sleep study shows that pressure requirement is lower, then you can shift to a CPAP on the same machine.
So one question, if a patient has a low ejection fraction, suppose a patient has an ejection fraction of less than 25, and we are applying CPAP, so it will decrease the venous rate and further hypotension, and those patients are already hypertensive. So what is your take, or what is your way of treating those patients?
So if you are giving very high pressures, only then that physiology will work. But if ejection fraction is less than 25 and there is the patient requirement is high, the CPAP pressure is high, I don't think that will decrease the pressure. I don't think that will do, because we have seen patients of heart failure who have been prescribed CPAP therapy on the basis of manual titration, and they usually do well. But if you are giving a BiPAP, that will hamper the problem. If BiPAP without titration, if you are giving for these kind of patient, SURV-HF trial has shown that if you are giving ASV in a very low ejection fraction, it increases the mortality. Right now, the Advent-HF trial have shown that it doesn't increase the mortality, but it does not have any benefit also. So I think right now the concept is, if there is a central sleep apnea, a low ejection fraction, you do a manual titration and see what the pressure is required, the CPAP pressure. Most of the patients who, if they are lean and thin, they will improve with CPAP. If they are obese, then chances of failure with CPAP is higher.
Thank you, sir.
Sir, one question. So patients with complex sleep apnea syndromes like COPD with OSA, what is our mode of PAP therapy?
So that is not complex sleep apnea. This is
complex.
This is overlap syndrome. Overlap syndrome. So the question is, what is the CPAP titration? So we always start with CPAP. And in my opinion, if patient has presented with respiratory failure during acute phase, a patient will require BiPAP at that time. Most of the patients will settle with BiPAP. After a few weeks, if you want to repeat the sleep study, the pressure requirement will always be same. We have done that study. We have recently published it. If patient is lean, his BMI is less than 22, then chances of him settling with a CPAP titration is higher. If patient's BMI is more than 22, because COPD is a high catabolic state, even in spite of having a COPD, if the BMI is more than 22, the chances of having coexisting OSA is higher. And that has been proven in 2 of the other studies. Then CPAP failure will be higher. So you always start with CPAP titration, and if it fails, then you move to BiPAP, ST.
Okay. Sir, one more question. Like previous person asked, like heart failure, patient with OSA with heart failure, ejection fraction is less than 45. Sir? So OSA patient with heart failure where ejection fraction is less than 45, I heard AVAPS is better than going for CPAP.
No.
Is it like something?
No. What is AVAPS? Is a kind of ventilator. It gives a target ventilation. Okay. So you set the tidal volume, ki itna tidal volume you have to deliver. That's all. So it will increase the pressure support. If you increase the pressure support, there is a high chances of development of central sleep apnea. So if patient has central sleep apnea, there is a higher risk to develop central sleep apnea, which will increase further if you give higher pressures. Okay. So for patients who are at higher risk to develop central sleep apnea, the current concept is to give a controlled amount of pressure, be it on a lower side. It is always better to start with CPAP, and 50% of the patient will settle with CPAP. If it doesn't settle with CPAP, the next best option is to add either acetazolamide or add O2 along with CPAP, or you can do a ASV titration.
Okay, sir. I have one patient. He is a known case of myotonic dystrophy, is having bilateral diaphragmatic weakness. I started initially on BiPAP, sir. Still CO2 is retention is there. Do you suggest in this patient go for AVAPs?
So
Because
for
lung volumes are compromised, sir. So
for this you can go for bilevel ST because the diaphragm is involved. That hypercapnia must be there.
Okay.
And if the airway is also in airway means the aerophagia is there, then bulbar involvement is there, then PC mode will work better theoretically. Practically, I don't have experience for that. But considering diaphragm involvement and hypercapnic respiratory failure, bilevel ST will work better.
Okay. Thank you, sir.
And moreover, with AVAPs, the pressure limit is of 25. So that is another consideration. You cannot give higher pressures in some patients who require IPAP more than 25.
After this question, probably we'll restart the video. Okay, please go ahead.
Sir, in CPAP therapy, till what pressures we can keep, like, is there any limit for the pressures after?
So
when should we plan to shift to BiPAP?
Yes. So ASM mentions 15, but in my experience, I think up to the margin of 18 is also good enough because of the cost issues. Because bilevel S or ST has also in some inherent problem because of the increased pressure. Then you have to use oral nasal mask also. That will further decrease the airway caliber. So I try to use CPAP as far as possible. My limit is 18 centimeter.
18. Beyond that, you will be.
I shift to BiPAP.
ST mode.
S mode for OSA.
Okay.
BiPAP maximum pressure. So for the titration machine, it is 30 by 25, but most of the companies are selling of 25 by 20 pressures. So you have to choose your model which you are. If you are doing titration of 27 by 21, just like I show, it is very rare to have those kind of patient. But if you are doing titration of 27 by 21 and you are prescribing a bilevel ST with an IPAP mode of 25, that will not work.
We'll restart again the demonstration of PAP devices. Thank you, Abhishek. Thank you.
Good afternoon, I'm Dr. George Roshan from the Department of Pulmonology in AIG Hospital, and I'll be demonstrating on how to set up ST mode in a bilevel PAP system. So this is the machine that we'll be using to demonstrate the BiPAP setting, the BPAP setting in ST mode. There's an external humidifier that is attached to the machine, which can be detached. So once it's detached, there is a notch which can be used to open up the humidifier. The humidifier chamber can be filled with either RO water or distilled water. If you're using an RO water, the water needs to be changed every day. And if you're using distilled water, that is not the case. Until the water gets contaminated, it can be reused over and again. And there is a marking up till which the water needs to be filled, and the water needs to be filled up to the marking, which is given on the side of the BPAP machine, which can be opened where the filter is placed. So the filter is generally white in color, and what denotes that the filter has become dirty is that it changes color to either greyish brown or just brown. And how to clean the filter is that the filter needs to be tapped until the residual dust falls away. And ideally the filter has to be changed every month. Next, I will be demonstrating on how to connect the tubing to the BPAP machine. So this is a climate control tubing, so which goes and attaches on the back of the BPAP machine, and once it's attached, the system automatically recognizes that the climate control tubing has been attached to the machine. Next, we will be switching on the machine. Once the machine is switched on, there are two options that are available for the patient. One is the My Options and the other is the Sleep Report. The My Options gives limited access to the BPAP machine's settings. Those are the ramp time, the ramp down time, climate control. So climate control, when a climate control tubing is attached, it automatically recognizes it and sets the settings as default. The tube temperature, leak alert, smart start, the kind of mask the patient is using, and the fit test and the warm-up test. I'll be explaining about the ramp time and the ramp down time in the subsequent settings. So moving on to the controls that are available for the practitioner to set. So once we go into the settings, there are different modes the BPAP offers. between CPAP, S mode, ST mode, T, IVAPs, and this particular machine has a PAC mode as well. So we'll be dealing with the ST mode. So once the ST mode is selected, there is an IPAP and an EPAP option. IPAP stands for inspiratory positive airway pressure and EPAP for expiratory positive airway pressure. The IPAP minimum range is between from 4 centimeters of water and can go up till 25 centimeters of water. And the EPAP ranges from 6 to 25. So care should be taken that when IPAP and EPAP is set, there should be at least a minimum of 4 centimeters of water difference between the IPAP and EPAP. This system comes with the intelligent breath backup rate, where the machine automatically detects the patient's respiratory rate and sets up a backup rate. And there's an option for manual backup rate. Manual backup rate is generally selected based on the patient's respiratory rate -3 or 4. There's an option for TI max and TI min. This particular setting comes in use when you're having a patient of COPD where you want to increase the inspiratory to expiratory ratio. There's an option for rise time, and the default is set at 150 milliseconds. So rise time basically denotes the time it takes for the machine to deliver a pressure in each subsequent breath. Ramp is the setting where when the patient starts using the machine, the amount of time it takes for the machine to deliver this adjusted pressure. There's an option for cycle and trigger, and the sensitivity is based at very low, low, medium, high and very high. And based on patient's comfort, the sensitivity of cycle and trigger can be adjusted. And in the mask setting, there is a setting for pillows, full face mask, nasal and pediatric mask. It is important to choose the right kind of mask for the patient, which helps the machine to identify the dead space. There is a set of options which are available under the comfort, where ramp time is set. Ramp time can be switched off if required. And there is an option called ramp down. Ramp down is selected when a patient requires high pressure, and when the machine is switched off abruptly, the patient might develop some discomfort. So in order to correct that, so when the patient presses the switch off button, the machine starts to slowly reduce the pressures until the least pressure is attained. Once the ramp down is selected, it also gives you a start EPAP option where it starts at a default 4. Climate control is for the tubing, and the tube temperature is also displayed. Other accessories such as the antibiotic filter, the external humidifier options can be adjusted. And that's about setting.
Hello everyone, I am Dr. Tanuja from Department of Pulmonology, AIG Hospitals. Today I am going to tell you about the device settings of BPAP S mode. The BPAP device has 3 modes: S mode, T mode and ST mode. Now I am going to tell you about S mode. S mode is best used for spontaneously breathing patients whose breathing efforts are good, but one has to be cautious of apneas. To choose S mode, go into settings, mode, select S mode. After selecting S mode, you will get these following variables: IPAP and EPAP. The range for IPAP is 4 to 25 and the range for EPAP is 4 to 14. We have to keep those settings according to the patient's requirements. The rest of the settings, TI max, TI minimum, rise time, trigger, cycle, mask, comfort are similar to that as explained in ST mode.
Hi, I am Dr. Srivani from Department of Pulmonary Medicine in AIG. So today now I am going to tell about how to set the parameters for IVAPs in this Lumia 150 machine. So after connecting the power cord, it will be displaying like this attention and also we have to click OK. Then we have to press these 2 buttons. So here it will show like the settings. So in settings we have to go to mode. So we'll be having a number of modes over here: CPAP, SST, T, IVAPs, PAC. So in this, as now I am going to tell about IVAPs, we have to click over here. Then in this, first it will be asking us regarding the height of the patient. So in order to calculate the ideal body weight. So normal body height I'll be considering it as 160 centimeters here, and the target patient respiratory rate. This usually we have to set the patient's own respiratory rate. Suppose if the patient is having 15 or 16, suppose 15 respiratory rate, that I'll be setting here. It is not the backup respiratory rate, it is the actual patient's respiratory rate we have to set over here. So, and after this, we have to set the target alveolar volume also. So this depends completely upon the ideal body weight of the patient. So for suppose for 160 centimeters of the height, usually the patient tidal volume according to the ideal body weight will be around around 400. So we have to adjust this alveolar volume until we reach a tidal volume of around 400 ml. So just look over here, I am rotating the knob over here so that we reach around 400 ml of tidal volume, that is according to the ideal body weight. So at that point of time the target alveolar volume is around 4.6, so we have to set that as the target alveolar volume. After that we have options like auto PEEP or auto EPAP or EPAP. So here I will be showing you the manual EPAP kind of thing. So the minimum EPAP will set as 4 and we can adjust according to the patient needs, this one. So if we set this EPAP minimum as 4, the minimum pressure support will be around 4, because the pressure difference, the pressure support is actually the difference between IPAP and EPAP. So if the EPAP is 4, IPAP should be around 8, because the difference should be around 4 and the minimum pressure support will be around 4 then. So the maximum pressure support, it also depends upon the patient conditions. Like if in case of any obstructive airway disease, the maximum pressure support will be little less, and if it is like for any neuromuscular disorders and all, the maximum pressure support should be more. So usually what we set is around, the minimum pressure support should be around 4 and maximum should be around 8. And the T inspiratory maximum and minimum values, these completely depend upon the I/E ratios. So for suppose if in COPD patients or in obstructive airway diseases, that I/E ratio should be, usually what we set is around 1:2. So for that, the T inspiratory maximum will be around 1.4 if you calculate, and the T inspiratory minimum value should be around like 0.3. Yeah, these are the basic, all the basic settings for this IVAPS mode, and these are the manual settings. Apart from that, we also have the learn targets. In this, if we press this button, so the machine itself, after connecting this, pressing this button, if we connect the mask to the patient, so the machine itself detects whatever the parameters required for the patient, and this mask needs to be connected for about 10-15 minutes. After that, the machine will be giving the readings, and in that, if it is acceptable range, then we have to select here accept. Here it will display like accept or reject. There we have to select whatever we want. So this is all about IVAPS.
Hello everyone, I am Dr. Divyashree from the Department of Pulmonary Medicine, AIG. So today I am going to explain about auto CPAP device. After connecting the adapter to the power button, there is this green light, and you have this home button and the dial button. Now press OK and you will have My Options in Sleep Report. My Options takes you to the clinical settings. So to go to the My Options clinical settings, press simultaneously on the home button and the dial button. You will get the settings. Go to the settings and then you have the mode. It is auto set mode, auto CPAP mode. And then you have the maximum pressure, which is 20, and minimum pressure will be 4 for the device, and the settings will vary according to the patient's pressure. Next, mask. You have pillows, full face mask as well as nasal mask. Then comfort. Response is standard, and there is ramp time, which is off, and the EPR, expirated pressure relief. It allows the patient to sleep comfortably at lower pressure rates. And then the EPR type and the EPR level. EPR level is 2 here. And then humidity level. Normal humidity level is between 2 to 4. And if the dryness of the mouth of the patient increases, you can increase the humidity level. Thank you.
Hi everyone, I am Dr. Surgeries, first year DNB.
Yeah. So we have seen the demonstration of different devices actually. I know it will be difficult to capture in immediately, but I think This will be uploaded into YouTube videos, and probably whoever has some doubts regarding the machines and other things, setting how to set them, can go through the videos once again. And all these devices are also displayed outside in the table actually. So you can have a view of all the different kinds of machines, masks, and how to apply the straps. And in addition to this, we have mandibular advancement devices which are demonstrated outside on the table. This is from our orthomaxillofacial surgery team actually. They are demonstrating the mandibular advancement devices as well actually. So we can, I think we can move out together and then see all the demonstration. So here we end this session, and I thank one and all for being here today from morning till evening actually. I thank all the excellent faculty, delegates who have made this really wonderful experience for us at AIG, and the interactions were very great. I thank our AV support team for helping us with excellent coordination. Yes. Okay. And also I thank ResMed team, Sun and also Lupin for pitching in and also helping us with some logistics. I think there are many people who have been involved in this, especially our team members, actually consultants and our residents. We have seen some beautiful videos from all our team members actually. Roshan is here, Tanuja, Dr. Vinay, and all of our team members have excellently worked hard to make this event and a successful experience for us as well as for all the delegates who have participated here. And may I request you all to stand up for the national anthem, please.
जनगण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जनगण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
Thank you everyone.